slides.
So we'll be starting in 5 minutes, okay? Till that time, let me give some backdrop. May I have an introduction from the delegates? Can you please give them mics? So let me put some background. Consider this as a very open forum. You can stop any one of us, ask whatever questions you feel like. The faculty over here is inclined more to make this journey easier, whatever the questions and difficulties are. Yes.
Good morning, sir. Sir, myself, Dr. Karthik Soni from Raipur Institute of Medical Science.
Okay.
Morning, sir. I'm Dr. Saikat Roy Chaudhary from Raipur Institute of Medical Science, GR2.
Welcome, Saikat and Karthik. Yes.
Myself, Dr. Vilas Rathod from RNH Hospital.
Acha. You are Dr. Mukesh fellow. Okay, nice. Welcome.
Hello sir, I'm Dr. Anmol Mittal from Bombay.
Fantastic. Nice, nice, nice. So we had a long discussion, Amolya. Hi.
Hello, sir. Dr. Shripal Doshi from RNH Hospital.
Fantastic. Okay, welcome, Shripal.
So
Yes.
Shripal, basically you are from which place?
Rajkot. Yeah. Knowing where exactly you are from and
Yes, sir.
what
I'm from
brings you.
Rajkot, Gujarat.
Yeah, fantastic. Welcome, Shripal.
Good morning, sir. Myself, Dr. Alex from Kerala.
Okay, welcome, Alex. So we have, as you see, we have got a very multifaceted delegates also and multifaceted faculty also. So let me take time to introduce Dr. Sarthak. Dr. Sarthak Patnaik is from Bhubaneswar. He's a very renowned arthroscopy surgeon from Bhubaneswar, and he is presently lead mentor and specialist surgeon consultant for hockey team, senior hockey team also. And he has helped athletes with the likes of right from elite javelin throwers, hockey players, known IPL cricketers. So, and we have Dr. Samir Dvidmute sir. He is head of the department AIMS Nagpur. Okay. We have Dr. Jagtap sir, Satyajit Jagtap. He is the pioneer of arthroscopy surgery in Nagpur. He started basically the journey over here, and he is our chief mentor and our guide in this endeavor. So the background, as I already mentioned in this course, is that we are initiating. We want to connect with the beginner's mind to the beginners who are starting their journey in arthroscopy. This scope, the fruition of this scope was we face day-to-day activities or day-to-day difficulties. The first and foremost is that, अरे यार ये होता कैसे है? मतलब how to start with, how to procure equipment, what exactly the equipment should be, how triangulation. These are the small difficulties we at the initial of arthroscopy which we face off, and then slowly and steadily we stumble our way. We stumble our way through, but we want to make this journey easier for our next generation. Unless and until we do that, we will keep on repeating the mistakes. I mean, you will keep on repeating our mistakes. So this was the basic idea. In due course of time, I will, I hope, or rather I will know that if you stick or rather come up with a beginner's mind and with an empty cup without any preconceptions, you will definitely take valuable insights from this. We have arranged for a fantastic triangulation workshop. You will know how to make your own triangulation stations without using any kind of expensive equipment. I'll make sure that you understand you can use regular equipment to make your own triangulation stations. At the same time, we have arranged for a very high-tech precision augmented reality station, which you need and practice as much as you can today. Learn and triangulate and practice as much amount of triangulation today. Then we have got fantastic sawbone stations with all the graft and the equipment which you need, practice passage of the graft, meniscal stations. And tomorrow, when we go to the cadaveric stations, the modules are designed in a way that the instructors are just going to observe you executing those modules. Not that we will be telling you, okay, this will be a hand-holding session. Unless until you ask for, okay, sir, help me do this, we are not going to be there, okay? Just like AO courses, got it? So I hope you enjoy this journey with us. So Dr. Pradeep will be live with us now, okay? Chalo.
So Dr. Pradeep sir is still in transit. I'll kindly request Samir Dwidmute sir to please start with the presentation.
Session 1 मध्ये टाकलं असेल. Yeah, first one. Good morning, and at the outset I would like to thank you Dr. Aashay and his team at DMMC for arranging this program, inviting me and giving this opportunity to speak on this topic on arthroscopy. So I think we have some freshers from, how many of you are doing arthroscopy? कोई करता है? नहीं. अच्छा, have you witnessed some arthroscopic procedure going on? Okay. Have you scrubbed in some arthroscopic surgery? Yes, that's okay. Okay, that's good. So you will find this topic quite interesting also. So we are going to see what is arthroscopy. Briefly, we are going to see the history of arthroscopy, how it started and how it's evolved over a period of time. And briefly, we'll also see the different equipment which are essential for starting a arthroscopy. Okay. So initially, it all started in the Greeks, where the Greek word is the orthos means joint, and scope means we are going to look within the joint. Okay. So initially, the laparoscopic and the cystoscope were initially surgery started with that, and orthopedic surgeons in where tried to do the joint examination through the cystoscope, but they were quite bulky, so it was not possible to see. So gradually over a period of time, so this is Professor Kenji Takai, who was the first person who described examination of a knee joint. So at that time, the instruments were that much were not that refined. So he was just these are the specific instrument which were he was using. And if you can see, most of the design which is there, it is still persistent. Refinements has been done in the optical system and the camera system, but the equipment design is almost similar. So he was the first person who started the arthroscopy, and one of his student, Professor Masaki, he continued with the different designs of the arthroscopic surgery, and he designed the 21st arthroscope in around 1967, where his the diagnostic arthroscopy started. So initially, we used to start, he has described these different phases of arthroscopic surgeries. So during the 1920 and 59, designs were there, but the arthroscopic and the visual system were not that accurate. 1960 and 69, with the invent of the arthroscope proper designing, the number of surgeries increased. So initially, there were camera system were not available. So you need to have direct vision So there was a chance for contamination also, and the assistant which was there is not able to see what the surgeon is saying. Then with the development in the 1967, he described the 21st number orthoscope. So it was the first commercially available orthoscope which they started doing the surgery. And the fourth stage started after 1979, where the advancement in the system of video camera, light source, and all these things will lead to increase in the number of indication, as well as the other joints were also explored for the diagnostic arthroscopy. So these were the initial days. Then we started the 21st orthoscope. Then these are the initials, the development of the different lens system. Then these were the initial cameras which were used. Okay, you can see how bulky it is. Now this is the current model setup which is there at every place. And now we are moving on to the wireless system. So where there is no light source is attached, the light source, camera, everything is inbuilt, and the image is transferred to a wireless system. So we are moving towards that now. So coming back to the basic orthoscopy trolley, which everyone should have, one should have an orthoscope, a light source and cable, camera system, monitor, orthoscopic instrument, motorized shaver, radiofrequency cautery, fluid management system, and a tourniquet. Okay, so one by one we will go into detail of everyone. So orthoscope, it is the basic instrument which is used to see within the joint. Most commonly used orthoscope is the 4 mm 30-degree orthoscope. So what do you mean by 30 degree is that it means there is an angle of inclination of the lens at the end of the scope. So it is looking 30 degree down. So whenever you are seeing through the scope, you are seeing 30 degree down. So you are not seeing straight away. If you are using a 0 degree scope, then you are looking forward. So to have a better vision, the orthoscopes are designed such that you can see 30 degree down. And there are other orthoscopes are also available like 70 degree and 90 degree. Usually the length is between 8 centimeter to 15 centimeter. So for the knee, you have a larger or the 4 mm 30 degree with the 150 centimeter length. For ankle, you will have a shorter orthoscope, ankle or a wrist. Then with this, if the scope is smaller, the field of vision will be smaller. If the scope is larger, that is the 4 mm, the field of vision would be more. Also, with the help of a 30 degree orthoscope, you have a field of around 115 degree. The advantage with the 130 orthoscope is that if you rotate it, you will have a better vision and there is no blind spot. Whereas with the help of a 70 degree orthoscope, you have a wider view, but there is a blind spot. If you can see here, there is a blind spot. So anything in this particular region will be missed. So there are specific indication for using a 70 degree orthoscope, but most commonly almost 90% of the time or the 99% of the time we will be using a 4 mm 30 degree orthoscope. And the indications where the 70 degree orthoscope can be handy if you are going for a PCA reconstruction, if you are removing some loose bodies, if you want to look down without taking the posteromedial portal. So in that case, this particular orthoscope is useful. Also, if you are trying to do a subscapularis repair, then this particular orthoscope is useful. Then orthoscopic sheath, there are various types of sheaths which are available, but you should go for a high flow sheath. High flow sheath, if you have a high flow sheath, the joint distension would be better. You will be able to better visualize the joint, and there won't be any use for need for a orthoscopic pump, mostly for the knee or the shoulder orthoscopy, if you are using a high flow sheath. If the fluid is not coming, the distension is not proper, then the visualization is going to be poor. Then light source. So initially a light, normal filament light were used for illumination. So there were the instances where the patient used to get shocked during the surgery. But now with the refinement of the halogen light, then the halogen light was heat creating, then there was xenon light. Now we have the LED lights, which are cold light, more whiter, and which will give a better vision. You need to specifically take care of the the light source cable. You should not bend it acutely, because there are chances that it may result into damage to the filament, resulting into decreased illumination. Camera system, yes, it is essential. And for the beginners, I would suggest that go for a good camera system and good orthoscope. You should not compromise on the camera system, because if the vision is not good, the ultimate result is not going to be good. And many times it happens that we start with a substandard instrument, and then it becomes very difficult to learn new things as well as do whatever you are doing perfectly. So if your vision is good, you will be able to execute the surgery in a better way. So we have now the HD and the 4K system. Even a HD system is okay, but it should be complemented with a good high definition monitor. Orientation of the camera, how to orient the camera, that we are going to see into the cadaveric session. Because if you are inserting a joint, you should align your camera in such a way that you are seeing, you should be visualizing the joint as it is. So you should be at the level of the joint. It should not be, अगर कैमरा टेढ़ा हो जाता है तो फिर ऐसे करके देखना पड़ता है. Okay, so there are multiple, this vision will change depending upon the how you are positioning your camera and the light source. So different permutation and combination are possible if you try to move the camera as well as the light source. So what you can do, you can fix the camera, keep it parallel to the joint line, and then you can move the light source. So if you move the right source, you will be able to see the different part of the knee joint without much moving the multiple movements. So this trick will come with the practice, but initially try to do fix your camera at one particular place, move your scope to visualize the different directions. Then video recording system is good. Maybe initially you can go for a cost-effective equipment, but later on you can move on to the advanced recording system, which is good for making the videos, also for giving to the patient, because many a time the insurance companies will ask for the videos. Then probe, arthroscopy probe, it is called the extension of the arthroscopist's finger, because it is used to palpate the different structures which are there within the joint. You can use it to retract your structure if they are coming in your way. It is able to move if there is a loose body, you can move it with the help of a scope. Also, the size of the scope is, the hook probe is fixed. So you can also calculate if there is any articular defect is there. You can calculate with the help of the curve end of the probe. So there are different uses of the probe. The triangulation techniques, yes, we are going to have a different lecture on this, where you are able to, triangulation means the scope is in one hand and the instrument in the other hand, and you have to bring it into the vision of the camera, and you should be able to execute the different maneuvers. Motorized shaving system, these are also one of the essential component. So there are different type of blades and burrs which are available. So mostly whenever you are using it, you use it in oscillating mode with a suction on the mid portion. If you are sucking more, then it will result into all the loss of fluid, joint distension, and loss of, the vision will be compromised. Orthoscopic scissors, they are available in the market, but most of the time they are not recommended, because there have been instances where they are resulting into breakage of the instrument. So they are no more recommended now. Basket forceps, yes, these are also one of the essential instruments one should have, mainly used for removing the meniscus, damaged meniscus. Also, if the remnant of ACL is there, it can be used to remove that. And always don't forget to give a lavage, because whatever the particles which you cut with the help of basket forceps will be dropped into the joint. So always use a shaver after that to suck out whatever the fragments if they are lying into the joint. Grasping forceps, these are also one of the essential thing to remove the loose bodies or the part of the meniscus. You grab the meniscus. Also, it is useful in the shoulder surgeries. Then cautery system, we have the RF system and the cautery systems also. So this Arthrex has a very good cool cut cautery. So it is basically, they say it's a single use, but you can use it for multiple surgery, and it's very useful when you are doing a bankart repair, even for a ACL surgery. So no need to go for a RF, which are very costly. And even the wands you cannot use for multiple times. But this cautery is good. They are available with the other companies also. So they are also cheap, and it is able to achieve a hemostasis whenever it's required. Irrigation system is important to have a proper joint distension. But with the invent of the high flow system, there is a very minimal need, hardly anyone using pump for knee arthroscopy procedure. Even for the bankart repair, many of us are not using the pump system. But maybe for the rotator cuff, you can use it. So another trick in this that you can use your TUR set and attach a BP cuff to that, and you can put it directly into your 3-liter saline. So with which you will be able to create a increased pressure within and improve the joint distension. Especially it is very useful whenever the knees flex. If you are doing a transportal femoral tunnel, you need a joint distension. In that time, this may be handy. And also increasing the height of the saline system will also improve the distension of the joint. So these are the basic instruments which are essential for starting any diagnostic knee arthroscopy procedure. But depending upon the diagnostic arthroscopy is also termed very misleading. As such, there is no diagnostic arthroscopy. Most of the time, we will be doing performing some kind of surgery, either synostomy, either meniscectomy, or ACL, whatever it is. So it will be, you will need to have some other instrument also, surgery specific instrument. So if you are going for ACL, you will have to have a ACL set, then meniscus report cannula, and the shoulder surgery specific instrument will be required. Most of the time, the implant person would be providing it, but it is a better idea if you have your own instruments. So proper positioning of this implant is also essential. The screen should be easily visible. Usually the preferred location of the irrigation should be on the same side of the patient. You can keep it in the axilla. All these instruments are very delicate. So we need to have take proper care of this instrument, otherwise it may result into a lot of damage to the instrument. I know of a person who has who got damages orthoscope 4 times in a single year. So you can imagine the cost which is involved into that. So taking care of your instruments is very important. So there should be some dedicated person who will be taking care of their hand instrument as well as the optical instrument. Various enzymatic and ultrasonic cleaners which are available. The enzymatic cleaning solution are easily available. You can use it, and that will be very useful for preventing the infection. As such, in rate of infection in cases of orthoscopic surgery is very less, but yes, they are been reported, and the persons who are practicing multiple surgeries in a day, they must have experienced a high incidence of infection. So you should take all precautions to avoid infection, and the cleaning of the solution, proper interval, proper cleaning of the instrument between the 2 surgeries is also important. The preferred technique for the metal instrument, you can send it for autoclave. Even the camera head and the orthoscope are autoclavable, but I don't think any of us are sending the cameras for autoclaving. So most preferred tech, if you have a facility for ETO or plasma, you can use it. If you are doing multiple surgeries in a single day, then you can soak the instrument in the Sidec solution. But that solution, Sidec solution, should be freshly prepared. Otherwise, there is always a chance for contamination. Even the Jagtap sir has taken the initiative with the help of the Arthroscopy Association of Arthroscopy Society of Nagpur, that the society has brought a ETO machine at one center, and all the members of the ASN can take this benefit and keep their send their instrument for ETO sterilization. So it has helped immensely in the many surgeons. So take home messages: you should know the essential equipment which is required for the orthoscopic procedure. Buy good quality equipment to have a clear vision during the surgery. It also makes your life easy during the learning phase. And orthoscopic instruments are delicate and costly. Take care of instruments for a longer lifespan. Thank you.
Thank you, Dr. Samir, for the wonderful presentation. So now that we have started off with our session, I would like to take this opportunity to make a formal introduction. I, Dr. Tejas Ashutosh Apte, on behalf of the entire organizing committee, would like to extend a warm welcome to you all to the Knee Arthroscopic Workshop 2023, which has been organized by the DATTA MEGHE Institute of Health, Higher Education and Research in association with the Vidarbha Orthopaedic Society, the Arthroscopy Society of Nagpur, SELSC and OrthoTV. As Dr. Aashay gave a beautiful summary of our workshop, this is aimed at acquiring knowledge and skills in the basics of knee arthroscopy and comprises of a whole day of interesting lectures, demos, sessions along with sawbone workshops, followed by an exciting cadaveric hands-on session which is scheduled for tomorrow, so that everyone gets an opportunity to apply all the knowledge learned into practice. We have an eminent faculty with us from Nagpur as well as Central India and all across the nation, who are highly experienced and skilled arthroscopic surgeons who have come all the way to help us and guide us along this journey. So I would like to thank all the faculty members for sparing their valuable time and gracing us with their presence. So I would like to request all the delegates to brace themselves for a joyride filled with information, knowledge, and practical exercises, as well as some life lessons and career lessons on the way. I would also like to take this opportunity to congratulate you all on taking the first step and embarking on this journey of knee arthroscopy. Hopefully after today, once we gain the necessary knowledge, we'll be able to peep in the knee joint and spy on the things and repair them if required, as and when required, instead of tearing up the whole building every time, like plastic surgeons. I'm guilty of being one. So moving on, after the wonderful lecture by Dr. Samir regarding the basics of the equipment, trolley setup, and the sterilization techniques, we also need to realize that we need to know the basics, as in we need to identify the patients who require an arthroscopy, for which a good clinical examination of the knee and a diagnosis in the form of good imaging techniques is highly essential. So the next two lectures will be focused on knee examination and investigation techniques related to soft tissue knee injuries and diagnosing knee pathologies. First of all, the knee examination lecture is scheduled to be taken by Dr. Pradeep Nimade, who will be joining us online. I think he's still on his way from some other commitment. So what we'll do is we'll carry on with our next lecture, in which we'll understand how to read an MRI of the knee joint and how to diagnose common soft tissue knee pathologies and injuries. For this, I would like to invite on stage Dr. Anand Hadgaonkar, who is an eminent radiologist from Nagpur and the head of the department at Shalinita MEGHE Hospital and Research Institute. Please welcome, sir.
धन्यवाद. सर्वप्रथम आयोजकांचे आभार की त्यांनी आम्हाला 2-4 शब्द बोलण्याची संधी दिली. 2-4 शब्द. Actually, knee joint, I will try to keep it to 2 and 4 only. How? You will know now. So let's start with this interesting topic. Knee joint actually is a really simple joint. It is hinge type of joint, all of you know. Moments, common moments are flexion and extension. So hinge, it is moving in only one plane. It is synovial type of joint. And how many bones are there? You can see almost 4 bones. So 2, 4. 4 bones are femur, tibia, fibula, and that hidden chin, which is seen on the lateral view, is patella. And it is forming 2 joints, patellofemoral joints and knee joint proper, which is nothing but a tibiofemoral joint. Then again moving to MRI, again acquisition, we are taking 4 planes. So what are these 4 planes? Normal planes, you all know, that is sagittal, coronal and axial or transverse. These are done in all these all planes are done in almost every MRI. But here in knee joint, we are taking one special sequence, and that is sagittal oblique. Sagittal oblique is basically we are taking these sequences in the line with ACL. So ACL can be seen from origin to insertion. Footprints are really important to look for the insertion site and origin site of the ACL or any ligament as such. So here are 4 different planes where we are acquiring images. And if you look at the sequences, again 4 basic sequences are there. So we are having fast Pinico T1, fast Pinico T2, then we are having PD, that is proton density images, and we are having GRE or the gradient images, basically to look for calcium and hemorrhage. So all these sequences, although radiologist life is not only black and white, it is also having grayscale. But in this case, if you look at almost all ligaments, whatever you are coming across, they will appear black on all sequences, unless and until some hydration or the water is there or some fat is there. So likewise, some degeneration or normal. Otherwise, if you are coming across a bright is a red signal on any sequence, which is actually pointing towards the pathology. We sometimes take fat suppress. PD fat suppress is a routine thing, but if at all we are going ahead with contrast, we will take T1 fat suppress sequences post contrast. MR orthogram, again two type of orthograms are possible on MRI. One is direct, it is a minimally invasive technique, and we are directly instilling contrast in the joint. Another one is indirect technique, where we are giving it IV, asking patient to exercise, and that way, that contrast is getting accumulated in the joint over the period. I am not going in detail about all these technique and sequences. We will directly move to MR anatomy. MR anatomy, again simplified it, just 4 different quadrants or 4 different parts. Most important from the even arthroscopic point of view is intercondylar notch, where there are only 2 ligaments, ACL and PCL. Then medial quadrant, a lateral part or the lateral quadrant, then patellofemoral joint. These are all 4 parts, what one should remember. So knee joint is that simple. One by one, we will just go through anatomy. Before that, one coronal view, just to show you different parts. As one can see here, is the intercondylar part, where you can see 2 ligaments are there, that is ACL and PCL. Looking here, fibula, this one is the lateral part. On lateral part, most important things, what you are seeing is 2 muscles are there. One is biceps femoris, which is on posterior aspect, and another one is deeply situated popliteus muscle. Then 2 ligamentous or the fibrous sort of tissue is there. One is lateral collateral ligament, and not to forget about the anterior part, that is the iliotibial tract. So just keep it simple. Other things are also there, but most of the things are in 2 and 4. So 4 things are here. Looking at the medial aspect is a little bit complicated, but you will remember them if at all you know what pes anserine. You know about pes anserine muscles. How many are they? 3 or 4? Some says 3, some says 4. But basically what we will remember, these are 3. So 3 pes anserine muscles or tendons, what we are seeing here, and these are sartorius, gracilis, and semitendinosus. So usually the gyropes consists of the 4 muscles. So where exactly is the semimembranosus? So semimembranosus is getting inserted on the posterior medial aspect of the tibia here. Then 2 ligaments, or we can say ligament complex. So this one is medial collateral ligament complex. This one is tibial ligament. Actually, tibial ligament is a thin part which is connecting the meniscofemoral and meniscotibial part. So it is not always seen on MRI. Moving to the next part, that is the most important, is the intercondylar notch. So intercondylar notch, it contains 2 important ligaments. I said everything is black. If it is white, it is a sign of some abnormality. So see here, this one is the anterior cruciate ligament. As the name is, anterior cruciate ligament. It is arising from the anterior part of the intertibial notch. It is coursing in the cross-like manner and getting inserted on L, that is the lateral condyle of the femur. So ACL is easy to remember, it is ACL. PCM is again similar thing, it is arising from the posterior part of the tibial intercondylar notch. It is crossing ACL, or it is coursing in a cross-like manner and getting inserted on the medial condyle of the femur. So such a simple thing is ACL and PCLR. Let's go through these few video images, which makes it really easy to understand or to see ACL, although this is not sagittal oblique view. If sagittal oblique, you can see ACL through and through. So this one is PCL. What one can see here is the PCL. Here is the PCL. And ACL is just starting here. This one is the anterior attachment of the ACL. And here one can see ACL. So this is sagittal oblique view, which is in the direction of ACLs. So look at ACL. ACL is having two important parts. One is anteromedial part, which is dark, and posterolateral part, which is little bit brighter. I say ACL is a ligament which is holding some fat, which is holding some fluid. So fat and fluid both are bright. So that may add to some impurity in ACL, but it will not always be causing tear, or it should not be taken as a tear. So some sort of brightness is always there, which is on posterolateral aspect. But if at all it is approaching anterior part, then it is abnormal. Looking at PCL, PCL is total black. We have seen PCL. So if you look at the PCL, PCL is totally black. As one can see here. So this one is PCL. So PCL arising from the posterior part of the intercondyle notch of tibia, coursing like this and getting inserted here. Again moving to ACL, look for the orientation of ACL. ACL is oriented parallel, little bit slanting anteriorly, and that too parallel to what? It is intercondylar notch of femur. So if this orientation is disturbed, there are high chances that there can be a tear. If any brightness is there are high chances that there can be tear. Most important part is footprint. So again one has to look for femoral attachment. Most commonly it gets damaged there. Mechanism I am not going in detail, but here again PCL and ACL. But seeing it in sagittal sections is really satisfying. However, one must compare it with coronal and the axial view. So in coronal view, how it appears? Let's see. Here is the coronal view showing the same. So I will just hold it. Here is actually a footprint of, or the insertion site of ACL, which is on the lateral condyle. And as one can see here, rest of the ACL can be seen if we go anteriorly. So here we are going anteriorly. This one is posterior part. Come on. Here we are going anteriorly. So this is the origin. Here is the intercondylar notch where the origin is, and here is the insertion. Similarly, one can follow PCL. Here we are following insertion of PCL. So it is posterior. It is two-way images I have taken. They should run like so. Here is the tibial attachment, what we are seeing right now. Here is the tibial attachment on posterior aspect. Here are the axial sections. In axial section also one can confirm those findings. So easiest way to look for ACL and PCL is to go ahead with sagittal oblique or the sag view, and you can just confirm it. To look for the footprint, best I think image is either coronal or go ahead with this image actually. Here what one can see in this particular image, here also you can see footprint better, insertions. So ACL and PCL, these are most important. ACL, PCL is dark only. ACL is having some impurity, some bright part, and one should be aware of all the pathologies. That is quite easy to make out. So let's just go through the medial knee joint space now. We have already discussed. So it is having pes sensorin tendons. Pes sensorin tendons are 3 in number. These are sartorius, gracilis, and semitendinosus. Let's go through, and we are having medial collateral ligament complex and tibial collateral ligament. These are the images. Simply we will go through. This is the medial part. In medial part, the posteriormost part, where we can see gracilis muscle, Semimembranous, although here they are not getting inserted into pes anserin bursa, which is inferior to the insertion of semimembranosus, which is on the posteromedial aspect of the tibia. Here is the semitendinosus. So let's go through all these images. Yes, I will stop here. So again, see here, sartorius. We are having all these images on medial aspect, pes anserin bursa. Now started. Here, one by one we will go ahead with. So here came the medial collateral ligament. So medial collateral ligament closely and deep to medial collateral ligament is the tibial ligament. Tibial ligament we cannot differentiate from medial collateral ligament, so we are just considering it as the medial collateral ligament complex. Even few people consider, just a minute. This is very sensitive keypad. I don't have a mouse. I am trying to move it, and every time it may that. So you have a pointer? Yeah, I have a pointer, but trouble is actually I want to move those images and I want to show the pathology as well. It's okay. So here, concentrate on the medial aspect, my side of the screen. So we have cross pes anserin. Here is the medial collateral ligament and medial meniscus. So if at all we will look at lateral aspect now, again similar, hardly we have. If anterior to posterior we are going, we will see iliotibial tract first. Later on, we will see biceps muscle, which are actually two important tendons or biceps tendon on the lateral aspect. So let's go through. Here concentrate on lateral aspect. So should I stop here? So this one is biceps femoris tendon, which is getting inserted in the fibula. And what is seen here, which is actually medial to the lateral collateral ligament or the fibular collateral ligament, is a popliteus tendon. So popliteus tendon is medial to it. Again, it started on its own. Anteriorly, what one can see is iliotibial tract. So anatomy is real simple. So AI is actually coming in radiology very soon. It started working here automatically. Even without touching, everything is coming like that only. Anyway, it's great. So here is another video showing the same without any labels. I will try to show you here, starting from the anterior part. We have cross iliotibial tract. This one is fibular collateral ligament. That thick part was the fibular collateral ligament. Tibial. Here is the tibial and the medial. Come on. Usually multiple videos are there, it gets hang for a period. So even after your command, it will take some time. That is quite common in medical colleges where students also respond in the same way. They are get hanged and they will respond after some time. So from lateral knee, I am moving on to the next. That is anterior compartment. That is a patellofemoral joint or patellofemoral articulation. Again, images are there. It's really simple. We are having patella. On the either side, condensed fascia, that's patella retinaculum. Posteriorly, three bursae, infrapatellar, suprapatellar, prepatellar bursae, what one can see. This one is patella with medial and lateral articular facets. Then we are having, this one is femoral sulcus or the trochlear groove where patella is fitting into. So that anterior patellofemoral articulation part is really simple to understand. Pay attention to the articular cartilage, what is seen here. all of ligaments I said they are black because they are fibrocartilage. But if you look at articular cartilage, that is a hyaline type of cartilage. So its appearance will be different. So all these fibrocartilages, because of major fibrous content, they will be black. But if you look at this hyaline cartilage, it will be little bright on T2. But a little brightness one has to make out, we may have to go ahead with some different sequences, or one may go ahead with the GRE images which are already there with you. So GRE images show pathologies of the ligaments and menisci better. However, I am more comfortable with head side PD images. So in lateral view, again really simple, what we have is patella here, patellar ligament and quadriceps tendon. Here look at the patellar articular surface and patellar cartilage. Position of the patella, then install solvity ratio, which can give you idea about patella alta and patella baja. All the students there, they can remember is alta is above and baja is below, what we used to teach them. Again, here is a menisci. So we are moving to the menisci. If you look at the medial meniscus, both horns are triangular and they are sharply angulated on the medial aspects. I told you, कि menisci, they may be little bright on T2 weighted images as compared to the T1. Moving to the next. Here, posterior horn is always larger than that of the anterior horn. If at all anterior horn is larger or of same size, suspect some tear there or maybe post-operative. So likewise, one has to properly take history. Never forget to look at the root. So posteriorly, root is actually in relation to the posterior cruciate ligament, and it is inserted here, just immediately anterior. If at all you can't see this particular image with a small root of medial meniscus which is inserted anterior to the PCL, suspect there might be a root tear. Then medial meniscus and lateral meniscus, they are entirely connected. So this one is the intermeniscal transverse ligament, what is seen frequently. Lateral meniscus, both horns are of equal height. Both horns are equal, but posterior horn is at higher level as compared to the anterior horn. ACL picture we had seen, this one is the normal appearance of ACL. And see here, this one, although this is T1 weighted images, one can see, we cannot make out ACL, which should have been here, obliquely oriented, almost parallel to that of the intercondylar notch of the femur. So AC is over, AC बंद है क्या? नहीं, मैं anxious हो गया मेरे को लग रहा है, sorry. So whenever pathology comes, I become anxious. So here is the pathology, my wife is pathologist, that's why I am little more anxious. I shouldn't miss anything otherwise. So one cannot see ACL here. So ACL, absent ACL, disruption of ACL, partly or completely, one can make out easily on different sequences. Here is the another sequence. Can you make out where exactly is the problem? It is in the mid substance. Usually football player or the athlete injury, it involves mid substance. So mid substance tear is there, but one can see intact fibers. Sometimes there may be formation of some granulation tissue, and this granulation tissue may mislead you and may tell you that this ligament is intact, however, it is disrupted. And it may come into your hand and you will find that radiologist had written it intact, but this one is disrupted. So that is a problem whenever there is a granulation tissue or fibrosis already settled in injured ligament. Mucoid degeneration. It is not uncommon to find mucoid degeneration. This typical appearance like that of ciliary stalk is actually indicative of mucoid degeneration. Sometimes mucoid degeneration, along with that, some cystic changes are there. So cystic changes are common in all, whether it is menisci or the ligament. This cyst formation or the ganglion cyst formation, actually telling you that duration is very long, and it may point towards the pathology. If cystic changes are there, pathology is always there. Tear is always there. PCL tear. Again, PCL tear, they are somewhat rare as compared to the ACL tear. I had come across most of the time avulsion rather than, so such a strong ligament is the PCL. But here PCL with altered signals and disruption of the fibers, which is pointing towards the tear. A meniscal injury, actually you people are more well versed with. Only I will talk about interstitial tears are there. Suppose horizontal tears are there and they are, let's see what are vertical tears. Here is the posterior root tear, as one can see here, is the vertical hyperintensity or the brightness which is seen at attachment, posterior attachment near attachment of the medial meniscus, medial cruciate ligament. Here is the posterior root tear of posterior medial meniscus. One can see here is a vertical tear or horizontal tear, two tears in the same ligament. So these are, this one is a complex tear. So tear, making out tear is really easy. One can see the black, that is the appearance of meniscus, and this brightness which is pointing towards pathology. ACL injuries, they may associate with the LCL or the MCL injury. So let's see here. Here is the lateral collateral ligament complex, and what one can see here, disruption of this fibular ligament, and some collection is also there along the ligament. At the same time, if you look carefully at insertion site of the ACL, which is seen in same picture, one can see here some changes as well. So ACL tear with that of LCL injury. Here is also again LCL injury. One can see a tortuous course of the lateral collateral ligament and little bulk at fibular attachment, and again is associated ACL injury or the ACL tear. Similar picture with MCL, as one can see here, MCL ligament hardly seen. Although if you look at lateral collateral ligament is little thicker as compared to the medial collateral ligament. But together complex, we can say the complex. Complex, actually I was telling you about the complex. Complex is the tibial ligament which is actually a part very closely attached to the capsule. Then we are having medial collateral ligament and sometimes Cooper fascia. So Cooper's fascia is there's actually fatty fascia which is coursing from above downwards. So this Cooper's fascia is a part of complex. And even some fat stranding lateral to the Cooper fascia also points towards MCL complex injury. Here is ACL tear. So ACL tear along with medial collateral ligament injury, and if associated with medial meniscus injury or the meniscal tear as well, so it is an unhappy tear. So unhappy triad of Odenum. Am I right? So medial meniscus, medial collateral ligament, and ACL. Thank you.
Thank you, sir.
Thanks a lot.
We will have a question and answer session after this, immediately once we finish.
ठीक है, बंद करना.
The next topic is
Thank you, sir, for the very informative lecture. I doubt anyone else could have explained diagnostic imaging of the knee in such a simple and comprehensive manner other than you. I would like to welcome all the faculty members and the delegates who joined us a bit late. Can we all welcome them with a huge round of applause, please? And I would also like to acknowledge the presence of senior and eminent members of our orthopedic community in our audience, Dr. Deshpande and Dr. Sandeep Srivastava. Thank you for sparing your valuable time and being with us. Thank you. Moving on, now we have Dr. Pradeep Nemade speaking about the examination of the knee joint. He'll be joining us online via Zoom. So can we have a huge round of applause for Dr. Pradeep Nemade as well, please? Thank you. So I guess Dr. Pradeep Nimade is still busy with the technicalities. Moving on, now that we've learned about the basic diagnostic imaging of the knee joint, and now that we've learned about the basic arthroscopic setup, we've known our equipments and we know how to sterilize them. Now the next step would be to start off with the knee arthroscopy, and I can't think of a better person to help us start off with knee arthroscopy than the national head of the Arthroscopic Society Women's Division. Please welcome Dr. Neha Godghate with a huge round of applause. Thank you.
Thank you, Tejas. So, good morning, everyone. I'm Dr. Neha Godghate from Nagpur. Today, I'll be speaking on starting up of knee arthroscopy. So, after our clinical examination is done, which Dr. Pradeep will be telling us soon, and a very nicely depicted lecture by Dr. Hadgaonkar about the imaging. Now we have a diagnosis and we know that this person or this patient needs arthroscopy. So how do we proceed with arthroscopy? So basically, basic indications of arthroscopy is diagnostic arthroscopy. If there is a meniscus injury, then meniscus suturing, which is the norm now that's saving the meniscus. Then ligament reconstructions like ACL or PCL reconstruction. Then MCL reconstruction, loose body removals. If there is synovitis, then synovial biopsy and total synovectomy. Then chondroplasty and microfractures are various indications for knee arthroscopy. So over the period of many years, that there have been many papers all worldwide. They have shown that the most common surgical procedure worldwide is knee arthroscopy. And in India, in last 10 years, in a decade, the ACL reconstruction surgeries have grown up very exponentially. So if your OR is the heart of your hospital or institute, then your instruments or armamentarium are the vessels of your body. So coming up to the armamentarium, the first thing on a scopy trolley is a monitor. This is a TV basically which shows what is going inside your joint. It is connected to the camera and the scope. So the next is camera and the light source. It is a camera head which is attached, and the light source which is attached to the scope. It will light up your the dark spaces of your joint. Then the shaver. Shaver is a very useful tool in all joint arthroscopy because whatever tissue comes which is giving hindrance inside the joint will be shaved off. If there is some pathology that should need to come off, it will be used. It will be useful to use a shaver there. Then this is a RF device, which is a radio frequency device, which is basically a cautery system of arthroscopy. And very important tool on your trolley is a stabilizer, because these all instruments are very voltage specific or very sensitive to voltage fluctuations. So stabilizer is the important one on your trolley. So now coming to your MEGHE trolley does have these instruments, a camera, arthroscope and a light cable together, which is sterilized, etio-sterilized or plasma sterilized. Then shaver and shaver blades, cannula and trocar like that, which is autoclaved, and a probe. So your armamentarium, scopy armamentarium basically uses these instruments. These are various punches. Sorry. So these are duckbill punches, curved punches. So these are duckbill punches, which are, these punches are devised in such a way that there is a hollow part inside, beneath the punch. And whenever we cut the tissue, that tissue gets dislodged itself in the joint. So you don't have to cut and take the instrument out, again put it, again cut and take the instrument out. This is very nicely designed instruments so that every time you cut the tissue, it goes inside your joint, and then you can, with the help of shaver, you can help of shaver and suction, you can just take those bits of tissues out. So this is a grasper. This is a cigar handle punch, which is a basically side cutting punch. It is again helpful in various difficult parts of your knee. This is a grasper. Grasper is basically, it is a non-traumatic holder which holds the tissue or maybe a loose body. When you are taking off the loose body from the joint, the grasper helps. It catches that loose body and you can directly take the loose body out. In cases of shoulder arthroscopy, you can hold your cuff and see the movement of the cuff with the help of grasper. There have been various papers. This has been a paper by Katrina, and they have shown that still the 5% of all pyogenic arthritis cases in adults are attributed to the knee arthroscopy. So the sterilization of instruments is very, very important. So instrument sterilization is done by either ETO or plasma sterilization. The instruments which are sterilized by ETO are your arthroscope, video camera, light source, light cable, and shaver blades. Shaver blades are basically disposable ones, mainly the shaver piece. These instruments, steel instruments, are very well sterilized by autoclaving. The various punches, trocar and cannula, grasper, which Dwidmute sir has already told in details. There are various disposables which are used in arthroscopy, like suction cannula, TURP set, cling drape, water impermeable drapes, and 3 liters of NS bottles. So now we see the attachment. This is a video camera. It has got quick coupling mechanism like that. And then we take the scope and we just open the quick coupling and insert the scope in that and just release the quick coupling. The scope is fixed to the camera. Then this is a light cable which is attached to your scope like that. It gives the scope illumination. Then we hold a white structure like a gauze piece in front of the scope, and then we hold this white button which is on the video camera for a longer time. Then it helps in white balancing. And then this is a trocar and cannula which is attached with the TURP set to NS bottles, 3 liters of NS bottles. So arthroscopy principles is basically angle of inclination. You should know the basic principles of arthroscopy. The angle of inclination is basically, it is the angle formed between the line which is parallel to the scope and another line which is perpendicular to the lens. So this is the angle. Now here we can see this is 30 degrees of arthroscope or 30 degrees of angle of inclination. And to know the orientation of arthroscope inside the joint, for beginners, we should know this very important principle that light source is exactly opposite to that of the lens. So if I rotate my light source exactly 180 degree, your lens will be facing up. So here we can see your lens is facing up, 30 degree up. So light source is basically a lighthouse outside the joint. So here you will know that, okay, my scope is facing on left side if my light source is on the right side. So there are scopes which is 0 degrees, commonly, no, not 0 degrees, 30 degrees and 70 degrees. Commonly used scope is 30 degree scope. Viewing angle or a field of vision, which is another principle which we should be knowing. 0 degree, if there is a direct lens, then field of vision will be limited. If it is a 30 degree scope, then if we rotate, as I showed in the last slide, if we rotate, the field of vision will be a larger, and there is at the center, there is a overlap of the field of vision. But in case of 70 degree scope, you must remember that field of vision will be much larger, but there will be a center which is a blind spot. So while using a 70 degree scope, we should be knowing that at the center there will be a blind spot. Then coming to triangulation technique, triangulation is a core competency needed for performing arthroscopy. So what is triangulation? It is basically seeing your instrument in front of the lighted camera. So this is your lighted camera which ends here at the end of the arrow, and your instrument which you have put from the other portal will be exactly in front of that lighted camera source, so that you will know that your instrument is in the field of vision. So this is a triangulation technique. So if logically speaking, if your portals are exactly opposite or far away from each other, then you will be able to see your instrument very nicely vis-a-vis. On this left side, if we see, your portal and your scope is exactly going parallel. So there are chances that you will feel difficult to see your instrument in front of your scope. So once you are well versed with your triangulation technique, then you can play anyways. So there are triangulation simulators which will be having a workshop soon. So these are simple simulators. In a box they put up some object, and from one portal you insert your scope, and from other you insert your instruments, and then you play with those instruments. Like it's like a video game where you need to know what where your hand is going. So with that you can learn your triangulation very well. Then there are anatomic simulators like Alex model, then knee model, where there is a proper anatomic simulator where you can insert your scope and then learn about the arthroscopy well. There are virtual simulators like that nowadays, where you can see on a TV and actually work on your instruments, and then you learn your simulation properly. This was a very nicely done paper by Rachel Frank, and Rachel Frank et al., and they studied that they divided the residents into two groups. One group was a training group which trained on a simulator, and the other group was non-trained group. And they conducted a cadaveric study before training and after training. This was a controlled trial group, and they showed that the ASSET score in training group was higher after the cadaveric course, and which was equal when the residents were not trained on simulators. So basically, the first step is triangulation technique learned on simulators. Then the next step is a cadaveric course, and then you can go ahead with your patients. So after learning this on simulators, the next step is cadaveric courses, which are nicely conducted all over the India, even all over the world. Tomorrow we'll be having a good cadaveric session. So after we learn about the arthroscopy, now we are working on actual patient. So the utmost important thing is to note down is confirmation of side. So this is the first step we need to, I cannot help but emphasize more on confirmation of the sign. And after which examination under anesthesia is performed, as it gives us the better picture as the muscle forces are nullified when the patient is under anesthesia. So we check for range of motion, mediolateral and anteroposterior stability or instability, then patella mobility, and etc. So as a surgeon, we always focus on surgery, but not giving attention to this first step of surgery has led to disastrous complications. So after spinal anesthesia, the patient's, the position is like that. After spinal anesthesia, patient's ipsilateral hip is on the shifted to the edge of the table. The foot should be at the end of the table, and the tourniquet is applied as high as possible. And we apply a transparent sticking like that at the edge of the distal part of the tourniquet, so that to avoid any seepage of your irrigating fluid or seepage of your scrubs beneath the tourniquet, which might lead to rashes later on. So And then the high thigh support is applied at the thigh end, and at a foot end, proper foot support is applied. The foot support is applied in such a way that the knee is in 90 degree of flexion. Then the surface marking are important. They are done as follows. First we mark the patella, then we mark the tibial tuberosity, and then the patella tendon. And then the joint line, the first we mark medial joint line and then lateral joint line. Note that the lateral joint line is slightly higher than the medial one. So this is the joint line we palpate. Then we mark the portals. The portals which are, first portal we mark is a viewing portal, which is an anterolateral portal. And then the working portal is anteromedial portal. And then accessory portals are superior medial and superior lateral portals. The central portal is seldom used, which is called as Gilchrist portal, like this. It is a transpatellar portal using, it is used in ACL avulsion fractures. Then making anterolateral portal, which is a first portal of the knee. Knee is being a superficial joint, it is easy to make the portals in the knee. So the thumb is palpating the soft spot. It is on the anterolateral side of the joint line. It is created by palpation of the soft spot, and it is generally 1 centimeter superior to the lateral joint line and lateral to the patella. So then after palpating that soft spot, the 11 number blade is taken and a stab incision through and through the joint line. Unlike your shoulder, where we incise only the skin part, in knee joint we go through and through till the capsule. The capsule is also incised. A 5 mm length incision is made for the anterolateral portal. Then after the incision, a cannula is inserted in a rotatory fashion. So once we feel that it has gone inside the capsule, we know the resistance is lost, then we know that our cannula is inside the joint. So this is an anterolateral portal. Then once we insert our cannula inside the knee, then the knee is gradually extended, and thus at the same time the cannula is moved to the suprapatellar pouch. So once we know that our cannula and trocar is in the suprapatellar pouch, then we take out the trocar and we insert the scope like this. And as we go inside, we know that we are in the suprapatellar pouch, then the inflow of the saline is started. So this is an arthroscopic view of suprapatellar pouch. Here we know that we are basically in the suprapatellar pouch. As we gradually withdraw our scope, we come to the patellofemoral joint line. Then after inspecting the suprapatellar pouch and the patellofemoral tracking, then patella, is there any chondromalacia patellae, then our scope moves gradually to the medial gutter. Medial gutter is important to check because most of the times any loose body is there, then it is lodged in the medial gutter. So here we can see there is one loose body which is lodged in the medial gutter. Then after this, we create a anteromedial portal. It is created by palpating the medial joint line. There we can see the indentation inside your joint, and according to the pathology, your portal is made according to the pathology, whether it should be superior, inferior, more medial or anteromedial. So after making the portal, then your extended finger, which is a probe in your arthroscopy, which is inserted in the joint, and then we can palpate everything with that extended finger. Then your scope moves to the intercondylar notch. This is your intercondylar notch. As a novice surgeon or a beginner arthroscopic surgeon, we sometimes confuse this synovial plique for ACL. But once we remove that synovial plique, once we shave off the synovial plique, we know that ACL is lying there. Then our scope moves to the lateral joint line. Lateral joint line is nicely seen when the limb is in figure of 4 position like this. So in lateral joint line, we see femoral cartilage, tibial cartilage. Then most of the times laterally there is a discoid meniscus. We can see that. And if there is any injury to the meniscus, that also can be seen and palpated with your probe. Then your probe moves, then your scope moves to the lateral gutter. Lateral gutter, again, it's important because, again, loose body can be seen, any ramp lesion or any PLC injuries can be seen. This is a popliteus which is nicely seen in the lateral gutter. So I end my talk with this. Thank you.
Thank you, Dr. Neha, for the wonderful, informative lecture. Moving on, I guess Dr. Nimade is still not with us. So moving on, now that we've learned about the basics of knee arthroscopy, we can now move on and learn about the various portals in knee arthroscopy and their safety. So as you all probably know, it's not just a single portal through which we work and do the knee arthroscopy. It's a plethora of portals. So selecting the correct portal for a surgery can actually make or break your surgery. So you should be aware of selecting the correct one in the correct situation. So I now invite on stage Dr. Professor Sarthak Patnaik, who's come all the way from Bhubaneswar to help us understand portals a bit further. Thank you, sir.
Thank you, everyone. Thank you, Dr. Aashay. At first, I would like to thank my mentor, my teacher, my guru, Dr. Sandeep Srivastava, sir. Thank you, sir, for inviting me again. And my other teacher, Dr. Samir, sir, who always was been an inspiration and is my guru. So to start with, knee surf portal, can you just, delegates, please raise your hand. Okay. So just everyone, just feel your knee. Just feel your knee, your right knee, yeah. All these things, yes. Now, if you could feel, you can feel, just try to feel the inferior pole of patella, okay. Try to feel your condyles, both sides, the lateral femoral condyle, the medial femoral condyle. Go ahead and feel the tibial condyles. Try to go and feel your patellar tendon, okay. Are you feeling it? Then slightly slide your finger, your ring finger, and feel a notch, a soft spot, or a depression, right? Clear? Okay, fine, that is what I wanted. To go ahead, so the first and foremost, which is most important for any knee arthroscopy, is the surface anatomy. Like you might saw many instruments we need for arthroscopy, but the most important tool which I till date use is my pen. If my pen is not there, I don't operate. Because all knees are different. You might get a thin skinny knee like this, or you will get a very fat knee of a 140 or female. So once you do this, the first thing is palpate the tibial tuberosity, mark them, palpate the lateral femoral condyle, the femoral medial femoral condyles, both the, as I mentioned, just both the tibial femoral condyle, the medial and the lateral. Once you do this, try to feel the depression, try to feel the lateral border of the patellar tendon. Sometimes what happened, it is not easy to feel the patellar tendon if it is a female or in any obese patient because a lot of fat. At that time, slightly extend your knee to around 30 to 40 degree of flexion, and then you could feel the patella. So when you feel that patella, try to slide your finger to the lateral, just adjacent to the patellar tendon, you can feel the notch. So once you feel the notch, this is two way you can confirm, go from superior and go for inferior, the point or the average point where it is you can feel the depression. So this is where you can go and go ahead with the anterolateral portal. So once you do this, so to go ahead with this, we start our procedure. So you go and feel the anterolateral portal, you do the incision, and you should always use a straight artery forceps, try to use a smaller one, and pierce it on 45 degree so that it reaches your opposite lateral femoral condyle. Put your trocar cannula and then insert your scope, and once you go inside, you can see all those fatty tissues. Then you have to go for a lateral condyle or the anteromedial portal. So once you see the anteromedial portal, the key is take an 18 gauge needle, keep it parallel to the anterolateral portal, just keep it similar like this, and try to go more medially. And when you push it, when you push your spinal needle, try to hit it to your other condyle, the medial border of the lateral femoral condyle. And to go ahead, see, there won't be any nerve structure. Even if there is nerve structures, we can't see them. So don't bother about the superficial nerves and all those things. But what we should be bothered is the superficial veins. So that you can do by this light test. So when you put that, just switch off the lights, ask your fellow to, whoever to remove the light to the other side. Once you see this light, red light, as you can see over there, just revise. So this, can you see how clear it is? Once you see this, put your needle under the view and just go ahead with your anteromedial portal. Once you go inside the anteromedial portal, the first and foremost what you should go is remove the fatty tissues, which my other speaker is going to speak. I shouldn't speak about that. And to go ahead with all the diagnostic. So then we come to the then there are two more portals. So the most important portals are the anterolateral portal and the anteromedial portal. So in this anterolateral anteromedial portal, you can do all your ACL, you can do all your meniscus surgeries. As Dr. Neha has already mentioned, the other two portals, the anterior superior and the accessory anterior superior, yes, they are thing, but since it's a basic course, I thought I'll stick myself only with these two important portals. Then come is your posterior medial portal, for which we have a topic in which you are going ahead and trying to reach for the PCL tendon. So once you do this, that is again under observation. Now what is important here is positioning of the needle. So if you see over here, this is where you should be, or you should go slightly above, because you need to do your instrumentation. Sometimes people use a one portal, sometimes we use two portal technique. For at that time you can put your things according to it. So once you do this, first place your needle under observation, use your dilator, go ahead. Try to many surgeons use a knife, but I am a bit skeptical because once during my internship fellowship days I saw the blade fell down. It has happened in one of the IS Congress also by a very senior doctor. So I thought they have methods where you can tie it with the Vicryl and all, but I don't practice that. I just go ahead with this. And so once you do it, do this. So the other portals, if you say this, as I mentioned, the anterolateral portal, the anteromedial portal, we have the posteromedial and the posterolateral portals, which is basically for PCL. So in our future courses, you can have a nag of it. At this stage, you remember the two main portals, the anteromedial and the anterolateral portal. And to go ahead further, in the posterolateral portal, like we saw for the anteromedial portal, the red light vision or the red bulb. Similarly, for the posteromedial also, you should see for your follow-scope to see the fatty structure, the red thing. Whereas in the posterolateral portal, you won't be visible properly because of the ITVs and everything. So this is how you should mark your thing. You have to feel for the biceps tendon, the lateral collaterals, and in between them, we have your lateral portals. So the take-home message is, do a proper examination of your patient the previous night, so that if in an initial stage, so that you know, okay, I don't have a fatty knee or something like that. The surface anatomy is a must. If fat, as I mentioned earlier, please flex the knee to 30 degrees and palpate the patellar tendon and mark it. First, always go ahead with the anterolateral portal, always. The anteromedial and rest under observation, confirm with needle, always. So when you put an anteromedial portal, when the needle touches the medial border of the lateral femoral condyle, you know, okay, I'm in the proper, because you are doing it under observation. And then do your anteromedial portal and followed by things. They have the thing that, see, your anteromedial portal can be so nice that you can do your meniscus work. You don't have to do an accessory. But yes, if you're struggling, we have many other portals such as transpatellar and all. I thought we can do it in the next series. Thank you very much.
Thank you very much, sir. Moving on, I can't help but stop thinking that we truly have entered the modern era of clinical practice, of referral practice rather, where we as all arthroscopy surgeons, a patient comes to us with a diagnosis saying, "मेरे को ACL tear है, मुझे treat करो." But jokes apart, moving on. Now that we have a diagnosis, we are aware of how to set up our trolley and sterilize our equipments. We have developed the necessary motor skills and selected the correct portal to go inside the knee. It becomes very important to identify what is normal and what is abnormal. There was a quote in our anatomy department back in my UG days which said, "The mind knows only what the eyes can see." So that being said, to take us through the journey of differentiating normal from an abnormal inside the knee joint, I invite Dr. Tejas Waghela, who is an eminent arthroscopy surgeon from Akola, to speak on the diagnostic, abnormal as well as normal. Thank you, sir.
Thank you, Dr. Aashay, the whole organizing team. And Tejas, you have been eloquent the whole conducting, so I congratulate you on this. So, can we start the presentation, please? Okay. Yeah. So, good morning, everyone. So, this is going to be a quick refresher. There are certain important points which I want you all to just take home. So, जब भी आप लोग trolley लगाते हो, whenever you guys are putting the trolley, this is how I mark this. I've been doing this for the last 15 years, and I think you all should do it the same. So what you have to do is you have to take an 18 gauge blade, 18 gauge needle, which comes with your TURP. Your TURP irrigation set has 2 needles. One you give your assistant, you have to puncture. One you keep it with you. Take a 11 number blade, take an artery, your arthroscopy sheath, followed by the probe, and your meniscal instruments, and if you are doing an ACL, your curettes. So this is how you arrange everything. Do this each and every time. You do it yourself, your assistant will learn it. When your assistant does it, you don't need to do it again. A few important points. I always keep the monitor on the opposite side. I try to segregate everything. So I segregate the shaver blade with the suction, then the light cable, then the camera cover with the camera head. The wires, sheets, everything needs to be, like all of this is very expensive for each and every one of us. So don't use the towel clips. The towel clips are very sharp. They will gradually, slowly corrode your wires, and they'll cause a lot of damage. So you can use, I use alleys forceps, but you can use those blunt point tips, or you can use even arteries. Of course, the TURP set also goes on the opposite side. I also use an alleys on this. This tip was given to me by Dr. Abhay Narvekar sir 15 years back, and I still followed it. I'm not going to go through diagnosis. Dr. Aashay, pardon me, but I think Neha explained it so well that I don't think I need to go with it. Meniscus. When you look at the meniscus, again, a few pointers. Meniscus, generally your medial joint is going to be tight. Your lateral joint, you don't have a lot of things to do to open it, but for the medial side, you have certain things you can do. An important thing is the MCL pie crusting, which I'm going to be talking about. Of course, these are the various tears that you can see. This is going to be covered in the next session. As you can see, this is like a small video of where your degenerated knee has a lot of small space for you. And these are the typical degenerated meniscal tears which you might see. Another pointer for each and everyone who is starting with scope is, don't do very arthritic knees. आपने को क्या लगता है कि यहाँ OA नहीं आया है, चलो स्कोप डाल देते हैं. Don't do that. It will damage your confidence because your medial joint is so tight in it. Secondly, they have rotational abnormalities. You might not be able to go underneath. There will be contractures in the fat pad. Take simple meniscal tears, take simple ACLs, choose your cases wisely to start with, and then gradually progress to more complicated work. Also, the another point, whenever you're doing a case initially, have a confidant, a senior colleague of yours. Now many of us have become arthroscopic surgeons, and all around the city we have people who have done now thousands of cases. So keep your senior confidant under guidance for the first few cases. It helps. It really helps. We didn't have that back in the day, but now I think you all do. You all should do it. Of course, and then as you open the MCL, it open the pie crust. It opens significantly. So now talking about, of course, Neha talked about this, but I thought I'll add some very few practical points when you're looking at the lateral meniscus. So I tell my assistant to do it in 3 steps. The first is you flex it. You keep the knee in figure of 4, flex it. So the first thing is to flex. Second is to elevate the leg. And last is for your assistant to put the hand on the femur to give it a valgus force. Generally, a lot of our assistants or a lot of people are trained to put the hand directly there and open it. Because now all of us are orthopedic surgeons and our assistants are also orthopedic surgeons. And they have this tendency of reduction. So they'll, be like bodybuilders. And of course, yeah, orthopedic surgeons are supposed to be that. But still, in arthroscopy, there's a little bit of finesse involved. So I think it should be flexion, figure of 4, flexion, elevation of the leg, and lastly, it should be the hand on the femur to open given valgus. Another point, even though in this you see a leg holder, I have found that the way to open this joint is to flex the knee further initially. So what happens is, as soon as you go in the gutter, you saw Neha has shown it beautifully that from the medial gutter you go into the medial compartment. Now, when I was trained, they said that never do that. Because what you're going to do is, you're going to damage the medial femoral cartilage. So what I have been trained to do is, always go in the gutter again. So it is a one-way traffic. You're going in the suprapatellar pouch, going in the gutter, again coming in the suprapatellar pouch, coming reverse lena hai, and then go in the joint. Now this is what I follow, this I've been trained. However, it is nothing wrong if you go directly. In fact, Lubowitz has significant amount of papers where he always goes directly from the medial gutter into the condyle. And then you flex the knee. The more you flex the knee, I think the better it gives you a visualization of the anterior and the middle body of the medial meniscus. A quick point of the MCL release. So as Dr. Sarthak was also talking of, illumination is our very good guide. It helps us in preventing nerve injuries. It also helps because always the nerve follows the vein. Maximum number of times, lot of cadaveric studies tell us that the vein is followed with the nerve. So you just prevent puncturing the vein, probably you will not damage the nerve. And I have seen, and I'm sure you all will see a lot of infrapatellar saphenous nerve injuries. Your patients will have hypoesthesia. I have it with my patients. It is not very bothersome, but sometimes, rarely, they develop a neuroma. So why try to, give that to them? The other thing is, as you can see in this, do I have a pointer? Yeah, I do. Sorry. Pointer? Oh. Yeah, so you can see where my fingers are. So always palpate the posterior aspect, posterior-medial aspect of the tibia. It is always palpable. Again, Sarthak, I'm borrowing one trick from you. So everyone, please palpate your posterior-medial tibial line. And as you go, you palpate it and go up. So keep your knee in 30 degrees of flexion. And as you go up, that's the point where your MCL, actually it is not just an MCL pie crusting, it is the posterior oblique part of it, which you are pie crusting and gradually opening. And you hear a sudden pop. Now, Dr. Bancha from Thailand has a paper on this. He calls it the magical spot. I think I'm not good at magical spots. I just do it like a string of guitar and try to open the joint. And that's how then you can get a good MCL pie crust. Okay, so as we are talking about what is abnormal, now we have learned that the ACL has a large cord-like structure, which we have discussed in the diagnostics. Now, ACL, you will see that they'll have different kind of remnants. And the classically described remnant morphology is by the god of ACL, Dr. Freddy Fu. And he described it into various 6 parts. I have been fortunate enough to see almost all of them. So, as you can see, the first one which I wanted to talk about, I'll just pause this. So, in your clinical examination, sometimes you will feel, yaar, patient ka lachman to theek dikh raha hai. Patient ko lekin complains of instability. MRI, you are very sure that there is an ACL. So why is the patient not having a soft point or the one which we were taught during our MS days? What happens is the ACL sometimes goes and gets stuck onto the PCL. Now this is called the lambda sign. Now, this is type 2 Freddy Fu ACL morphology, and this you will see. In fact, in our patients, we see this a lot. So ACL getting stuck onto the PCL. That's your common thing that can happen. As you can see in this case, sometimes there will be some scarring which goes and gets touched onto the notch. So I'll spend some time on this video. You can see that there is scarring in this case. Of course, you know I'm in the anterolateral portal. There can be nodules, as you can see here. There can be, the scarring can be stuck up on 12 o'clock position. This can happen, and of course, you can have a mucoid degeneration and ACL tear as well. That can happen. So these are various ways in which these things can present. Yeah, so another quick pointer, always you have to look at the posterior, we all know, anatomy we have learned, each one of us is well versed with ACL anatomy. There are two bundles in the ACL. You have the PL bundle and the AM bundle. Now what happens is, when you go in the triangle, as we just saw, that you have to go into the triangle, which is formed by the ACL, the lateral femoral condyle, and the lateral tibial plateau with the anterior horn of the lateral meniscus. Now, as you open, if the PL is gone, you will directly see the posterior lateral compartment. However, if the PL is intact, you won't see that. So this is a very good indicator of a partial ACL tears. So always see the triangle and then do your figure of 4 and see whether the PL bundle is attached or not. Another common thing which I think you should start, this is probably the best cases to do. If you have a loose body removal, it is not only a good arthroscopic triangulation exercise, it is also a quick surgery. Your patient will be extremely happy. You can show your result to your patient, and most importantly, it is a quick surgery, but sometimes, like implant removal, loose bodies can cause you a lot of trouble, and I've had it. I've had my share. Another point, of course, Neha told us, so this is called the alligator max grasper. This is quite traumatic. So when you grasp it, actually it causes a lot of damage. So I don't use this. I use the coker, Sadar Gauran coker. Go in, clamp it, take the whole thing out. So you can see some very interesting cases. You can see these kind of bodies. This patient had a large open wound, and he came to the primary surgeon with severe crepitus and pain. And in fact, it was a shard of glass which was inside his joint. You can also see there is damage to his lateral femoral condyle. So again, these kind of things crop up to us. So that was the glass body which was removed. Another very interesting, sometimes you see these flakes, ऐसा लगता है कि ये कुछ नहीं है, but we don't treat the X-ray, we first see the patient. This patient had a dislocation. And then on X-ray she had this. The primary surgeon told me that patient को PCL avulsion लग रहा है, आप देख लो. When we were, of course, we got an MRI scan for her, and in fact, this was a piece which was coming from the patella. So it was a patellar dislocation which dislodged not just in the gutter, but in fact it went into the posterolateral side. And of course, like we saw, an abnormal arthroscopy, there is a large lesion of the patella, it is eroded. And we went in, that's your normal ACL. This is the triangle which I was talking about. So we went in through the space between that. We grasped it with a non-traumatic forceps, and we took it out. Sorry. And then we fixed it with a biopin open, and the patient did reasonably well. Another thing, whenever you are removing the loose body, make a significant big capsulotomy. Because sometimes what happens is we have these small portals. We are going in, grasping and trying to take it out. But what happens is it gets stuck there. You will be frustrated because बहुत देर तक वो घूम रहा है mouse अंदर, और finally we have grasped, we have caught hold of it, and then we are trying to pulling it out, and it doesn't come up. So make a big capsulotomy, take your mosquito forceps, open everything up, and then take it out. You can also see these kind of things where you feel that this could be a large, either a cystic lesion or a large cavity. It turns out to be these massive rice globules. Of course, posterior medial portal, as Professor Sarthak has told us. And this turned out to be turned out to be like poha, and it was synovial chondromatosis. We all are hungry maybe. And yeah, so this is the best one, the normal ghumta hua mouse, which is there in the suprapatellar pouch. Another thing which I do is I use the 18 gauge needle and sometimes I transfix it. It is sometimes not possible to completely transfix it, but it at least keeps it in that position. You can make another extra portal in line. So basically, as our triangulation principle suggests, that we should be in a vector so that we can take that thing out. So if it is in the suprapatellar pouch, the best thing is to get your loose body in the suprapatellar pouch, make a large opening, capsulotomy, and take it out. And that's how you can do it. Of course, that's my coker taking this out. So to cut the long story short, complex tears in white zone are generally present, and these will be degenerative tears. You can do a meniscectomy. These are probably your first cases that you should try to do it. However, not in very arthritic knees. Use all your visualization maneuvers, including MCL pie crusting, including figure of 4 3-step procedures. Your portal placement, I cannot reiterate it more, that it has to be in line. So always use your 18 gauge needle to get a proper vector. Of course, examination, proper history. It should not happen that you will become visiting surgeons. Your primary orthopedic surgeon tells you it's a PCL avulsion. You go with the PCL set and it turns out to be a loose body in the posterior lateral gutter. Always adequate capsulotomy for loose body removal, and stabilize it with a spinal needle or your 18 gauge needle before removal. Thank you.
Thank you very much, sir, for the highly informative talk. With this, we come to an end of the lecture series of session 1. Can I please invite all the speakers of session 1 on stage? We'll open up the floor for a question-answer session for 5 minutes. Can I please invite all the speakers of session 1 on stage, please? I open up the floor for any questions from the delegates or faculty members.
Yeah, my name is Dr. Nyanda. I'm from Fortis Vashi, Navi Mumbai.
First of all, no question is a bad question. So, you ask everything, all of these that all are experienced, and everyone will give you an answer. So, I think never do pie crusting for each and everything. In fact, pie crusting is making your knee a little unstable, right? There are a lot of papers where people are talking that how much pie crusting you should do. So you are doing pie crusting only if your joint is not opening significantly. That's it.
I have one question. So is there any preferred technique by all of the evidence speakers in which you do pie crusting? Dr. Aashay? Is there any preferred technique in which in the sequence in which you do your pie crusting? You go anterior, posterior, what kind of equipment do you use? Of course.
So to start with, when you do it, most of all, when we do a diagnostic knee scopy, after going through the when we go intercondylate, we try to see the meniscus. It's mostly the medial meniscus. If you are able to see the medial meniscus, especially the root, sometimes over there the PCL pad of fat will be there. So if after dissection, if you are able to see the root and able to put your probe and you can see, okay, fine, it is clear, then no need to do a pie crusting. Suppose there is a posterior tear, or there's a big bucket handle tear. At that time, you need to open your meniscus even more. You have to see it better. You have to open the medial joint space. At that time, what I do, basically, I use this 18 gauge needle. I give a slight valgus stress. Ask my sister, to give a small over there to push it. And while giving the valgus stress, I try to feel. Now, exactly where, Dr. Tejas was saying, Banchas mentioned, but just to quote, there are 2 places where you can go. either go to the tibial attachment of the MCL. So you need to feel the bone. You need to feel the bone and just go for 18 to 20 strokes, and sometimes it open. There are surgeons who do intra-substance, like in the mid-ACL, who goes into, but it's a bit risky, but yes, you can do. So you can feel, sometimes they don't make that typical noise, but you can feel like it's something is like open up, just like a small give up type of thing. At that time, you can see your joint space opened up. But if there is an, you can see your middle joint line well open, then you should suspect for any other lesions in the medial side.
I think very well described. I just had one pointer. If you have you're doing an MCL pie crusting with an ACL reconstruction, first always harvest your CEMITI. I have a colleague of mine who told me that he was doing MCL pie crusting. In fact, he damaged the CEMITI. So first harvest and then do it. The other thing I do is I keep it in 30 degrees. And yes, I do what Bancha describes as in going from the posterior medial side, and I have found it to be fairly reliable. I don't need to do multiple punctures, but I use this guitar technique where I use the 18 gauge needle, and like a guitar, I just make 4 or 5 nicks, and that generally gives you a crepitus, and that probably tells you that you are there near.
This pie crusting is mainly important whenever your ACL is intact and you are dealing with the isolated meniscus. Because if there is a meniscal tear, many a time the D joint is already opening. So many a time it is not required. But whenever the ACL is intact, yes, pie crusting would be always required if you are going for a middle meniscectomy.
And one more thing is, while palpating the posterior medial part, and when we put our 18 gauge needle, we get this grating sensation, and at the same time our scope is inside. So how much to open is most of the times is the question. So whenever our scope is inside, we know that it is sufficiently open, you stop it. It's not like hard and fast, like some people might get it in 4-5 nicks. Some people might require it 10 to 15 nicks. So it's like that.
I have a very basic question. Regarding patient positioning, do you prefer to have any specialized, like, kind of leg holders to hold the leg in a particular position? Do you prefer to let the leg hang down the table? Because I've seen a few surgeons pull the patient to the edge of the bed and let the leg hang down. Or do you prefer to be supine and ask someone?
It's basically how you are trained. I have been trained with leg on the table. There have been many people who have already putting the leg hanging down. It is comfortable, definitely. Your shoulders are not at stake, your shoulder and elbow. So I use generally a lateral thigh support and a foot end. But there are various special holders which are made in the market. So you can use that. But I generally use a basic thigh support and leg support.
So I differ with Neha. I use a knee dangling position. The advantage with the knee dangling position is that the other leg is abducted and supported. So you have a very good access on the medial side for drilling also. And especially if you are doing a PCA reconstruction, if you are creating a posterior medial portal, this is very handy.
I think you should be well versed with both the positions. And the reason is because if you are doing an MPFL reconstruction, you will require a supine position. You cannot do it in a head dangling position. And if you are doing a PCL, you need the leg to be dangling. So I think it's the same way in shoulders, they say beach chair or lateral, dono aana chahiye.
So I do in supine position. The most important thing when you position your patient is drag your patient. The foot end should come exactly at the edge of the bed or the table, because then it gives you a lot of space while operating. Now if your patient is slightly up, then your working area gets reduced. It puts lots of pressure in the shoulder. Second, the lateral post. When you give a lateral post, just flex it. It should hit on the tunicate bed. And then you should see, then that's where Dr. Samir sir's opinion comes. You should make the patient hang, make his leg hang, so that you can work on the meniscus and everything. So indirectly on table you can get a hanging also if necessary, because you have given you. So you need to hold, like position the lateral post very meticulously, and you should, even if you are assistant at positioning the patient, but this is one thing you should see is this, the lateral post, so that it can hang easily and you can do it. Otherwise that's resting.
I'm Dr. Anil, I'm from Kerala.
My question is regarding the incision put during the entry. Is it really matters to put a vertical incision or a horizontal incision?
So I put vertical incision. There are many surgeons have which horizontal incisions. I don't think that multiple papers have come on it, right, regarding the giving the incision. But I am well trained and I am quite comfortable with the vertical incision. I don't see anybody horizontal incision here.
So I always use a horizontal incision. The advantage with the horizontal incision is that the chances of damaging your lateral femoral condyle are less. Another thing, the risk of the damaging the anterior root of the lateral meniscus are higher if you are using a vertical incision. And also they are more cosmetic. And always, whenever you are doing the incision, your knife should be angled 45 degree. You should not be going straight. If you are going straight, then you are going to hit the condyle. Similarly, when you are doing a medial portal, this should be angled medially into the intercondylar notch. You should not damage the, it should avoid your medial femoral condyle.
I actually do horizontal portals a lot of time, but there's only one when I do a vertical one, which is when I'm doing a PCL. Because PCL, you need a bigger portal, and also you need the axis as more straight for your PCL aimer to go down. One pointer, always use your 11 blade upside rather than like this, so that you don't damage the meniscus if you're using a vertical portal. Though I think both of them are okay.
The advantage with the vertical portal is that if you have put a wrong porter, it is easier to revise with the help of a vertical portal. But if it's with horizontal portal, you will have to create another entry. If it's a too high or too low, you will have to take another portal.
I think it's an excellent question and a lot of points to be discussed on this itself. This is a very important point for all beginners. Also, I think we all will take a lot of pointers in this. So one is you have to understand how to do a Gilchrist portal or go through the posterior medial part. And the way to do it is you have to go between your medial femoral condyle and the PCL. Now what happens is a lot of times it becomes very tough to go inside. Now there are a few tricks to do. One, you can directly use a Wissinger rod. Take your view on the opposite side and take the Wissinger rod and pass it between and go into the your compartment. There'll also be certain times when it will be too tight and you won't be able to do this also. Then you go between the ACL and the PCL. So this is your first, how you go into the posterior medial compartment. Once you are in the posterior medial compartment, I think it was very nicely shown that you have this illumination which happens on the posterior medial side. You look at the veins, take your index of whatever finger and punch it and look into the capsule will show you indentation. That means your finger is at the right position. This gives you a rough idea. With your 18 gauge needle, generally you will tend to be a little more anterior because under say there is some apprehension from us initially. So don't worry, go posteriorly. Even if your 18 gauge needle, you're not using a spinal needle. Spinal needle is quite big. 18 gauge needle, if you go through and through, you won't damage the popliteal artery, believe me. So be very confident in that. Go into the posterior medial. Keep the needle there. Don't remove it. We are normally, हम लोग क्या करते हैं with your anterolateral anteromedial portals? We are going in and we are removing it and then we are cutting it. Don't do that. Keep your needle there. There are a lot of things that you can do. I have actually got my 11 number blade stuck in the posterior medial quadrant. But again, they say that if you have not broken an instrument inside the joint or you have not left a blade inside, you have not done arthroscopy enough. So I think there will be a stage in your career where all of you all will do it. And I think that would be a eureka moment for you कि हमने आज arthroscopy बहुत सारी कर ली है. Jokes apart, once the blade is there, you don't need to worry about it. What you can do is to prevent it. So preventing it is use either a linen. Dr. David Rajan, with whom I got taught my basic training, he always used to put a linen. I use the surgery wear drapes and they have these blue stickings. So I just put that sticking. When I'm doing a PCL or I plan to do a posterior medial portal, your blade will not slip. Once it has slipped for me initially, after that I've always done this. Go in, make a capsulotomy. I know Dr. Sarthak does it directly, he's confident enough to do it, but I have found that you will make either multiple punctures or you'll have a lot of trouble putting your cannula. So make a good big capsulotomy, fluid should be start flowing out decently, use your straight artery, go in, open the whole thing up, then use a cannula. Initially, always use a cannula. You can use it with a tip, or you can first put a Wissenger wire, Wissenger rod, and over it, you can put a cannula. I think that should do. Any other tricks?
Also, some of the companies have this cannulated Wissenger rod, so that can also be used. So initially, you can put that wire inside, keep it there, and over that you can put the cannulated guide wire. So these two steps, that is the putting of the needle, knife, and the Wissenger rod, can be shortened. So initially, that can be tried. So more you go near to the patella, more you are going to go through the fat pad. If you go lateral, you will avoid the fat pad. But if you are doing any surgery which is into intercondylar notch, you should go as near to the patellar tendon as possible. Not cutting it, but just lateral to the patellar tendons. You will have a better picture of the intercondylar notch. Okay.
Yeah. Just a quick practical tip. When you are going inside, when you will be doing in your cadavers as well, your cannula, your sheath should go very smoothly into the suprapatellar pouch. If it is not going, that means you are hitting the fat pad or you're getting stuck in the fat pad. That is one judgment for you. The other thing, I think now in 2023, the idea of using only 2 portals is gone. We are all now advented into shoulder surgery. We are using 5 portals, 7 portals. So now even if you make 4 or 5 portals, nothing wrong in it. I used to do ACLs with 2 portals, now I do it with 3 portals. I use a central transpatellar portal to identify my femoral footprint. It has changed my life. I think you should all learn it. You should all do it. So there is nothing wrong if you make 2 or 3 more portals, as long as you do a good surgery.
Yeah, as you asked, like how close is better to go close to, as much as close to the patellar tendon. And what Dr. Tejas has just mentioned, I have not tried the other portals, transpatellar. Maybe I'll try one day. But if you are well trained and well, got a good view of your medial border of the lateral femoral condyle, I think you can sufficiently manage with 2 portals.
Thank you very much.
Thank you.
Please. We would just like to felicitate all our speakers of this session with a memento as a token of our appreciation. Can I please invite on stage respected Dr. Srivastava sir, Professor Orthopaedics and Director Global DMI HER, to present a memento to Dr. Neha Godghate and Dr. Samir Dwidmuthe, please. Thank you, sir. Can I now invite respected Dr. Deshpande, sir, Professor Orthopaedics, to felicitate Dr. Tejas Waghela and Dr. Sarthak Patnaik. Thank you, sir. Thank you very much. That brings us to an end of the first session. Moving on, now I would like to invite Dr. Aashay Kekatpure, Organizing Chairman of the Knee Arthroscopic Workshop, to give a demonstration of how to set up your own triangulation setup. Dr. Aashay, the stage is yours.
Okay, we are from India, and there is a very common word which Indians have introduced into the world of Oxford Dictionary, which is called as jugaad. Okay, so I don't know. I mean, I come from a very humble background. To starting with the orthoscope was a very, how can I say, a very rich dream to initial with for me. I'm not talking about everyone else. So to initiate myself into orthoscopy and learning, okay, to get a hands-on, I mean, scopes are expensive, right? So you need to start somewhere. So I hope this little exercise, this little jugaad helps each and every PG to set up their own triangulation setup at their home. Having said that, for this particular course, we have also set up a very advanced augmented reality setup, which you will soon go after the inauguration workshop. Okay? So in the words of Lombardi, this is a football. Get it here. Yes, Agar. Camera. So I want you to just settle one fresh Everyone is aware what a boroscope is. This is used to evaluate engineering or pipeline without opening them. Okay? It's available easily online. You can get it anywhere. Another thing which you need is a common shoe box. Okay? I have just made some markings inside the shoe box just so that to complete various exercises. Okay? You can keep two small how can I say, small round cups or something like that, in which when you progress, you can just pick those instruments. If you have instruments, that's good. Okay. Anas, I need 2 needle holders. Needle holder रहेगा या फिर छोटा instrumentation का set रहेगा तो चाहिए. So what you do, you turn on your phone. So there is a thing called as a dual camera application. Can someone hold the mic for me? Able to see? So this is like a scope, okay? It has got a USB cable and this thing. You can use a normal file clip. This is a filing clip, okay? So when you introduce it inside and keep the tip slightly prominent outside, okay? So this is a 0-degree scope. Now, this particular thing comes with the light source intact. Okay, give me the tape. So because the posterior part cut. A dual phone app. So far interesting, yeah? It's a dual USB app. Just connect it in your C side cable. That's it. You are live. Can you see? So this is your makeshift orthoscope. For doing those exercises, you can use any normal shoe box. I've punctured or made these 2 holes over here as demonstrated by one of the lectures Dr. Neha had showed. Okay. Now, spread it out please. And then for light, you can make an extra hole or something like that. And then you can use it. Just hold it. There is. You can adjust the light also. Okay? Turn on the lights. See this? And then you can practice all your triangulation over here without damaging anything. Okay, I hope this is helpful and you can do it and practice it and learn these initial triangulation skills. Okay, so these stations will be open for you. You can try it over here after the inauguration. And then we will go for the AR, augmented reality session. Thank you.
I request all the delegates and the faculty members to please be seated. We'll start off with the inauguration ceremony now.
So as the custom of our esteemed institute go, this will be the official inauguration of our maiden knee course, knee cadaveric course. So may I invite on stage our chief guest, Dr. Anup Morar sir, to please. I'll invite Dr. Sandeep sir, Sandeep Srivastava sir, our mentor, our guide and our source of strength to be on the dais. Our big brother and support, Vasant Gawande sir, who is also our chief medical superintendent, to come on the dais for the inauguration ceremony. Dr. Deshpande sir, who is my guide and mentor and my PhD supervisor, to please come on the dais. Please have everyone. We will have sufficient, inauguration, most of the conferences, they do it slightly hastily, but we'll take our time over here because this is our initial event. So right now with this particular conference, we are trying to, sow a sapling, which we hope that will grow into something substantial in the due course of time. So that I'll request all the dignitaries to please light the lamp.
So, a very good morning to everyone. Again, on behalf of the organizing committee of the Knee Arthroscopic Workshop, I welcome you all to the inauguration ceremony. So as we all know, seeking blessings from the elder and more experienced members of our family at the start of any new good deed is a tradition that is being followed since time immemorial. In keeping with this tradition, today we have been graced by the presence of such eminent, experienced and highly respected members of DMHER and the orthopedic community. I thank them all from the bottom of my heart for taking time out from their busy schedules and gracing us with their presence. Now that we have paid respects to Goddess Saraswati, we'll carry on with our inauguration ceremony. I would like to invite the organizing chairman of the knee arthroscopic workshop, Dr. Aashay Kekatpure, to kindly say a few words, give a brief description of our workshop, and as well as the future plans which have been lined up and are in the pipeline. Thank you.
I think I've already said a lot since the morning, but still, to officially request for the inauguration, as I told you, we are sowing this sapling which we hope turns into a very big tree in due course of time. So with the blessings of all my mentors, dignitaries and teachers and guides over here, we dwelled, or rather how this course came to a fruition. So this was idea initially incepted in my mind by Dr. Anup Marar sir, Dr. Sandeep sir and Deshpande sir, and of course Vasant Gawande sir, ki we have the setup. In central India there is a vacuum where we don't have any kind of a lab. We have to travel long distances, go east, go west, go south. So we need something of our own. And most of us who have traveled slightly, they know the importance of such a kind of a setup where you have supporting lab where you can practice your surgical skills and train as well. So having that in mind, we came or started with this basics course. Of course, we have got, equipment and those setups. We have got huge support from our respectable Honorable Principal Advisor Sagar sir, who was very quick enough to grant us, okay, you need a lab, we will give you a lab. So they made the lab for us. And with that, we started on this journey now. So this is our first course. In due course of time, we will be having more courses, more focused small courses, as well as tailor-made courses for a variety of people. With the guidance of Honorable Sandeep sir, we are also trying to get associated with international community for our future courses. To brief more on that, he will himself do it. That's it. Thank you.
Thank you very much, Aashay sir. Can I now invite on stage Dr. Vasant Gawande, our Professor and Head of the Department and Chief Medical Superintendent, SMHRC, to kindly say a few words. Thank you.
Dignitaries on the dais, Professor Dr. Sandeep Srivastava sir, who guided us in the Savangi. Now this is, I think we call this island of Savangi because we started with few faculties. Dr. Anup Marar sir, who is a guide here, who is guiding most of the things, and now we are standing today. This is like morning I put a message like this is a maiden cadaveric workshop we started here. Now we have lined up to Nagpur Orthoplasty Society. They have contacted me, and we have on the 23rd orthoplasty, anterior hip. Most of the people they are interested in, and the knee. I suggested them some vastus if they people will. Most of the postgraduates who pass out and SRs I call, or the new practitioners who really wants to get such exposures, but we know only the names like Ramaya, everybody orthopedic surgeon, and the AIMS Delhi, where we get these exposures of cadaveric workshop. So here with the as Aashay had just told, Honorable Sagar MEGHE sir, he has agreed, and with this vision we could start it here. And as this is the first cadaveric workshop on knee, which the Aashay has started, and I'm overwhelmed to see national faculty, our very own Dr. Sarthak Patnaik is here, Dr. Tejas from Akola, Dr. Samir sir has come from AIMS. So many faculties and stalwart, Dr. Jagtap sir is there, Dr. Naved is there. So so many experienced arthroscopists. So I can say to all the delegates who are specifically, few are flown from I think from Mumbai, Chennai, Madras, right? Sorry, Kerala. So guys, you have maximum the whatever things you want to know. These people are so friendly and most experienced. You'll get everything what your queries solved. So please do ask. Feel free don't feel like embarrassed to ask any silly question, as Dr. Tejas has just told. Every question is important. You get your queries cleared and try to be a better arthroscopy surgeon after such courses. So that is what I want to convey rather than taking more time. Thanks a lot. Thanks for coming. And I wish this should be successful so that, and please spread this message of this like cadaveric lab to other your colleagues so that they can take advantage rather than flying to like Bangalore, Indore. So central India, this is a like good, and we know Nagpur is a friendly city. So thank you. Thank you again for coming.
Thank you very much, sir. Can I now please invite our guests of honor, Dr. Srivastava and Dr. Deshpande, to kindly say a few words.
Respected dignitaries on the dais, Dr. Anup Mehra, sir, the CEO of the DMMC and the hospitals, Dr. Vasant Gawande, the Chief Medical Superintendent and Professor of the Department of Orthopaedics, Dr. Deshpande, sir, my dear colleagues, and special presence I acknowledge of my own alumni, Dr. Sarthak, Dr. Aashay, Dr. Sameer, Siddharth, and I saw Harshal also there, and Naved also there. So it's a good pleasure to see all of them who had been associated with us at Savangi to be becoming so prominent, eminent orthopedic surgeons. My pleasure to have you all, Dr. Jagtap and everyone. It's like good to see a beginning. Regarding that, it's the way the whole education is shaping up is slightly different now. No more we are restricted ourselves to just clinical trainings. It's spreading out to the lateral parts, and simulation brings in a lot of change the way we can sort of build a safety around our clinical dispensations. And with those things in intention, I think the DMMC and JNMC both have taken a step forward to integrate, as they are saying, a sort of a higher skill development workshops integrated with all the things, simulations, clinical skill, hands-on, and of course, cadaveric. So we will have workshops which are designed and aligned to this type of integrations where the learning is through all the modules. And I am happy to see so many delegates coming from outside also. We'll request you to go around and have a look at the whole School of Virtual Learning as well as museum over here. And you will find that definitely the learning things are changing very fast. Having said that, I think so orthopedic department at the Placia, at both the Placia are doing great works. And we are so happy that the Arthroplasty Center at Savangi just completed 300 cases in less than a year. So it had been a good achievement for us. Similarly, we want to establish a very good sports and orthopedic sports medicine center over here with Aashay, Siddharth, Vasant, all scopists leading over here. So it would be a good thing. And I promise you, leading the international division at DMHER, whatever your needs are in terms of skills as well as instruments or associations and fellowships, I will see that it is done. We'll make it sure. So we'll bring it over here. The region should take, I think it's time that Nagpur and Vidarbha has to come into very good prominence. It has got a lot of potential, better than so many other localized regions. Why? Because when South India says something, it is hard for North Indian to listen to. When North Indian says something, it is hard for this person. West says something, East doesn't listen. But when Central India will say, everybody will listen. So with that intention in mind, I think so it's important we make this as a very good hub. And whatever little things we can do, we will definitely try to do every day and every time. Thank you so much for inviting us.
Good morning, my friends. I'm happy to see everyone over here. I don't feel I'm out of the Savangi. सारे के सारे मेरे colleagues, यहाँ तक अंजलि भी पीछे बैठी है. I still feel I'm in my JNMC Savangi MEGHE. It's all right. I congratulate you all. Please keep on progressing. Thank you.
I now invite on stage Dr. Anup Mehra, our CEO, Shalinita MEGHE Hospital and Research Center, to kindly say a few words.
My dear friend Dr. Sandeep, Dr. Deshpande sir, and my younger brother Vasant, Dr. Aashay, and all stalwarts who have gathered here and have graced this occasion to enlighten the delegates who have come across from all corners of India. As said by Aashay, this is a maiden effort with the vision and with the interest shown by the faculty members to have a cadaveric lab. This lab, with the support and backing of anatomy department, has been established. And Department of Orthopaedics, I am proud to say, was the first department which spearheaded this movement. And in coming days, I think 5 or 6 such workshops have been lined up, which has also motivated anesthesia department, and we do hope all rest of the departments will also take advantage of this facility. DMHR University, which happens to be the most accredited, NAC accredited health university as on date in India, wants to showcase and ensure that whatever the faculty members, what Phil Collins has said, to teach is to learn and to learn is to teach. And this practice with immersive learning program, which Dr. Sandeep has ensured, that with the museum, with the SVL, with the cadaveric workshop, and subsequently on the patients, this lineup which has been going to be provided to all the PG students who are here, this facility, the DMHR management is proud to share it with all other interested faculty members and postgraduate students across. So thank you, thanks a lot, with best wishes to each one of you. Thanks.
Thank you.
And I think I will, if I forgot, getting old nowadays, this is the best orthopedics department has given to their professor, Dr. Vasant Gawande, the birthday gift of organizing this workshop on this date.
Yes. So, before concluding the inauguration ceremony, I'd just like to say that it is actually a very pleasant coincidence that the knee arthroscopic workshop shares its birthday with 2 very prominent personalities in this room, Dr. Vasant Gawande, our professor and head of the department, and our senior lecturer, Dr. Ashwin Chauhan. And as a birthday gift from our side and from knee arthroscopy workshop, we have 2 cakes over here.
This is a big privilege. Thanks a lot. Because this is, I cannot share this dais with, like, so many people, stalwarts are there. Yeah. It's a big privilege for lifetime. I wouldn't get these people from Akola, Ames, from Bhubaneswar, so many people. So please join. This is, we will consider this is a cake cutting of the arthroscopy workshop. So everyone is privileged. Please come down here. हम 3 arthroscopy वाले, Siddharth and I was initially for the department, and Aashay has recently joined. So we are day by day just doing it. Please join, please. And our department, I would like to introduce Dr. Ashwin Chauhan. He takes care of most of the trauma, complex trauma and orthoplasties. So for scopy, he has been invited here for his birthday. Thank you. Please come over here. One is for arthroscopy workshop, all delegates and stalwarts. One is for us, both of us. Please.
We will have a short coffee break after this, and after that all the delegates will move to the SVL or the virtual lab for the triangulation session. Okay? Just we will have a break for a short coffee and enjoy the cake also. Yeah, please.
सर फोटो we'll have a short coffee break now, and then we'll meet, everyone will meet for the triangulation workshop in SVL on second floor. सुश्रुत सर आले बसले एक मिनट मैं बुलाता हूँ चल रहा है सर ठीक है Good afternoon, everyone. I welcome you all back for the next session of our workshop. This session is all about the anterior cruciate ligament and covers all aspects related to the management of ACL injuries. From selecting various graft options for the reconstruction to details about the ideal tunnel placement and the different techniques of ACL reconstruction and fixation of ACL avulsion injuries. To chair this session, I would like to call upon stage Dr. Amit Hadole. Sir, if you could please take your seat. Sir. Yeah. So, starting off the session, we have Dr. Sushrut Rajan speaking on the various graft options for ACL reconstruction, their importance and biomechanical properties. So you can go through your slide. Okay.
So Dr. Sarthak is the editor. He has started his own sports magazine, which is called as Fanzine. Okay, he will tell us more about himself.
Thanks again. So this is my magazine. This is known as Sports Science India. If you Google Sports Science India, you can find more things in detail where we treat many national, international players. So to reach the knowledge of sports science, I started this magazine, which is India's first sports science magazine. So isme where I encourage and also request all my seniors, my colleagues and youngsters, if you want, you can put an article, because it reaches to all the orthopedic surgeons, all sports institutions, all SAI, jitne bhi Sports Authority of India academies mein. So in India we are having around, at present, we have crossed 10,000 marks, sir, and this is the 19th edition, and it's a monthly edition, and internationally I have reached into 4 to 5 countries, not in thousands, but yes, in hundreds. So I consider that also a good thing to reach in 19 months. This is a very different type of magazine in which we have, I'll just give it to. So as you know, every chief editor has to give one article. So I start the article, the first page goes with my article where I talk more on the conservative manner, because we should understand the mentality of a sports person. Surgery डालेंगे तो वो पहले चीज़ भाग जाएगा. So you need to tell them the essence of conservative and the essence of rehabilitation. Then we have an expert speaks where we can put our doctors and my colleagues article if you want to speak, and you can rotate, because indirectly इसके बाद my team works on the advertisement, like we make reels, we make blogs, और हम सबको सर्कुलेट करते हैं monthly basis and weekly basis हम लोग का जाता है. So everybody it goes and we put it in YouTube shorts also. सर आपका मैगजीन, तो वो मैगजीन आप ही का मैं ले लिया था. तो and then what happens after that, there will be a sports person who gives an article on unke how he cope up with injury and how he came back. There is an article on, our Arjuna awardees or Padma Shri, Padma Vibhushans, all those past sports personnel of our country, they give. Every month we are receiving 2 international articles nowadays, mostly on sports science, like about burnout, about sports psychology, about strength and conditioning. Followed by that, every 2 months or maybe quarterly now, we get articles from clubs. So like many sports club, and we have a section for the achievers of the month, जो India में achieve किए हैं for the last month, and what is in future, what is coming. I'm going to add a section in this magazine which is coming from next month, where you all can contribute. That is going to be fan hub page, in which is going to be a 2 minutes video along with your article. So there will be a question. And said, we are going to send it to schools and all budding who have certain thing you want to write, you can write on this magazine about sports or sports science. So it is not indexed. I have just made it an article for an easy read. But yes, we give certificate to the surgeon, whoever contributes, we give them a certification of appreciation or contribution, as they do in AJSM or any other article, because I am the reviewer for AJSM and British Medical Journal of Case Reports, so I have seen what they have done. And this is less like a coffee book where you know about sports personnel, how they cope of injury, and if you are slightly fitness freak, this will give you a good insight into that. So the magazine name stands for Fanzine. Magazine, we all know what is a magazine, but since it is for the fan, that's why I kept it name as Fanzine. Yeah, thank you.
Congratulations, Dr. Sarthak, for a great initiative. Now I will call upon Dr. Shushruth Rajan for his talk on graft options and biomechanical properties.
Just before we start the presentation, can I also please request Dr. Sameer Dwidmuthe to join Dr. Amit Hadole as a moderator for this session? Thank you.
Thank you, Aashay sir, for giving me this opportunity. So let's look at the ACL graft options and biomechanics. We all know that the ACL is generally composed of two bundles, the anteromedial bundle and the posterolateral bundle. The anteromedial, this nomenclature is based on the tibial attachment. So the anteromedial is attached anteromedially on the tibial surface. The posterolateral is attached posterolaterally on the tibial surface. So if you see the first diagram, it is in extension. So the anteromedial bundle is anterior on the femoral side also in extension. But the main confusing part when we put our scope inside is during flexion, where the posterolateral bundle is anterior on the femoral side. So in 90 degrees of flexion, there is a twisting of the bundles where the posterolateral comes anteriorly. So this is the main confusing part where we need to know which is which bundle and which bundle we are going to reconstruct and what are the functions of each bundle. So, but in the recent times, Smigelski has done some wonderful work on the shape of the ACL. And it is generally accepted now that instead of these tubular structures, ACL is basically like a flat ribbon. So the bundles are still there, but the shape is not like a cylinder or tubular. That's why newer and newer techniques, including our own Ladda sir's technique of a rectangular tunnel. So that helps in recreating this tubular shape. So what is the function of the ACL? We all know that ACL helps in preventing the anterior tibial translation, but it also helps in the rotatory stability. It prevents internal rotation of the tibia. So if we plot the stress strain graft, if we see which bundles has most stress, we all know that the posterolateral bundle is more active in extension. If we see the graph, the green one, the red one is the posterolateral bundle. Maximum strain is in the extension. And if you see the green plot of the anteromedial bundle, it prevents the anterior translation on the flexion part. Okay? So the functions of the bundles are different in each flexion angle. The same goes with the center of axis of rotation. So in an intact ACL, the center of axis goes through the center line of the tibial plateau. However, when the ACL is deficient, in chronic ACL deficient cases, this center of axis is shifted medially. So what this does is, it causes increase in contact forces on the lateral side. Every contact force on the tibial plateau is shifted on the lateral side. So in chronically deficient patients, we generally notice a lateral side pain or a lateral patellofemoral joint pain. And the reason for this is the center of axis is shifted medially. This is a very interesting concept which I think every clinician should know. What is the center of gravity? So if we see the top two diagrams, that shows the joint, the dotted line is the joint reaction force. So what it signifies is when the knee is flexed, the center of gravity and the joint reaction force is on the posterior side. When the knee is extended, the joint reaction force is on the anterior side. So suppose the center of gravity is on the posterior side, to compensate for that, the quadriceps muscle has to act. If the joint reaction force is on the anterior side, to compensate for that, the posterior muscles and hamstrings have to act. If they don't act, we'll fall. So if we see the stance phase, so the lower diagram is for the stance phase. So there's a heel strike, there is a mid stance and the toe off phase, 1, 2, 3. So if we see, whenever in the position 2, in the mid stance phase, the knee is in flexion around 20 degrees. So that's where the quadriceps and ACL have to act. And when the ACL is deficient, this function is lost. So there is a chronic quadriceps weakness in the mid-stance phase. That's why we see so much of quadriceps atrophy in ACL deficient patients. And the reason for this is the quadriceps force is lost in this mid-stance phase. The same can be seen here. The ACL forces are maximum in the mid-stance phase at 20 degrees of flexion. This is again a very important concept which is which is often overlooked. We neglect this theoretical aspect, but it is very important for our clinical scenarios also. So this is nothing but the force length or stress strain graft. That means how much force is applied to an ACL ligament and how much fiber length changes. So if we see that maximum portion, the ACL is slack. However, in a narrow range, there is a force increase happens. And once the force reaches up to a threshold, after that it fails. The same plot is magnified here. Generally we see these stress strain graphs, and the slope of the curve is nothing but the stiffness that we see, that we calculate, that is the elastic modulus. So if the graft is too vertical, it is stiffer. If it is too horizontal, it is elastic or less stiff. So based on these concepts, let us see how the graft length and graft diameter is important. So in the first graph, the graft diameter, we have doubled it. We have increased, suppose the diameter, we are comparing the 5 mm graft with a 10 mm graft. So what changes in this? The stiffness changes. If you see, the slope is 2x more in a thicker graft. However, the length remains the same, because if you see the femoral and tibial attachment site, the length is the same. So the elongation failure length is the same. However, the stiffness is 2x more. This second graph is very important, which is often overlooked. We always calculate and see how much is the force to failure in newtons, but we overlook this length aspect. So if we take two equally thick grafts of equal diameter, and if we change the length between the femoral and tibial attachment sites, the stiffness drastically changes. So in the first diagram, the length is suppose x, and if we increase the length to 2x, the stiffness reduces by half. So this is a very important concept in the sense that if we change the femoral or tibial attachment sites, if we make the tibia too anterior or make the femur too posterior, we are increasing the length of the graft. So if even if we use a 10 mm, 11 mm, 12 mm, we are reducing the stiffness of the graft. So that's why these attachment sites are so important. The third important concept is the quality of the graft, whether we are using a parallel fiber grafts or a crisscross grafts. So if we see equally thick graft, suppose and one is a parallel fiber like our ACL, MCL, and if we use a crisscross graft, suppose we use capsules as a graft, the stiffness drastically changes. So even if the diameter is equally thick, if we use a crisscross graft, the stiffness is very low, it is more elastic. And the same can be seen in the lower diagram where we are comparing the MCL with the capsular structures. The stiffness of the capsular structures being crisscross is very low, it is more elastic. And hence the slope of this stress strain graft is drastically reduced. The next important concept which is often overlooked that I have mentioned is the attachment sites. Why it is so important, which you are going to learn today and tomorrow. This is the reason for this. So in these diagrams, let us go one by one. In the first diagram, the plus mark is the attachment site on the femur. On the tibia, we are changing the attachment sites. So the M is medial tibia, lateral tibia, anterior tibia. +1, +2, +3, +4, +5. So +1, 3, 5 are more medially. +2, 4, 6 are more laterally. So even if we err on the tibial side, if you see the graphs, there is not much change in the fiber length. The fiber length is pretty much the same. So if you want to err on one aspect, we can err on the tibial aspect for the fiber length. But there are other problems like notching, flexion deformities, other problems are definitely there. But the fiber length remains the same if we err on the tibial attachment sites. But we should not take home this message that we can err on the tibial attachment site, but the fiber length remains the same. But if we shift to this right diagram, if you change the position of the femoral tunnels from anterior to posterior, see the drastic change in the fiber length. So we are absolutely, if we err on this aspect of the femoral ACL attachment site, we are changing the stiffness of the same diameter graft drastically. That's why it's so important to absolutely perfect and to be absolutely accurate in the femoral attachment site anteroposteriorly. If you err from superior to inferior, still it is slightly forgiving. It's not that bad like your anteroposterior erring, but still this is forgiving. Still there is a change in the fiber length. So one take home that we should from this talk, that we should be absolutely accurate in the femoral attachment ACL tunnel locations. Coming to the graft options, we all know what we generally use here is autografts. We seldom use, we are not using the allografts. There's a quadriceps patellar bone graft, there's a hamstring tendon grafts, there's a patellar tendon bone grafts. So based on this stress strain plots, a lot of studies have happened and they have calculated the load to failure and stiffness. So to just conclude from this graph, we can safely say that the quadriceps and the patellar tendon bone is the stiffest compared to the native ACL. However, the hamstring, suppose we do a 4-strand or 5-strand or 6-strand, though the stiffness is low, the load to failure is the highest compared to the native ACL. The native ACL has a load to failure of around 2,100 newtons, but the stiffness of the quadriceps and the patellar tendon bone is the highest. So if we compare these graphs anatomically, so we have seen the load to failure, we have seen the stiffness, but the surface area is also very important. How much surface area we are able to replace. So if we see the surface area, the quadriceps tendon surface area is the highest. That's why it has come in, more and more people are using it because the surface area of the graft is the highest. The surface area of the patellar tendon bone is the lowest. The hamstring graft, the advantages is we can use a 4-strand, 5-strand, 6-strand based on the person. But the disadvantage is sometimes we get a too thin graft, sometimes we get a too thick graft. That's why the thickness is the limiting factor. Coming to the biomechanics, we have already seen that the quadriceps and patellar tendon bone is the stiffest and the hamstring has the maximum load to failure. The graft incorporation, obviously the bony aspect will have a better incorporation. So patellar tendon bone or quadriceps tendon bone will have a better incorporation than the hamstring tendon graft. So one take home that you should take from this CME is to accurately place your femoral and tibial attachment sites. We should not overlook it. We should be absolutely precise in these points. Thank you, sir.
Thank you, sir, for the excellent talk. We will now see and learn the technique of harvesting different types of grafts from eminent members of a faculty. To start off, I call up on stage Dr. Vikram Sapre to speak about BTB harvesting techniques and diagnosticscopy. Thank you, sir.
Thank you, Tejas. Thank you, Aashay, and the organizing committee for organizing this wonderful conference. Good workshop here. A lot to learn from here. I'll be talking on knee scopy and BTB harvest. There will be some repetition definitely, but since Aashay has said ki you should, repetition is good. So I'll just go through a diagnostic round, only a video. Yeah, so first, as Dr. Sarthak has already said, and Dr. Neha and Dr. Tejas have already said about the anatomical landmarking. So first, most important thing is marking the anatomical landmarks. First of all, marking the tubercle, then we mark patellar tendon and the patella. So I generally do surgery in hanging position. So here comes the anterolateral edge of the patella, anterolateral portal. Then you mark the anteromedial portal. Generally, I have my anteromedial portal slightly higher than anterolateral portal. So we will see how all the 6 portals are made. Then marking here for the superolateral portal and superomedial portal. So mark the patella, and 1.5 centimeters above that will be superolateral portal. So once we have marked all the 4 portals here, then we see, yeah. So then we see and for the posterior portals. So these are the 4 portals that we make, and the 2, one posterolateral portal and one posteromedial portal. So as we have seen earlier also, the best way to see posterolateral portal and posteromedial portal is by transillumination test. So here we do anatomical landmarks. We first mark the fibula, and we palpate for the nerve, common peroneal nerve we have marked here. Then that's the biceps tendon, and you also mark for the inferior, palpate for the inferior part of TFL. So you palpate that, and in between the two, so your posterolateral portal will be anterior to biceps tendon. Then coming to the medial side, this is the joint line, mark for the distal femur. So running slow. Yeah. here comes our posteromedial portal. Once you have done anatomical landmarks, then I usually make a vertical portal. It's personal choice. You can make up a vertical portal or a horizontal portal. This video is running in patches. Okay, it's running and slowly. Yeah, once you go in the suprapatellar pouch, there's the normal diagnostic round. Yeah, so then you see the patella. Once you are there, I generally go over the medial femoral condyle, then you come down. Yeah, so once you see the medial femoral condyle, come down. Okay, so from here you start going into the, once you are there in the notch, then you go in the medial compartment. Yeah, now it's working well. Once you go in the medial compartment, see for the medial meniscus. From here itself, you can go into the posteromedial recess, posteromedial space you can go. And you can assess for if there is any ramp lesion or the posterior lesion. So here we'll see how to make a posteromedial portal. So once we are marked, it's the point is 1 centimeter posterior to the joint line. So you see a needle coming out there, and you can adjust after once you have seen with your needle. So if you think that it's slightly lower down, you can adjust it slightly higher, or you can change the position. This is the transillumination test, where you dim your lights, external lights, and then you can see your posteromedial portal. And then you can come through the posteromedial portal, the point where you have marked, and come into the joint, and then you can see. So this is the best way if you have issues with the posteromedial portal, using a transillumination test. Coming to the lateral joint, similarly you can assess in the posterolateral space. So once you are there in the posterolateral compartment, this is the posterolateral space. The point from where we have marked, you can enter, place a needle, and see for your posterolateral portal. Similarly, as we have done with the posteromedial portal, we can do this posterolateral portal with a transillumination test. You dim your lights, figure of 8 position, and then you can clearly see where you have to go. You can see the veins also here, so you can be slightly away from the veins. So once you see this, yeah, so you can place your needle, and then you can see the needle coming from the posterolateral recess. Once then your anteromedial portal. Once you have made your anteromedial portal, place the needle, check, verify whether its direction is proper, and then place a portal out there. I try to have a smaller portal and dilate it with a scissor or an artery forceps, and then your probing comes. So when you are doing a diagnostic round, always try to see from both the portals. Anterolateral portal, as your diagnostic round is not complete until unless you see it from both the portals. So here the viewing portal is the lateral portal. You are probing the meniscus, probe the superior surface, inferior surface, see all the things on the medial side, cartilage, meniscus, then come in the notch, then in the lateral compartment, palpate for the meniscus, superior surface, inferior surface, see for whether if there is any tear. Try to keep the camera in anatomical position all the time. You can see the popliteus tendon there. That's the popliteal hiatus. You can see. So this completes the lateral compartment. Also see for the cartilage on the lateral femoral condyle and lateral tibial condyle. once you complete your lateral part, then we can go again in the suprapatellar pouch and see for our supramedial and superlateral portals. So once you are there, the point where we have marked our superomedial portal, yeah, you palpate it with finger, you can see the movement on scopy, place the needle there, yeah, you can see, here comes your needle. So this on the superomedial and superlateral portals, you can adjust and place wherever you exactly want to. So you have to locate that with the needle, and you can change the position depending upon what your procedure you want to do from there. And this goes the superomedial. Place a needle out there. So this is important if you are doing synovectomy and all the procedures, so you need to know all the 6 portals. So yeah, here comes your needle, and from there you can make a portal, you can place a scope there, or you can place an instrument out there. So when your scope is in the lateral portal, anterolateral portal, from there itself you can go down into the lateral gutter. Yeah, after you have done this, you go to the lateral gutter, you can go down till the, you can even see the good popliteus tendon out there. You can see the popliteus tendon there. This is the popliteus tendon. That's the popliteus hiatus of meniscus which we are seeing. So that's the popliteus tendon. And yeah. So this completes our complete diagnostic round, and you can see all the 6 portals you can make with this. Okay, so now coming with the other topic of BTB graft harvest. We have already discussed, Shushruta has discussed various graft options. So coming to the BTB graft harvest, when you are harvesting the graft, first of all thing is you assess the length of the graft, the tendinous portion of graft that you are getting. I think this is the only graft where you can calculate the length before itself. So you calculate the length, assess the length, what you will be getting. So you can calculate on your MRI itself. Okay, so this was a case of revision ACL. You can see a pivot shift. So here there are various type of incision that are used for a BTB harvest. Commonly used an oblique type of incision. You can also use paramedian incision. Generally the large incision, central vertical incisions are not used. You can take oblique incision, and basically you have to work through a mobile window. You can, when you place the knee in the extension, you can harvest the patellar part of the graft, and in flexion you can harvest the tibial part of the graft. So you have to make it a mobile window of that skin incision where you can harvest that graft. So the other thing is you have to be conscious there about the nerve damage for the paresthesia over there. So you try to take oblique incision or small pyramidal incision rather than, sorry. Yeah. So once you have placed this incision, so once you have placed the incision, you have to 4 retractors can be placed. We usually take a 10 millimeter of the graft tendinous portion. While you are incising this graft, take the knee to 90 degree of flexion. Whole of the tendon should be taut, so that you cut along the line of those fibers. So once you have cut the tendon 10 mm, then you start cutting the bony part. So you have to cut this graft will be around 20 millimeters of length and 10 millimeters of the width. So you have to cut it on the medial side, lateral side, distally. The angle, generally what we want is a trapezoidal type of graft. So you cut on the medial side with a slight angulation, about 60 degree of angulation. You are not able to assess that. So slightly angulated on the medial and lateral side. The other thing that we do on the tibial part of graft is that we try to harvest a tongue of the tibia, addition to the tibial bone plug. The advantage of the tibial tongue that we can get is it helps us in if there is a graft tunnel mismatch, it helps us in reducing that. So once you have done that, here we are going on the medial lateral side, and then this is the part of tibia bone above the insertion of tendon. So here you can get at least 15 to 20 millimeter of length also, additional length that forms the tongue of the your tibial part. Once you have cut it from all the four sides, then you just have to use an osteotome to just take the graft out. Then you place the knee in extension, and you might have seen these two holes what I am showing there. So these are the two pre-drilled holes that we have already made with 2 millimeter of K-wire. This is placed in full extension. You give a traction on the inferior part of the graft, bring that into the mobile window and cut it from superior, inferior, medial side you have to cut, lateral side and the upper side, and then on the inferior side you have to cut, and then we are able to harvest the graft. Once your graft is out, I try to get the bites, suture bites, circumferential bites. You can see here through the two drill holes that we have made. Yeah, so this is the final graft that you get. Yeah, so you have two sutures placed circumferentially. The tongue which you can see here, this helps you in minimizing the graft tunnel mismatch, and that one is the patellar part of the graft. So this completes our harvest of the graft. Thank you.
Thank you very much, sir, for the detailed and illustrative lecture. I now invite Dr. Sarthak Patnaik to speak on hamstring graft harvesting and preparation.
Thank you. To start with the hamstring graft, like once I again request everyone, try to feel the tibial tuberosity, the tip of your tibial tuberosity. Yeah, once you feel it, and now take your thumb. Just try to feel the distal crease, the interphalangeal joint. So this much of thumb you need to keep at the tip of your tibial tuberosity when it's where it starts. There is a slope. Don't count the slope, just when the slope ends the tip. So that is one thing what you can do before you start. Put the tip just on top of your tibial tuberosity, and then crease of your first or the distal interphalangeal crease, just try to mark a pin. So that is equal to where your normally your graft is there. So once you do that, you take an incision. It can take a small incision. Again, there are a lot of debate between taking a vertical incision or an horizontal incision. But what I do, it's a vertical incision, and my incisions are quite small, which I take. So once you get inside, once you palpate your thing, once you take the incision, remove the fat tissues. I'm sorry, I don't have those steps here. And then use a peanut gauge, and then try to clean all the fat tissue till you reach the capsule or till you reach the sheath. Once you did that, you can roll your fingers and try to feel both the tendons, the semity and the gracilis. Sometimes they're not easily felt on the tibia, on the shin border of the tibia or the medial border tibia. So slightly enroll it, so you can feel on the medial, posterior medial border, you can feel the both the tendons, the semity and the gracilis. Once you feel it, then take your 12 number knife and give an incision. Just try to do in between of them, or just to give on top of it a big incision, so that you know you can push here. Then what you need is your 90-degree artery, the 90-degree artery you need, and then just try to slide between these two grafts, touch the bone and then elevate it. So when you elevate it, this is where this starts. So when you elevate it, now see, this is how I elevate it, and I'm trying to bring both the tendon, both my hamstring and thing. I generally do with a small incision. This is what thing. So once I do this, try to see them properly. Can you see? I'm trying to. You can see both the semity and the gracilis graft together. I'm trying to hold it and go more better by it and try to. I'm pushing it. Once you do this, retract your thing and then use another artery forceps to go between the interface between the semity and the gracilis. Generally, as we all know, gracilis is on top and semity is beneath, right? So once you pass your artery forceps like that, not in the beginning but slightly posterior, you tend to get that gap, and once you do that, push your artery gap. Push your artery like this, and then you know, and then remove your 90-degree and place it just beneath. Once you get this semity, try to pull it. It won't tear, just pull it so that you know you reduce it, and then the most important is pass this thread. Always do this step, because if you miss it, it's a very tensed hamstring. It tends to go back, and once you do this, this is where you see, I try to take it again, give it to your assistant, let him hold this, use another artery forceps, take your gracilis up so that you don't, it shouldn't come in on your way, and you keep both the tendons separately. I generally do an all inside ACL reconstruction. That is why I think for me only the semity is quite enough. So I go ahead and try to remove the other vinculas. So generally the gracilis doesn't have vinculas. Sometimes maybe in 50 or 60 cases you will find one vincula, but how do you, but the semity are always attached with vinculas. So they will be either in the superior surface attached to the semity tendon or the inferior surface. So once you go that, you should always try to remove the hamstring graft from the periosteum. You shouldn't go, because suppose you're doing a screw technique, not an all inside technique, you know, you need good amount of periosteum attached to your semity graft. So once you do that, try to do this, use your assistant holding the tendon, give it slight amount graft. You try to remove it from the complete base, and once you get it, trim. Now comes the stripping. So before this, I'll just like to show you, there is one artery which is holding the tendon. That has to be done. Your stripper, when you insert your stripper, always be careful, don't give your assistant midway or anyone in midway, because if they don't hold it properly, the graft, it just cuts the graft. It has happened to me once. So when you put the stripper, there is an open surface and there is the smooth surface. The smooth surface always goes away from the graft. So if you see this, you see how I have been removing it. So once you do this, push it, and there's an artery which is holding it, and I push it inside and slowly. So to remove the graft, there are two types. One, you hold a firm thing and push it, whereas some, like as I've been trained with Dr. David Rajan, my teacher has taught me, you know, you give slight push and pull and slowly push it, push and pull and slowly push, and you get a good graft. And then followed by diagnostic. I'll just continue with this. This is, sir, I wanted to show this case. Sometimes what happens, this is, the patient varies, as I told you. You won't get a good, very sporty person. And you know, hamstring grafts differ in sizes. Like if it's a short female or an obese female, or it's not female but male also, you tend to, the graft size differs. The graft becomes more shorter and thinner. Like just in this example, just say, I got this graft, but can you see the thickness of the graft? It looks very thin, right? The condition doesn't look good. I was doing it for this workshop. But suddenly, while I was doing that, it got toned. Now, what to do? The thin. Now, what I'm doing, as I'm showing you, this is a very tricky situation. So, one artery should be always at this, and the other straight artery should be which you're holding, in which you're trying to pull it. Then again, you pull. Just see how I will suffer. One, I'm trying to push it. It's a slightly tight because a lot of fatty. I have removed all the vinculas, but then, sorry, did it slip? Sorry. So once I'm trying to, just see this, once I'm trying to bring the graft, to harvest the graft, And when I'm giving a small amount of pressure, the graft, even if after going something, it gets just stone. It just comes out. So here I got a very small and thin graft. You can see when I'm trying to prepare the graft. So how do we prepare an all-inside graft? We try to give it a quadruple size. We hold the two ends together with this tension. I will be showing in another demo. And when I do this, I'm slightly skipping my thing. I don't want to repeat. I went ahead with this, and so this is how you do. So when I try to do this, can you see the diameter is only 7. So this is a very tricky condition. So you should remember, in your initial stage, don't do an ACL reconstruction with a 7 mm diameter. That is my advice. There might be surgeons who must be doing with 8, but for me 7, I have never done with 7. And then I took a peroneus, which Dr. Aashay will be doing, and you know the graft technique, as you see, just see this, for an all inside, we try to hold the end of both the harvested graft, stitch it, and both your buttons, you can use a tightrope or any suspensory ligament buttons mostly. Once you do that, once you stitch it, both the thing, yeah. So we start giving the tension, then we focus on the femoral side and the tibial side. So as we all know, what the diameter we look for is around 8 minimal, and the length we look for around 6 to 6.5. So when you take, this is I failed in my earlier semi-T graft, so this is my peroneus longest graft, so it looks very fat. So, and now you can see, so I keep 2 centimeter over here, 2 centimeter from the tibia side, both side, and the bite has been taken completely, because this is one of the things which holds the graft together, and both the buttons, all the suspension in the tibia and the femur side are hanging on the other side. And can you see this? This is the femur side, and now this is the stitch which I am taking at the tibial side. So here my graft is ready, and now I get a good graft of around 9 mm, which is good. So never, why I showed this video along with my previous video, never compromise. And you know, a patient won't leave you if you are doing a 7 and he or she re-tears it and come back again to you. So take your time, go ahead with 9. Sometimes we get to come across such situation. So length is important. We need around 24 to minimum 30 to 3/4 it or quadruple it. Double, triple, quadruple, it depends upon the demand of the patient. Diameter minimum of 8, don't compromise. Graft length 6 to 8. If you are doing a screw fixation, you need around 8 to 8.5. Tension, like once you prepare a graft, give it in tension and start working on your knee scopy. Fixation, you can do with loop, button, suture wheel, with your choice. We will be having Dr. Naved who will show you all inside technique, which even I do. It's a very nice technique. So the take-home message is proper position of your incision. As I told you, use your thumb, measure your thumb, take a scale and see so that you don't forget it. I know my thumb size. Palpate the tendons. Sometimes initial days God is good with you. It gave me thin skinny patients, so I was able to palpate it from the skin itself. And then inside use your index finger, which is very important. Then nick over the tendon and then use a 90 degree. Always keep it with you. Don't use this artery, don't compromise by it. Semity and gracilis must be prepared before harvesting. You try to differentiate it, and don't, now the question comes internal bracing, which has been there. Yes, internal bracing is good, but always all total graft is far better than using a semi-T brace. And tie the tendon with ethibond and 2 arteries forceps, and these are things we should keep. Thank you very much.
Thank you very much, sir. What we'll do is, like the previous session, we'll keep some time for comments and question answers at the end of the session, so that we can have a good discussion at the end and we don't lose our time for discussion during the session. Now that we've learned how to harvest different types of graft, one also needs to be very thorough in their concepts regarding selecting the correct implants and the principles of fixation, so as to ensure that the harvested graft is fixed properly to the bone. A sound technique backed up by a good knowledge and principles ensure a long-term outcome for the reconstructed ACL. We have Dr. Aditya Bothra with us, who will help us learn about the principles of fixation and implant options in ACL reconstruction. Welcome, sir.
Thank you, organizers, for the opportunity. I will proceed with my talk. Now, there are multiple implant options, from the loop to the mill screw to the bio screw and interference screw. But what is the biomechanics behind all these things is, and that is very important, is we have learned that Suchrita has talked about the failure to load Newton about 4,000, 3,500, about the different grafts. But what is about the fixation? It is just about 150 to 500 Newtons. And that is very important, because if the fixation has load to failure of 500 Newtons only, so we need to be very slow in our early rehabilitations for initially first 6 weeks. If we don't do so, we will fail on the fixation part. There are 3 S concepts for the principles of fixation, and that is, first is it should be strong enough to avoid failure, it should be stiff to provide the stability, and secure to prevent from the slippage. That is what is our goal of ACL fixation. But obviously, anatomic. Sushruta has talked about all these things, and we all know that if the graft is more than 10 mm, a single bundle acts like a double bundle. Key to success is the anatomical tunnels. Sushruta has told about that, and 3S. We all know that anteromedial bundle predominantly acts, it prevents the antero-posterior translation, so it gives us the stability for the drawer test, and posterolateral is for the pivoting. Now, this is a very good point from the Arthroscopy journal, that anatomic anterior ACL reconstruction, we should consider 2 to 3 points. In spite of the tunnels, there is one important point, is that notch width measurement. If the notch width is more than 18 mm, we can use a bigger graft, and we should go for the bigger graft, more than 8 mm preferably. If it is less than 18 mm, we should, because there may be impingement, so we should look for the graft of around 8.5 to 9. Now, the types of fixation. One is the suspensory, and another one is the aperture fixation. Suspensory has 2 parts, cortical and cancellous. It is bone to graft area more in the suspensory fixation, so heals nicely. Graft and length can be preserved, bone can be conserved, as in all inside technique, but has its own disadvantages. There are 2 types of suspensory fixations. One is the fixed loop and adjustable loop. Fixed loop is the first generation, and adjustable loop is the second generation. But what is most important thing is, fixed loop being the first generation, it increases the area of suspension. So graft movement in the tunnel is increased. So even after fixation, final tensioning is not possible. And if we are doing any miscalculations, there can be bungee effect. We'll discuss about the bungee effect. So this is what the bungee effect is. So the graft diameter we have tunneled around 30 mm. The 7 mm, around 7 mm of space, we are creating a dead space there. And that is the suspensory part that will lead to the bungee effect. So what is the bailout option from the bungee effect if we are getting, in our cases, to add on extra button, and that we call it as the on button to our fixed loops. It is biomechanically proven to be superior to the adjustable loop devices. Now the adjustable loop, the more advanced part, and it was designed to reduce the dead space. Single and smaller graft can be used. Final tightening after graft fixation can be done. Bone conserving. But adjustable loop is no exception to the tunnel widening, because it is well proven that it lengthens to the cyclical loading and inferior biomechanical stability. So still the gold standard comes to be the fixed loop devices. Now comes the another part, and that is the aperture fixation. It is the compressive type of the fixation, reduces the graft movement, but it also damages the graft. Fixation at the joint level, biomechanically proven to be the more superior construct compared to the suspensory. Now why it is called as the interference screw? Because it interferes the gap between the graft and the bone. That's why it is called as the interference screw. Now factors which are influencing interference screw fixations are the length, size and geometry, divergence of the screw, torque of the screw, bone mineral density and screw material. We'll discuss it one by one. What about the length of the screw? Longer the screw provides better the stability, and in bone tendon bone graft, we have to only engage the bone plug, not the screw. So we can use a smaller length screw also. The size and geometry is well proven, and it is given that increasing screw length improves fixation strength more than oversizing the screw diameter. So our interference screw should come to the tip of our tibial tunnel. What is the ideal interference screw? It should be conical in shape, reverse and blunt threads, and the pitch should be more proximally than the distally, so that it engages the cortical bone. What are the advantages of the bioscrew? We all know that there is no need of removal, doesn't interfere with the MRI, revisions are easier. But there is one very important aspect with the bioscrew, that after 6 weeks, there may be 80% loss of the strength and 60% loss of the stiffness, and tunnel widening is more with the bioscrews because there is resorption started and it leads to the tunnel widening. There are other complications with the bioscrews: breakage, tissue reaction, and fixation lost after the partial degradation. Now, an important concept about the bioscrews or interference screw, whether to use the conical or the cylindrical screw, it is well proven that the conical screws, they perform better than the cylindrical screws. We have to be aware about the screw material. That is very important. Polyglycolide absorbs early, and that's why loses the fixation, leads to the bungee effect as well as the wind viper effect. So crystalline polylactides, which are recently are also called as the PLLA, along with the beta TCP screw, most of them are called as the third generation screws, or we are using most of them. This we have already discussed. Now what about the screw placement? Whether to go for the concentric placement or the eccentric placement, there is no biomechanical difference between the fixations. But definitely, the eccentric one is the preferred one. The reason being, if we put the concentric one, it damages the graft more, first thing. Second thing, we don't get the trajectory for the graft. So what is the ideal screw placement? In the tibia, it is predominantly the posterolateral tract. You can see on the MRI that if we have kept the screw anteriorly, we have loosened the graft, and if we have kept it posterolaterally, the graft length and tension is maintained. Screw insertion torque, it is a very important point, depends on the bone mineral density, tunnel preparation, and directly proportional to the stability. Because our weakest point of fixation is the tibial fixation. Poor bone quality because we are fixing it away from the joint line, which is the weaker bone. Technical tips are very important for tibial preparation, we will discuss it. So what is the key to prepare the tibial tunnel? That we should always use specific reamers while preparing the tunnels. We should use the fluted reamers for the tibia and the flower tip for the femur, because flower tip ones are the bone extractor and the fluted ones, they are the bone impactor ones. That is very important, first thing. Second thing, we should under ream by 2 mm. Supposedly, if our graft diameter is 10 mm, we should ream up to 8 mm only and then use a dilator so that we compact the bone, so our screw will have a greater torque as well as the greater stability. Divergence of the screw. This is very well known fact and must have happened to all of us. Acceptable limits are 10 to 15 degree. So what is the key point to avoid the divergence of the screw is that always insert the guide wire before inserting, tibial guide wire before inserting the graft, and keep it posterolaterally. Look at the guide wire through the scope so that your screw goes properly. Hybrid fixation. Now the term comes hybrid because the interference and the post fixation both has been shown to have the wind viper as well as the bungee effect. So here comes the hybrid fixation, which is post as well as the interference fixation. But it has not been, scientifically it has not been proven to be more superior to any of the either interference or the post fixations. Now the term we were talking about is that the bungee and the wind viper effect. Bungee is the sagittal movement of the graft and wind viper is the horizontal movement of the graft. So to avoid the bungee and wind viper effect, the tunnel preparations should be under rimmed and they should be prepared nicely and anatomical, and the screw placement should be perfect. So here comes the modified all inside ACR. In spite of all these things, there was still happening there was still incidence of the bungee effect as well as the wind viper effect. So there comes a modified technique for all inside anterior cruciate ligament reconstruction, and this one is called as upper fix system. So what is upper fix? It is not suspensory. It is not it's like a tenodesis. So this is the system where we pass the tendon through the screw and lock it over the femoral tunnel. The another advancement in this is the exo-shape system. It is an anatomic soft ACL reconstruction through the tenodesis screw in the tibia as well as the femur. What is the ideal strength of fixation? Whether to go for the suspensory with the aperture fixation or for suspensory above and suspensory below, like all inside ACL reconstruction. And this is the recent paper from 2021. Over the short term outcomes are not different and they are the same in both the fixation systems. But still, the take home message will be here: prepare tibia properly, be aware of the screw material, femoral suspensory and tibial interference still remains the preferred fixation system. Thank you.
Thank you very much, sir. Now that we have a sound background of the principles of fixation and the various implant options in ACL, the other important thing to learn is the creation and accurate placement of bone tunnels, as it is one of the most important part of an ACL reconstruction surgery. An ideal tunnel not only helps in the proper orientation and alignment of the graft, but it also restores the biomechanics of the knee and contributes to the longevity of the reconstruction. So I now request Dr. Siddharth Jain to enlighten us on the ideal femoral and tibial tunnel in ACL reconstruction. Thank you.
Thank you for giving me this opportunity. Good afternoon to all of you. My half of the job has already been done because Dr. Shushruth and Dr. Aditya has already told about the importance of the proper tunnel placement for the femur and the tibia itself. So we have evolved from the transtibial to the anatomical positioning of the tibial and the femoral tunnel. So if we see, the tunnel placement is the most important factor for the successful surgery. Why? Because it is the most common cause of the failure of the ACL surgery. If we go through this study, you can see that this study have been about they have studied the cause of the failure of the ACL ligament, and they have seen that in 88% of the cases, there were the non-anatomical graft placement was the reason. In the 61% of the cases, there were the graft were entirely on the intercondylar femur roof, that is the non-anatomical placement of the femoral tunnel, and 35% extended posterior to the ACL tibial placement, that is the malpositioning of the tibial tunnel. So what is the isometric concept? That is the concept is that the full range of knee can be achieved without causing the long-term ligament deformation. Various authors have tried to define the isometric point, but the isometric cannot exist because during the range of the motion, there is no one point on the femur that maintain a fixed distance from a single point on the tibia. So elongation will always occur. In tibia, what is the ideal point? If we see from the inside the joint, the tibial femur we should fix at the 55-degree, seated on the debridement stump of the ACL. So that is, if you see like even after the completing this lecture, the most important thing is you have to take the entry point at the anatomical side, because the every knee is different, and every knee, if you see, no bony landmarks can define the exact position of the tibial or the femoral tunnel. Okay, so the center of the tunnel is at the 7 mm, should be at the 7 mm anterior to the PCL notch, posterior fovea, or the retroeminentia ridge. in the line with the posterior border of the anterior horn of the lateral meniscus. If you see outside, it should be like the 3 to 4 centimeter away from the tibial joint line, or 2 centimeter medial to the tibial tuberosity. Or one more point, that if you have the attachment point of the hamstring, you can take 1 centimeter above to that. So isometric femoral tunnel, you can achieve it by the various technique, by the transtibial center of the tunnel at the over the top position. The center of the tunnel should be 6 to 8 mm anterior to the true back wall, that is the extreme posterior cortex at the junction of the roof and the lateral wall of the femoral intercondylar notch. This will result in the 1 to 2 mm proximal cortical margin. But we have already shifted from the isometric point to the more anatomical point. Why? Because now we know that the graft plays as closely as possible to the center of the tibial and the femoral attachment of AM bundle. This will result in the least amount of strain, least change in the length of the ACL during the range of motion. So this you will see in this diagram, you can see that if you go through the transtibial tunnel, if you go through the transtibial one, so you can see it will be more on a higher side. It will be deep. So this we called is normally as a shallow, this one is deep. This we normally call this one part, the distal part we normally call as a shallow one. This is the deep one, this is the higher, this is the lower one. The anterior one will be the higher and this one is the lower. So this is the terminology which we normally use for the placement of the femoral tunnel. So you see with the transtibial tunnel, it will be more on a like deeper side and on the higher side. So that won't be an anatomical one. So a femoral tunnel position inside the anatomical footprint of the ACL will results in the knee kinematics closer to the intact knee than does a tunnel position located for the best graft isometry. So we know that the anatomy is more important than the isometry. Anatomical ACL better restore the anterior translational as well as the rotational stability. So we can use the clock position also. Then the 10 o'clock position is more effectively resist the rotatory load when compared with the 11 o'clock if we are talking about the right side of the right knee joint. So it is the 10 o'clock position more effectively resists the rotatory load when compared with the 11 o'clock position, as evident by the smaller anterior tibial translation and higher in C2 forces. But the clock concept is easy to use, however it is inaccurate in describing the location of the femoral tunnel placement and lead to the non-anatomical positions. So what is better? Anatomical, definitely anatomical ACL reconstruction is better because it provides a better rotational stability, and sometimes we don't know, it decreases the risk of the osteoarthritis also. So first we go relook the anatomy of the ACL. If you see, ACL is divided into two bundles, anteromedial and the anterolateral one. Each bundle is named after its tibial insertion site on the like anteromedial and posterolateral. The anteromedial and the posterolateral differ in their length, width and the insertional area. In every aspect, anteromedial bundle is larger and wider than the posterolateral bundle. So if we go through the tibial attachment, it is always very variable. Sometimes you see the anteromedial and the posterolateral bundle, they are just behind to each anterior or posterior to each other, or sometimes they become so much parallel to each other. So it is not always like the anatomy will be same at for every knee. It will be different. So we have to choose, but still we have to choose some point, because not in every case we can get the proper footprint of the ACL. So there will be some point, we have to choose some landmarks. So this is the anterior margin of the PCL. These are the studies which have shown like how much anterior we can take our tunnel in the sagittal plane from the PCL. The other landmark is the lateral meniscus. So the posterior edge of the anterior horn of lateral meniscus, normally we draw a tangential line along with the posterior margin, and we normally believe that it is just anterior to that tangential line. The other landmark is the tibial spine. So it is, if you draw a line from the most prominent part of the medial tibial spine, normally your center of the tibial tunnel should be 4 to 5 mm anterior to that. So is it like the single landmark can be correct? No. Anterior horn of the lateral meniscus, it is a very easy landmark that we can just see while scoping the knee joint through the anterolateral portal, but still you can see every time the anterior root of the lateral meniscus, it is in the different knee, it is again in the different position. Sometimes it is very near to the ACL, sometimes it is very far away from the ACL footprint. So it is always like a single landmark, on a single landmark, we cannot believe. Okay, the center of the ACL tibial attachment is almost 9 to 10 mm behind the posterior edge of the intermeniscal ligament, and the center of the ACL tibial attachment is almost 5 to 6 mm anterior from the projected line from the peak of the tibial spine. So as taking all these landmark into your consideration, you can just make a point. If suppose the footprint of the tibial attachment of the ACL is not present over there. So some of the radiographic methods are also available. MS and Jacob line, that is the line parallel to the medial tibial plateau, or the Stabile or the Rosching's line, that is the line perpendicular to the tibial axis. Both the aim center bundle is almost at the 30% which we count from the anterior side, and the posterior lateral bundle is present on the 40 to 50% of the distance if we count from the again on the from the anterior side. Now we come to the femoral attachment. It is more consistent. If you see, this is this I have told already. Suppose if you are considering this one is the posterior part, this one is the anterior part, this one is the distal one, and this one is the proximal one. So we, in our terminology, we normally call it as a shallow. This one is the deep. This is the high. This is the low. This one is the intercondylar ridge, which is again for every arthroscopy surgeon, you should be able to identify the intercondylar ridge. Okay, so this is the pictorial diagram. So if you see that, this is the intercondylar ridge. This is bifurcation ridge, but I doubt like in every case you won't be able to see this. Okay, so just proximal to this is the anteromedial bundle, and posterior to that is the posterolateral bundle. Okay, so what are the useful landmarks which you can use identifying the femoral footprint? The femoral, if you are very lucky, you will definitely find the femoral ACL stump over there. Second is the resident ridge, that is the intercondylar ridge. Best visualization, you can just, whenever you are marking your entry point, you can go through the anteromedial portal, or you can just first mark while seeing from the anterolateral portal, and you can go again to the anteromedial portal and check your position. And if you have that facility of using the 70-degree scope, that is again useful. The other methods which you can use is the ruler method that's already been described. Like if you keep a ruler from the most distal part to the proximal part, and you can just in between to that, you can mark your point. So this method you can also use. But every time you should check from the anteromedial portal. This is again some of the radiographic method described by the Bernard and the Hertel and the other these authors. But only thing is that just now that I think Hiroshi Shima, he has come with a paper in 2017 that this Blumen sets line also have a classification. It is not that straight in every knee. Sometimes it is straight, sometimes it is that small bump is small hill area is there, and sometimes there will be a large hill area. So Blumen sets line is not always a straight one. So these methods are difficult to rely. Again, similar the quadrant methods that you can use if you calculate these quadrants. This is you calculate from this one part, the deep to shallow one, and from the high to lower end. Okay, so whenever you are just seeing from the your lateral portal, so whenever you are just having this picture, just remember you need not to go on the red area. The green area is good for making your tunnels. So in summary, ACL center, that is what the 43% of the proximal to distal length of the lateral femoral intercondylar notch wall, and femoral socket radius, that is around 2.5 mm anterior to the posterior articular margin. The anteromedial center, normally, that is the 29% of the proximal to distal length of the lateral intercondylar notch, and the posterolateral center, 50% of the proximal to distal length of the lateral femoral intercondylar notch. Okay, from the posterior to anterior, the AM bundle appears slightly anterior to the posterior lateral bundle, and both the bundles appear socket radius. This you should always remember that from the posterior cartilage margin, you should always have a 2 to 2.5 mm of the bony margin. Okay, so the femoral tunnel position, you should remember this jingle. This is actually ideal, so you should remember this is it should be more isometric. You should more focus on the direct fibers of the ACL. I will just tell you in the next slide what are the direct fibers. It should be eccentric, it should be more anatomic, and it should be which provides the less tension to the graft. So that is midway between the PCL and the lateral femoral condyle articular cartilage, and there should be a margin of 1 mm on the posterior wall. Okay, so if you see this picture, so just imagine this femur is at, the knee is flexed at the 90 degree, femur is just on the your table. So this is, so I have cleared this. So this one again, this is the higher, this is the deeper position, this is the shallow one, this is the lower end, and this one is the higher position. Okay, so what are the direct and the indirect fibers? So if you go through the ACL femoral attachment, so this area normally, which is more closer to the intercondylar ridge, the ACL attaches with the direct fibers. But on the posterior side, where on the posterior articular margin, the ACL attaches to the lateral femoral condyle with the indirect fibers. So those are the weaker fibers. So we have to focus more on the direct one, this one. So this should be your ideal entry point. So you can make your entry with the owl also, like this, and then you can go to your anteromedial portal and you can check your entry. Sometime what you can do, what I do, I just take a reamer and then I just push it till your entry point, and you can check that how the diameter will come and how much margin you are having on the posterior side. So to make it more simple for the femoral tunnel, the tunnel center should be 40% from the proximal to the distal distance of the lateral notch. It should be centered between the lateral intercondylar ridge and the posterior articular margin. This is a simple point. I have made it somewhat simple. This point you can remember while making the femoral tunnel. Center of the ACL coincide with the distance of approximately 2.5 mm plus plant tunnel radius. Remember, it's not the diameter, it is the radius. Like if you are having a graft diameter of 8, you have to just add 4 plus 2.5. From the posterior articular margin, tunnel center should be centered over the lateral bifurcate ridge. Okay, this is not the lateral intercondylar ridge, this is the lateral bifurcate ridge. Now we come to the tibia. So tibia, if you are lucky, you will get a proper this thing, and most of the time you will get the proper ACL attachment over there. You can measure that in the sagittal plane and the horizontal plane, and then you can decide your entry point. Or if you are having a good stump, you can just in the center of the stump, you can place your jig and you can make your entry. Again, for simplicity of the tibial tunnel, the center of the tibial tunnel should be located 40% from the medial to lateral width of the interspinous distance, and center should be in line with the posterior edge of anterior horn of lateral meniscus. Again, I'm telling you, you have to consider 3-4 landmarks for tibia and femoral tunnel. Tunnel center should be 7 mm anterior to the PCL notch or the posterior fovea. Why it is important? Because then the chances of the impingement from the intercondylar notch will be less. The tibial guide mostly kept at the 55 degree. This is I'm talking about the external, how you have to keep the jig from on the external side where you have made the incision and you have harvested your graft. So the tibial guide mostly you keep it at the 55 degree position with aiming the tip of the intra-articularly at the center of the ACL footprint. Extra-articularly, the guide should be set to the center of the tunnel is 1.5 to 2 centimeter medial to the tibial tubercle, okay, and 1 centimeter above the insertion of the hamstring. So from the tibial tuberosity, you can just keep a distance of roughly 1 finger width or more than that, and again from the hamstring attachment, you can keep a distance of 1 finger width. So if you come to the radiological assessment, suppose if you have done the surgery and you want to assess your this thing, there are some points like if you have to choose the tibial, you want to assess your tibial tunnel and the femoral tunnel. So there are some points like the femoral tunnel. If you are able to mark it, it should not be more than 45 degree in the vertical plane. So it should be around 40 to 50 degree around the femoral tunnel. Okay, so this you measure from the horizontal, the femoral tunnel, and the tibial tunnel should not be more than 70 degree. In the if you are seeing a coronal this anterior posterior X-ray. So this in this way you can measure that. So this angle alpha, it should not be more than 70 degree, otherwise your tunnel will be more vertical, or this angle beta, it should not be more than 40 to 45 degree. In the sagittal, in the lateral X-ray or in the sagittal plane, you can again assess your tunnels. Like if you see, this is the rough idea, if you just draw a Blumenset line, so your tunnel entry should be in the proximal 1/3 part of the Blumenset for the femur, and for the tibia, if you extend this Blumenset line, so your tibial and the intra-articular entry of the tibial tunnel should be posterior to the extension of the Blumenset line. So there won't be any impingement like this. Okay, so this you can get a rough idea of that. Thank you.
Thank you very much, sir. Now that we have all the necessary concepts and ideas in an ACL reconstruction surgery in bits and pieces in our heads, the next step would be to amalgamate all the concepts in ACL reconstruction that we have learned so far. We will now go through a series of real-life surgeries to do so. This would serve as a good revision of all the concepts and help visualize the ACL reconstruction surgery as a bigger picture. I now invite on stage Dr. Abhishek Gadge to take us through ACL reconstruction using a hamstring graft. Welcome, sir.
So, good afternoon to all of you. Thank you, Dr. Aashay, for the invitation, and kudos to your whole the organizing team for such a wonderfully crafted session. So, I will be talking on real-life surgery. Just to give a short information on the patient, this is a patient, a young patient, and he's having ACL tear on the left knee. So, what you are seeing is a knee which is left knee, and my preferred technique is just like a TKR position where I keep the knee on the table in 90 degree with a lateral post and a post at 90 degree to keep the knee at 90 degree. So first first and foremost thing to start a surgery is examination of the knee in anesthesia, just to confirm what you have diagnosed in the operating in your OPD, just to confirm the findings that you need to do a anterior drawer test, latchman test, assess the amount of pivoting you have. In this way you confirm the diagnosis, and this helps in planning your surgery. Then graft harvest. My most preferred technique is hamstrings graft. For all harvest technique, for harvesting, just have a marking of the anatomical landmarks already have been discussed a lot in detail by previous speakers. So after marking the anatomical landmarks, you mark a harvest intended point of incision. You can take a vertical or you can take a oblique incision, it is up to you. Then after subcutaneous dissection, just see this pes fascia, sartorius fascia. You feel both the tendons, semi-T and gracilis. The thing more tubular structure you feel is a gracilis. Semi-T has a more flat fan-shaped insertion. Then with a blunt dissection, dissect out the fatty tissue underneath the fascia, and with a mixture on a 90-degree retractor, take the semi-T out. Then mark it with your ethibond or a non-absorbable suture. With a blunt finger dissection, what I do is I identify the vinculas. Couple of vinculas you find, many a times in aberrant cases you can find an additional third vincula in the semi-T. Then before inserting your tendon stripper, just make sure that you are having an elastic recoil of the semi-T. Then only you insert this your tendon stripper. You can use an open tendon or a closed tendon stripper depending upon your expertise and your preferred technique. So in this case I have shown an open tendon stripper where I didn't took out the tibial insertion. Then after taking out the semi-T tendon, always assess the integrity of whole length of tendon. See that you have not accidentally amputated the tip of the tendon, because in that case the length of the graft, intended length of the graft for ACL will be less. And depending upon the diameter of the tendon, semi-T you try to harvest gracilis if it is very thin, or if you are preferring 5 or 6 tendon graft. So after harvesting the graft, simply do a whip stitches of the both ends. This is a 4-strand graft. So simply do a whip stitches using number 5 ethibond, and then assess the diameter and the length of the tendon. Then here you can see this is a 6 strands graft where there is a 4 strand of semi-T and 2 strands of gracilis. Then using your graft sizer, assess the diameter of the graft. It should go very easily without any amount of graft in the graft sizer's loop or the groove where the threads are, which are made for passing the threads. Then next we start with an arthroscopy. Arthroscopy you have for planning the ACL. The entry portal on the anterolateral portal will be a bit higher portal, we call it bird's eye portal, and the anteromedial portal will be a bit lower one and bit medial one. I take a horizontal incision for a anteromedial portal because this helps me in widening the incision in the femoral over drilling. And in a 90-degree position, and insert your number 18 gauge spinal needle from anteromedial portal. See for the accessibility of your posterior part of the notch where your intended femoral tunnel will be there. In this way you can easily reach the posterior part of the femoral tunnel. Then just have a quick diagnostic round, look for any meniscal pathologies and look for the ACL stump. The ACL stump needs to be shaven off to prevent the graft impingement, but try to preserve the remnant attachment of the ACL. Try to do as more biological without hampering the isometricity of the ACL. Then, for making the tunnel, if you go with go in 90 degree, it will find difficulty in reaching the posterior part of the notch. But when you flex, you can easily assess the anatomical landmark of ACL. See, in this, I have flexed it to 120 degree and then easily go to the posterior part of the notch where the anatomical footprint of the ACL on femoral side lies. There are two techniques where you can plan your, rather there are three techniques. One is outside in technique, and the two techniques, the inside out technique, you can use your owl or a K-wire to make a pilot hole, or you can use an offset guide. I use usually a 2 mm K-wire. So this K-wire, I tap it to create a pilot hole, and after creating the pilot hole, I insert my bead pin over this hole and just check it after entering the bead pin, that whether I am anatomical or not. And after entering the bead pin to both the cortex, then over drill the bead pin with a 4.5 mm reamer. This is usually decided by the type of button you use. Some buttons have 5 mm, some button 4.7. So that your implant guy will guide you which type of reamer you use. Then measure the length of the tunnel. If you are anatomical, your tunnel will be falling between 30 to 40 mm depending upon the type of the patient, type of the bony build. Then after measuring the size, insert your bead pin, and over the bead pin, insert your flower tip reamer. But here the key point is, you can see my scope is pointing towards medial side. In this way, I can ensure that while entering the flower tip, most commonly you encounter is while entering is a scuffing of the medial femoral condyle cartilage. So in this way, you can avoid scuffing of the medial femoral condyle. So just keep your scope direction towards medial side, enter slowly your flower tip reamer. Sorry, what happened? So, yeah, we are back. So now slowly turn your scope direction towards your intended tunnel and then slowly over rim it. How much to over rim? If you are using an adjustable loop button and you intend to put a graft of around 18 to 20 mm inside the femoral tunnel, then 4 to 5 mm of over drilling is enough. But if you are using a fixed loop button, you have to calculate depending upon the type of graft you use and type of button you use. So I am demonstrating here is an adjustable loop button. It is very easy to calculate for the beginners, so it is better for you. Adjustable loop buttons, just more than around 5 mm plus your So, adjustable loop button, 5 mm plus your intended length of graft you need to put. Like 20 mm I need to put inside the femoral tunnel, so I will over drill it with a 25 mm. So, while over drilling, have patience, go slowly. If you find bone debris, wash it out, then again start over drilling. Don't over drill in blind way in order to damage to your lateral femoral cortex. After over drilling, look for your tunnel placement. It is sometimes difficult from your anterolateral portal, so don't hesitate to switch the portal. And look for the integrity of the posterior wall, inferior wall, and look for the lateral wall. sometimes you feel this fibers coming inside the tunnel, which will hamper with the insertion of your graft. So you need to shave out these fibers. Now coming to the tibial side go anatomically, your tunnel should be coming in the line of your lateral meniscus, anterior horn, posterior border. इधर से कुछ हो रहा है. Okay, this one. So this is a lateral meniscus. This is posterior border of anterior horn of lateral meniscus. So your tunnel will be coming in line with this posterior border, around 40% more medial as compared to this dead center, just to avoid damage to your anterior root of lateral meniscus. So this will be your entry point. You can use a tip hammer like this one, or you can use a ring hammer just shown before previously, or you can use an elbow hammer, type of hammer you can decide. But the most important part is to be in the proper anatomical site of your entry. Then once you enter with your beath pin, the degree of degree is usually 55 degree we keep, but if you find your graft is very small, like 70 mm or 60 or 70 mm graft, prefer to go with a 50 degree of your hammer, just to avoid adequate coverage of the graft in the femoral side. Then after entering, after drilling with a beath pin, over drill it with a required amount of reamer. Then with a shaver, gently shave off this fibers, avoiding the intact part of the ACL, just to avoid impingement while graft passage. After preparing the tunnels, just you have to put a loop suture through the femoral tunnel and pull this loop suture from your tibial side. In this way, there is a loop suture from femur to tibia covering both the tunnels. Now graft preparation, I will be discussing about the adjustable loop button. So this is adjustable loop button. You have to do a 2 marking. 1 marking will be on the button. This marking is on the button. It is amount, this is the length of the femoral tunnel. You measure it beforehand, and that length is calculated from the distal end of the button to the loop. So this is the amount of the loop which will go inside the femur before flipping the button over the lateral femoral cortex. This will be the one marking, and another marking will be on the graft. This is the amount of the graft you need to put inside the So second marking will be in the on the graft. This will be the amount of the graft you need to put inside your femoral tunnel. Then I always used to tie the graft over here with a vicryl, just to have a colored marking if accidentally this ink marking washes off with the NS. Then next step is the graft passage. Every button has its own pulling thread. So you have to pull your button with this pulling thread. Like this button has a purple colored pulling thread. So pull your pulling thread till the marking on the loop comes at the edge of the femoral tunnel. So once the marking is on the edge of the femoral tunnel, the button goes. Now the marking is going slowly. Then once it is in the edge of the femoral tunnel, gently give a traction from the tibial side and assess that whether your button is flipped. And after flipping the button, reduce the loop using the reduction threads. You have to cinch the graft, and go very gentle while cinching such that you don't over cinch the graft. And this will be the marking of the vicryl, which needs to go up to the edge of the femoral tunnel. In between cinching, you just try to pull it back. Sometimes what happens is the button cinches, but it again gets loosened up. So after cinching, have a 10 to 20 cycles of cycling, and then fix your button using an interference screw. So if you are using a bio screw like this, go one size up and knee in 30 degrees of flexion. Then assess the integrity of assess the strength of the graft, laxity of the graft. If you find any laxity, you can again cinch it, make it good tight graft, and then you need to assess the impingement of the graft in the notch. Go a gentle extension and look into the notch. So here you can see on gentle extension, the graft should not impinge on the roof, on the lateral border of femoral condyle, and whole of the graft should come inside the notch. Sometimes you can find here a cyclops lesion which can have a post-op flexion deformity. So you have to shave it. Many times it is hidden under the intermeniscal ligament. So when you do this, you can assess it. So that is how you complete your surgery. Thank you.
Thank you, sir. Next up, we have Dr. Naved Ahmed, who will take us through the all-inside technique of ACL reconstruction.
Okay. Good morning. Good morning back there. I know you're hungry. Are you interested? Do you know all inside ACL reconstructions? Have you heard of it? Okay, everyone has heard of it? Okay. So it's a different technique. I've been doing it for the last 6-7 years, and many people do it, and it's very good in my hands. I'm very happy with it. So the talk was about a real-life surgery, but I spoke to Aashay, and I said that it would be better if I, take it not like a real-life, but some tips and tricks kind of thing. So let's see if we make justice to it. You can ask questions. You have to ask questions. Otherwise, there is no good meeting without questions. So till this thing comes up. Yeah, till this thing comes up. If anyone has a question, please ask. Any of the previous speakers, anyone. So, anything in arthroscopy is, I should not be saying, but it's industry driven initially. So it was driven by the industry because the implant is more expensive than a normal screw. But then the ease of doing the surgery, the failure of having any complications from the screws. There were no screws involved, so the complication rates fell. And in my hands, there was a lot of screw divergence always, and it was very difficult to understand which ACL has gone well and which is not, in spite of getting a good tactile feedback at the end. So yes, carry on. So yeah, it was basically because I wanted to reduce the complications of the screw, so that's why I shifted to the all inside. Yeah. Yes. So not in all of them. Suppose you have a single bundle tear. So therein you can go ahead and do an all inside and save the remnant. Okay, so not what you are talking about is the footprint fibers. Yeah, so there will be some destruction, but you can definitely save them. There are tricks of doing that. So as your learning experience increases, your skills increase, you can do that. It's not possible. It's difficult, but not possible. Yes, ma'am. So all my ACL reconstructions are all inside, unless the patient is not affording. So everything is all inside. Even my revisions, I do them all inside. I use a hybrid technique for that, in which the distal part is also suspensory and not a screw. Okay, so the difference is that in the standard ACL reconstruction, you have a screw on the tibia, but in the all-inside ACL, you have two adjustable loop endobuttons at both ends. So the difference, no tibial screw, a suspensory fixation at both ends, sockets, we create sockets rather than tunnels. So you are conserving bone. And the best part is that you can cinch at both ends, even after tensioning the graft at the end of the surgery. So why all inside ACL? Because you create sockets rather than tunnels, less bone removal, less of windshield wiper and bungee cord phenomena. Semitendinosis is enough, so less morbidity. Small graft lengths are acceptable, less functional deficits because you're most of the times removing only one hamstring, and there is less post-operative pain. So there is ample literature support for doing an all inside, be it literature support for suspensory fixation vis-a-vis upulture, be it support for retrograde drilling, which causes less pain, be it comparative studies with standard standard ACL reconstructions, be it early and mid-term results of all inside ACL reconstructions, be it support for post-operative pain, which is less in all inside ACL reconstructions, improved cosmesis, decreased bone removal. In fact, there are histological evidence for superior healing of suspensory fixation methods in animal models compared to interference screws. So you have ample evidence to just go ahead and start doing that. So coming to the surgical steps, the evaluation under anesthesia, the diagnostic round, and graft harvest, I think many of you have seen repeatedly over the day. So what I would say is, in the graft harvest, the semitendinosis is enough. 240 to 280 mm is more than enough. If you have more than that, you have to cut the tendon. You can't make it more than that, because when you quadruple it, I want a graft between 60 to 65. That is enough for me. And a graft diameter of 9 and 10 is very much important. I would sometimes compromise on an 8, but most of my grafts would be always 9 or 10. So graft preparation, if you want to know, it's called a graft link. The graft which you prepare is called a graft link in all inside. It was termed by Lubowitz, who's one of the forefathers of all inside ACL reconstructions. You should go and read this article about how to do graft link preparation. So that's an adjustable loop endobutton at one end, the other at the other end. You quadruple your graft, and then you first suture it with Vicryl. Both the ends, you suture it with Vicryl. And then you start making it. So there are 4 strands. So first you go through 2 strands, then you come in the reverse direction, and you go through all the 4 strands. Then you again go in the same direction again through all the 4 strands. So 3 times you take bites, and then you surround that graft 3 times with the ethibond, or usually I use a 0 number fiber wire. So once you have rounded that 3 times, then you tie 3 half hitches, 2 in the same direction, 1 in the opposite direction. Then you cut the shorter tail, keep it a little big, and then you again go through the tendon, and then you pull that knot into the graft. So that is why this is called a buried knot technique. So this is how your graft looks at the end. And very important, you should always soak your graft in vancomycin, because that reduces the chances of infection to nearly 0. So we have been doing this. You can ask any of my colleagues over here, they all do that, and the infection rates have fallen to near 0. So coming to the femoral tunnel can be drilled with a flip cutter, which is the instrument from Arthrex. There are many other companies with the same kind of instruments now. So you can do it with a flip cutter also, or you can do it with a standard technique, which all of you have seen right now. I usually use the standard technique for that, but you make sure that you have a 2 millimeter bone ridge posteriorly, and you can see the inside tunnel as well. So that's a tunnel-in-tunnel appearance. So the difference starts from here for the tibial, for the all-inside ACL reconstruction on the tibial side. So, but before that, this is another technique that the translateral technique, which is described by Adrian Wilson for the femoral side. So you can also read this article, and if you want to drill your femoral tunnels with a flip cutter, you can do that, because according to them, it's more anatomic. There is no accessory medial portal needed. There is no hyperflexion involved. The reduced chances of posterior wall blowout. You can make your tunnels length according to your requirement, and there are no misplaced tunnels if you position the flip cutter properly. So on the tibial side, you use this flip cutter. So it's an instrument which has a 4.5 mm shaft which goes inside, and then once it's inside intra-articular, then you can increase the size of the blade to whatever size you want. They have a flip cutter 3 now, in which you can have any amount of diameter of the tunnel which you desire in one instrument itself. Otherwise, previously they had flip cutters for 8 mm, 9 mm, 10 mm fixed, but this one you can change the diameter. The tibial jig remains the same, but there is a special bullet for the all-inside reconstruction. If you see, there is a 7 mm step over here, which goes into the cortex of the anterior tibia, so that when you're coming down, you do not inadvertently drill the tibial cortex. So that is how it looks. So this is the right knee. You're looking from the anterolateral portal. That's the footprint jig. So your flip cutter comes inside. You take that jig out. Then you push in the flip cutter, because there is a hinge from where it will bend. So you go and see that hinge, and then you flip it, like so. And then you pull it down to the cortex. And from there, you start drilling how much you decide to drill. That I'll show you in a while. So this is how it looks from the outside. So there's a black mark over here, which you can pull down and see how much you have drilled or how much you want to drill. So once you have drilled it, so there'll be a lot of muck around. Don't worry, you'll have to remove. So you get your flip cutter inside, and then again unflip it, and then take it back outside. You remove all the debris from there, because you want to see where your tunnel is. It's very important to know where your tunnel is. You should always be anatomic. And Siddharth has alluded a lot to the best place for the tunnels. So once you have done that, the graft passage preparation. So the graft is passed not through the tibial tunnel, because there is no tunnel actually, but it is passed from the accessory anteromedial portal. So you have to make the portal large enough so that there is no soft tissue impingement inside. You can use a flexible cannula if you wish, but usually people do it with a virtual cannula. We'll show you how. So you pass a beath pin retrograde with a relay suture, and you take it out from the accessory anteromedial portal with a suture retriever. Then you go through the accessory anteromedial portal with the beath pin as you do in a normal standard ACLR, and then you pass your beath pin and the relay suture into the femoral side. And then you make a virtual cannula. So that suture retriever comes with the tibial sided relay suture, and it takes the femoral sided relay suture in one bite, and then you take it out so that you know that you are in a single soft tissue envelope. Then you mark your graft. So there are 2 marks you need to do. One is on the adjustable loop, which shows the flip distance. That is the amount of femoral tunnel length that you have. So you measure it from here to there. That's called the flip distance. And then from this, the second mark is on the graft, which is the graft length which you want inside the femoral tunnel. Usually it is about 15 mm. So the femoral graft passage, make sure that you keep the tibial sided release suture very taut, because sometimes it gets entangled into this and then you are in a mess. So the other beath pin suture is taut, and you keep the endo button parallel to the sutures. So you make that endo button parallel and then you take that femoral inside. So it's going through the accessory anteromedial portal. And there are 3 ways of how you would know that you have flipped the button. So one is this red mark, wherein you mark your graft with a pen. So you will be seeing that intra-articularly. Second is you should be seeing the button going out. And the third is wherein some companies have flipping sutures. So intra-articularly it would look like this. So that's the femoral sided sutures going in with the button. So you should be seeing the button. Go very slow on this step. Always see the button when it is going into that tunnel. And so that's the first thing you see. The second thing you see is your marking on the sutures. And the third is then you can flip on the other side. So femoral sided fixation, you cinch the graft on the femoral side first. So that is how it looks on the external side. That is going through that portal. And on the intra-articular side, you can see and you can restrict your cinching to the mark which you have made on the graft. In this case, it's this ethibond suture. So the femoral side is cinched. Now we go to the tibial side. So on the tibial side, on the extra-articular side, the virtual cannula will help to avoid soft tissue bridge. And you see how it is pulled down, and go very slow. And then you just pull it out, the button should come out. Like that the button comes out. And if there is an implant called no button tightrope, so you can use that, because in that there is no button, so the chances of impingement reduces. And this is how it would look on the inside when you are pulling your tibial sided graft into the tibia. So those are the sutures. Now you're pulling it from the outside. So that's your graft which goes into the tibia. And then you cinch the tibial sided adjustable loop endo button. Make sure that you see it properly, because I've had an instance wherein the button went into the tunnel. So make sure properly you see it seating onto the anterior tibial cortex. Then you cycle your knee as you do in the standard ACLR. And after cycling, you will always see that there is some laxity which has again come in. So then you cinch the graft again, that is the beauty, and you'll see that it just extends, stretches out, and now it's taut again. So that is the beauty of doing an all-inside ACL reconstruction. So in the end, you tie knots. So what I do is now I make this construct, which is an adjustable loop endo button on both sides, to a fixed loop. I tie it on both the sides, and then I cut it, leaving about an inch of suture there, so that revision is easier just in case. So no surgery is without complications, and the more intricate, the more instruments you use, the more you will have problems, but you have to know how to get out of it. This is an instance where the flip cutter broke inside and we had to remove it part by part. But the take-home message should be that all-inside ACLR is scientifically proven to be at par, and it has less post-operative pain. You just need the semitendinosis most of the times. There is no need of a tibial screw, and the complications of a tibial screw are so not there now. And it is bone preserving and less bungee cord and windshield wiper effect. So that's how you remove a broken flip cutter. Thank you.
Thank you very much, sir. Now, for the last talk of this session, I invite Dr. Tejas Waghela to take us through fixation of an ACL avulsion injury. Thank you, sir.
Thank you. I'll just try to be as brief as possible. Even I am very hungry. Okay. So, what can you see? So this is what happens when you start your ACL avulsions. There's just red everywhere. And visualization is the key in ACL. And so we'll spend just 1 minute on how you will increase or better your visualization. So what we need to do is first put your scope in, give a good thorough wash. The best way to do is let a lot of fluid go in and let it have a tamponade effect. So as soon as the whole thing swells up, the bleeding stops and you keep on flushing it till the time the return fluid is also clear. So this is the first thing you need to do. If you do this for 5 minutes, this will save your whole surgery. Is it stuck on this? No. I gave a wash, Navid. Thank you very much. I didn't break anything. So, as we know, there are a lot of classification in avulsions. I'm not going to go into these details, but you all know about it. The advantages are humongous, but certain things that you definitely need to know, that it is technically demanding. There are visibility issues, and there is compartment syndrome. So another small trick, if your surgeries are done 10 days post-op, the chances of compartment syndrome significantly reduced. So try to do them at roughly around 10 days, it will be good. Your fixation points, this is the standard basic ACL avulsion. I'm not going to go into a lot of different tips. This is a standard one. What you're doing is, you're passing the loop around the ACL. I crisscross it, so this gives a 3-point fixation. Let's look at this case example. That's a standard ACL avulsion, the one which we can do. And here's what we are doing. We are going in, giving a thorough lavage. That's the ACL which is intact. So again, what I do is, I use the central portal as the visualization portal. The anteromedial and the anterolateral portals are my instrumentation portals. I use the suture shuttle. I go deep at the base of the ACL, so that gives me a good leverage. I use a fiber tape or a taping suture tape rather than simple threads, because that gives a good fixation with a single point as well. And of course, there are 2 tunnels which I drill. Sorry. So as you can see, that's the articular defect. That's the ACL. Of course, you clear the crater. So this is like our significant orthopedic surgeon surgery. So we are doing our fracture fixation. We clear the hematoma. We clear the fracture. And there I am passing the suture retriever. I use an ethibond and shuttle my fiber wire. So you can play with the portals. You can sometimes keep the central portal as a instrumentation portal. Here I think I have used the central portal as an instrumentation portal. I've used the fiber tape. These jigs are very good because they give you the exact rate where you need to keep your tunnels. That's one of the tunnels. As Navid pointed out, you use a pseudo cannula technique to prevent any soft tissue impingement. And that's the crisscross. And as you pull it down, the ACL retensions. Another thing, don't be very, very fussy about anatomical reduction of the fragment. But yeah, you should not have like a beaking anteriorly, because that will give you an FFD. But otherwise, more you should be focused on restoration of the ACL tension. And there, as you can see, there will be a very good compression, articular compression, once you finish the surgery. And that's the post-op thing. As I said, a fiber tape is a much better alternative for you, and I think all of us can try that. Of course, sometimes you have these very interesting ones where you have a associated lateral meniscal root. And there again the same protocol is used. So there you can see. So that's the ACL. Yeah. And of course, sometimes you have to cut the intermeniscal ligament. There are some studies which say that hampers the stability, but I found it that you need it sometimes, especially when you have these kind of, doubles. So that's the anterior horn root, and the other one was the meniscus, the ACL. I've passed an ethibond through the root, and I've passed one fiber tape through the ACL. I crisscrossed it, passed 2 tunnels, pressed it down, and here I have used an endo button to tie the whole thing down. So there you can see the tension comes, even a lot of times the reduction comes very well. And that's the endo button on which it has been tied on the anteromedial aspect. That's the result. Let's not waste time in it. And yeah. Okay, sometimes you get these very challenging ACL avulsions. So this is a boy who had an ACL avulsion since last 3 years. And he had a non-union fragment. Now since this boy is very young, he's like, I think 6-7 years. Of course, there are a lot of options that you can do. There is contracture of the ACL, there's hypertrophied fragment. So this is something that you should do once you master all the techniques. And here, again, as an orthopedic surgeon, you are following the principles of non-union. So you are removing all the fibrous tissue, you are freshening the edges, you are using your rasp. So here you can see, I'm using the shaver, I'm freshening the fracture beds. In fact, I also burred the fragment. And since this was a very small boy, I used only the, not the 4.5 drill, but your conventional 2.4 guide wire. So I've used just the ultra braid, I have not used a tape in this. And to cut the long story short, I fixed it. So that was the immediate post-op, and that is how the patient went on to have reasonable union. That was his follow-up, and that's the boy playing in my hospital where my staff got a CCTV footage, and a pretty reasonably happy boy and parents. Of course, there are non-unions as well. You will see a lot of these. ACL non-unions is a different ball game altogether. So you remove and do your conventional ACL. The same thing, these are always be hypertrophied. So in this, don't bother about fixing this, because this is an adult patient, and she has instability and locking because of this large fragment. And as you can see, the ACL is totally thinned out. And then we did an ACL reconstruction. So the post-op. So that's what I was talking about. You know, you should have see to it that if you have these kind of, if you have those kind of patients, then you should be more worried of the anatomical reduction. So these are the cases where anatomical reduction happen. This is my own case, and I had a little bit of elevation. I just thought I should share this with you all. This patient, I was not very happy with the X-ray. He had union, but he had a little bit of beaking. And in those cases, then you can add an anterior stitch as well. But he had a reasonable function. Sometimes you get these kind of cases. This is if you want to save this, I mean, anyone wants to save this, why we should do ACL avulsions arthroscopically, this is the case. So this person came to me with significant anterior pain. He had an open ACL fixation done by surgeon, followed by implant removal. And he had severe restricted flexion and severe pain. So just look at the amount of scarring that he had. You have seen everyone, especially Sapre sir, showing us so easily the scope goes into the suprapatellar pouch. But here I had to struggle like, it was in fact, my first ACL, something like that. And there you can see, you know, the amount of scarring that happens. So look at the amount of scarring that I had to remove for this patient. And once we removed it, we did an ACL reconstruction for him. So again, I won't bore you with a lot of big videos, but I just wanted to tell you that type 1 fractures, there is still role of conservative management. Even though we are talking about surgery, we are talking about ACL avulsion surgeries, but there is role. I treat type 1 ACL still with a plaster. I use it in full extension, and it should be above knee, not a cylindrical cast. So give that, take the patient, repeat x-rays at 3 weeks, see to it that there is no beaking, and the patients will do well. All others can be managed arthroscopically. You need to have good visualization, of course, and good skills of suture shuttling. And of course, the benefits of arthroscopy outweigh open. Thank you.
Thank you, sir. That brings us to the end of the second session. I thank all the speakers for taking us through ACL reconstruction with such ease. I would like to open the floor for our moderators to pass any critical comments or closing comments. So, just before we break for lunch, can I please request Dr. Samir to kindly felicitate Dr. Sushrut Rajan with a memento as a token of our appreciation. Thank you. I now request Dr. Amit Hadole to kindly present Dr. Vikram Sapre with a memento as a token of our appreciation. I would like to invite Dr. Samir to present a memento to Dr. Aditya Bothra. Next up, can I please request Dr. Amit sir to kindly present a token of appreciation to Dr. Siddharth Jain. And I now request Dr. Samir sir to kindly present a memento to Dr. Abhishek Ghatke. And I request Dr. Amit sir to present a memento to Dr. Naved Ahmed. And finally, I would now like to request Dr. Aashay Kekatpure, our organizing chairman, to give a memento to Dr. Amit Hadole as a token of our appreciation. Thank you very much. We'll now break for lunch and meet again in the same area at after 40 minutes for the ACL SOB workshop. Thank you. Lunch has been arranged in the Sodexo area, so it will be on the left side as you pass through the main gate, near the canteen.
सर का लेक्चर ये हो गया क्या, लोड हो गया सरांचा लेक्चर, सगळे लेक्चर्स लोड झाले. Attention delegates and respected faculty members, we have a small announcement. We will be conducting both the workshops for the ACL as well as the meniscus together. Our senior sir, Dr. Jagtap sir, he has emergency case. So we will be just finishing off with the last session, and then for the entire time till 6 o'clock we will be having those 5-6 o'clock we can have those corbin workshop. Okay, so we'll be just finishing off the lectures now.
Good afternoon, everyone. Okay. Good afternoon, everyone. I request all the delegates and the faculty members to kindly take their seats and settle down. So, okay. Okay. I request everyone to please settle down. We'll start off with our final session of the day. So, welcome back one and all for our final session. This is all about the meniscus, involving discussions on what to do, what not to do, how to do in different meniscal pathologies. In my relatively less experienced opinion, meniscal pathologies are the most common ones to be neglected or ignored. Apart from a displaced bucket handle tear of the meniscus, which is recognized by everyone as a cause of a locked knee, with requiring urgent management, #MCQ, I don't think most of the other meniscal injuries get noticed and are usually sidelined due to the lack of understanding or an inability to take firm decisions on the line of management. There's no better way to kickstart the session than to become aware about decision making in meniscal pathologies. I invite Dr. Satyajit Jagtap to help us understand the same. Please welcome sir with a huge round of applause.
First of all, thank you for the invitation. Actually, Amey was to speak, but he is not well. So I am talking. I will be talking on this topic with few of his slides and my videos. Considering that you have already diagnosed the meniscal injury with the help of a detailed history and a clinical examination, I will proceed straight away with decision making in meniscal tears. There are various factors that will affect the management of the meniscal injury, including the age of the patient, the age of the tear, what is the alignment of the limb, whether the tear is acute, chronic, what is the length of the tear, what is the pattern, whether it is a complex tear, and associated ligamentous injuries in the particular knee joint. The decision revolves around whether we have to go for a conservative management or whether a operative management is necessary on day one. But definitely initially there are some conditions in the meniscus which we can think about managing conservative like a partial tear or small tears less than 5 millimeter, few horizontal or degenerative tears which we can conserve or which are incidentally found on MRI, which we have been doing for some other condition. Conservative management revolves around either rest analgesics for around 3 months of time, but definitely we can go ahead early if it is a case about athletes or laborers where they need early recovery. If you at all you need to do surgery, whether there is meniscectomy or we have to repair the meniscus, but as you all know, we are more going towards preserving the meniscus as far as possible. So let us consider this structure of the meniscus where you have two fibers, circumferential and radial fibers, and as you know, wherever there are circumferential fibers, we try to conserve the meniscus, and where there are radial fibers, we try to excise. Also, there is a zone of blood supply that you all know, the peripheral zone about 3 millimeter. It is highly vascular, so you should try to preserve that knee and repair. Variable in the red-white zone, you can think about, you can take a call after you do arthroscopy. Vascular zone, it is better to excise them. There are various tear patterns, as you all know. If at all you need to go ahead with meniscectomy, which you should try to avoid as much as possible. Partial is the preferred one as compared to total, which is as far as possible should be avoided, and which will make the person a candidate further for the meniscal transplantation. If meniscectomy is the decision, then there are various principles. If it is a zone 3 tear or a flap tear, oblique tear, or as you should try to preserve the meniscus as much as possible and balance the meniscus so that there are no further tears in it. Metcalf has given very good guidelines for meniscectomies. Whatever mobile or unstable fragment which are likely to come in the movement of the joint, they should be removed, and the meniscus should be balanced or leave no changes in the contour of the meniscal rim. Use a probe as much as possible, repeatedly, frequently, to monitor how much residual tissue is there and how much it is stable or not. Protect the meniscocapsular junction, which is very important, and if you are not sure, you may try to leave the meniscus so that it will function. Second decision is surgery, either meniscectomy or meniscal repair. Repair, if it is a peripheral longitudinal tear, then you should always try to repair, and if it is unstable, if it is displaced by probing, then you should repair with other methods which will be discussed by the various speakers afterwards. If there are no secondary degeneration, if the tear is very long standing, even if it is a peripheral longitudinal tear, but if it is long standing, if it is not healthy meniscus, which I will show in one of the videos, then it is better to excise them. Active patient tears or tear if it associated with other ligament stabilization procedures or in a ligament stable knee, then it should be repaired. All inside out, all inside outside in techniques you all know about meniscal repair. Consider all other things like degenerative conditions, axis, age and other conditions before going for the repair. Now this is a case of bucket handle tear of the medial meniscus, which I have told you just now. It is a very long standing tear. Though this is a reducible one, it is not of a very good quality, and it is better to excise the meniscus. So first you remove the posterior portion of the meniscus, then you go ahead and remove the anterior portion of the medial meniscus, and then once you have removed, then you do the shaving of the remnant of the meniscus and what is called as balancing. So the three main principles where meniscectomy revolves is excision, shaving and balancing of the meniscus. So that will take care of the residual tissue which is not going to get damaged in future. This is another case, young female, she had ACL injury, but you can have a look at this meniscus, it is very badly damaged, and this meniscus is not salvageable, though she is a very young patient, but this meniscal repair is bound to failure. So it had to be excised unfortunately, and ACL reconstruction was done with partial meniscectomy. These are multiple longitudinal tears that were encountered in this meniscus, so it was not repairable. You can say that it was not a single bucket handle, or you can say multiple handles with a single bucket or whatever is. Also, degenerative tears encountered in this old population are better excised if at all you are going for some other condition, or if you find that it is causing a mechanical symptom. If it is blocking the movement of the knee joint, it should be excised. A discoid meniscus is a peculiar condition which also needs, if it is torn, it should be excised. First you have to identify the tear, because it is very close to the ACL. You identify the tear, and by using different punches, shaver and probe, you have to go on identifying the excess portion of the discoid meniscus till you have a balanced rim outside. Now you can see that there is also horizontal component to this lateral meniscus. Then this should be repaired. This can be repaired by all inside different methods like fast fix or anything of your choice. I have put only one suture, but if given a choice now, this is an old video, I will try to put a fibrin clot as well to enhance the healing of this meniscus. Last is the flap tear, which should be identified with a high index of suspicion. As you can see, the under surface looks little bit fishy, and you have to do definitely probing, and with some patients you can see that you have a very big fish. You have got a big fish. So this is the flap tear, and definitely this is not repairable. So this should be removed from the base. You remove it from the base, and once it is excised, then you take it out and you try to balance the meniscus. If it is completely removed, then you take in the intercondylar notch and then take it out with the help of a grasper after proper dilatation of the portal as told by Tejas. This is balancing of the meniscus. So to sum up, how you are going to plan for your meniscal management depends upon the age of the patient, around 40. If there is definitely locking and other tenderness, effusion is there, then you go for MRI, do diagnosis, and go for arthroscopic examination. If it is a vertical tear, either longitudinal or radial, and it is in red and red white zone, then you should go for repair of the meniscus. But if it is in white zone, whether it is longitudinal or radial tear, or I may add, if it is an old tear with very poor meniscal tissue or multiple longitudinal tears, then they may not be salvageable. And if you are not very confident that it is going to heal with your method, then it is always better to do excision of the meniscus rather than going ahead and doing second surgery and doing the excision. If it is a bucket handle tear and reducible, then definitely you have to repair it. If there is one statement that bucket handle is not reducible. I think it is a very rare condition that it is not reducible. It is always reducible most of the times by various methods. If there is a flap tear or a oblique tear, then you have to do removal or arthroscopic partial meniscectomy. If above 40, if there is a degenerative tear, then you should try to conserve as much as possible. Till that time you will find out whether the source of pain is the meniscal tear, whether it is a mechanical problem that is caused or there are other inflammatory problems. So if it solves on its own, then there is no point in going ahead with removal of the meniscus. But if conservative fails and he or she is complaining of repeated painful episodes, locking or movement restrictions intermittently, then it suggests that there is a mechanical problem and you should go ahead with removal of the meniscus, which is the culprit part. Thank you for your hearing.
Thank you, sir, for the wonderful talk. Due to some prior commitments, I think Dr. Jagtap will not be able to stay with us till the end of this session. So, as a token of our appreciation, I would like to request Dr. Aditya Kekatpure as a part of our organizing team to felicitate Dr. Jagtap sir with a memento as a token of our appreciation. Thank you very much, sir. Moving on, now that we understand what to do and what not to do in case of a meniscal pathology, we should make ourselves aware of the different techniques in the management of such injuries. With a variety of techniques being described, we will learn and discuss about the standard and most commonly practiced ones in this session. To start things off, I would like to invite Dr. Sarthak Patnaik to speak about the all-inside repair technique for meniscal injuries.
Thanks again. So my topic is on meniscus repair, all inside. To start with, small information, we all are hungry for information, no matter from where they come. So as we all know, to start with, I'll go in brief introduction of the anatomy. It's a crescentic shape, mostly fibrocartilaginous structure, smooth and glossy when you look it through arthroscopic. And the lateral meniscus, which is displayed greater variety in size, shape, and thickness in compared to the medial meniscus. This is just the salient points. So what's the role of meniscus? Is basically a shock absorber between the femur and the tibia, and among the two meniscus, we have the medial meniscus, which bears around 50% of the load, whereas the lateral meniscus bears on 80%. So, and during the walking phase, the force shifts from one meniscus to the other, which around increases to 2.2 to 4 times on running. So now the biomechanics, meniscus, yes, as we all understand, is the role of, mostly the role of transmission. So if there is no meniscus, no transmission, and the contact pressure increases, and thereby, you know, we lead to like post-meniscectomy or any surgical procedure or any after trauma. It leads to increase in contact surface, causing more flattening and degeneration of the articular surface, and which leads to further lead to subchondral sclerosis, loss of joint space, and lead to osteoarthritis. So force acting on the meniscus, as the femur press down, the meniscus do deforms radially. The anterior and posterior horns act as an anchor. That is why we need to be very careful when you do a diagnosticoscopy regarding the condition of the both the horns. And the meniscus hoop stress, what we understand, results from this radial deformation. So this is the zone which sir has already explained, red, 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 white, and white, white zones, which are the 3 zones. And so how do we diagnose the meniscus tear? First, clinically, the patient comes in of pain. You know, if there's only an isolated meniscus tear, they complain of pain in the joint line. It can be in the medial joint line or on the lateral joint line. And patient says that something is sticking or something is getting pricked while he's walking, or, you know, while trying to bend his knee and extend. Some patients do complain of locking, especially when at that time you should suspect for differential diagnosis of, if there is not a loose body in the axle, then you should think of, you know, maybe a bucket handle tear. Test which I personally recommend is MEGHE. We have the apply grinding test, which we don't do recently. I mean, I don't do it. MRI, to mostly diagnose, there's, as we have already been in the morning lectures, there is various we can diagnose, but to most important thing, when your patient comes to you with locking and pain in the medial joint line, look for the double PCL sign and the subclavian edema. Because if you are getting a double PCL sign, it denotes that you are seeing a bucket handle medial meniscus tear. So what do we do now? First, to understand, you need to understand the patient's profile. Like what is the demand of the patient? Does he require, understand, like, because every sports, first and foremost, like, you need to save it, but demand of the patient you have to understand, because then second thing which comes in mind is budget. Now meniscus repair, it's require a lot of finance. I think more than ACL reconstruction, even more than or equal to ACL reconstruction. So once you know, okay, this patient is affordable, your one click is one box is tick, okay, I can repair it. Then demand of the patient, whether he want to sit cross-leg and how immediately he want to sit cross-legged, or he immediately wants to go back to his profession. Now, there is a patient who is who doesn't have patience and you want to immediately walk or he has to go, and you see a small radial tear, a small flap tear, you know, we can repair it by just doing a marginal interposition. It's better to, I will say, depending, understand, you can go for a small, balancing of the meniscus. Then comes site of the tear and how big is the size, which helps us in diagnosis whether to save one meniscus. So always the intention should be, there shouldn't be any confusion. Always the intention should be save the meniscus, and before you start your procedure, there is this diamond rasper which will help you. But if there is a mild small tear, no need to repair it. The basic trephinization technique in which we just go and poke the meniscus tear can do help or augment with fibrin clot. So if you divide the meniscus into 3 halves, the anterior third, the middle third, and the post third. So the anterior third goes for the technique of outside in, which we will be learning. The mid third is mostly goes for inside out, as we repair a bucket handle or any type of tear. Mostly, I am talking of a medial meniscus tear. And the posterior third is basically we do the all inside tear, which I will be showing you. This is a various tear configuration which we find in books. I think we all can go through it. Now the type of fixation, yes, I have already explained the outside in, inside out, and the all inside. And regarding the incision which we need to make for a bucket handle or any type of incision is completely surgeon choice, whether you make a vertical or a horizontal incision. So this is the site of tears which has been there, various site of tears, and what I am going to speak on is the all inside technique. So I'm just going through this. So the implants which is basically you should have for any meniscus tear is your probe, your diamond rasper, the diamond rasper probe, or you have the cannula, one cannula is enough, or you have this cannula which is there, and your suture cutter and suture pusher, the knot pusher. So this is an example of the first case where this patient presented with a pain and on the medial meniscus side, but it was not clearly visible. But when you do on hyperflexion, you could see the meniscus is coming. So when I probed it, I could see, and after doing pike resting, I could see the meniscus. So when you see the meniscus, always probe it. 3 types of probing you should do. 1, you should probe the superior surface if there any tear. Then go on the inferior surface and just to put your probe and see whether it is going through and through. Sometimes we just get one articular surface tear, and then how much is it coming out. Then we take this all side suture anchor. This is of this is 4 anchor disposable. This is from Conmate company. They do have it, and we go and repair the stitch the tear. Now this, how do you go, whether you go from from the root towards the body or from body towards root? Basically I always go from the body towards the root, and after proper opening you can put your anchors one after other, and once you do this you give the tension. But I can still see there is some amount of meniscus just still coming out after repairing it, and I had this opportunity of this instrument, so I went ahead and again gave at the posterior third, all inside. So this is one case, and so I'm trying to give the tension in between, and then the last one I give it at the exactly at the root, which gives me the last stitch. Sorry for this poor quality. Our scope is broken in my hospital, so we are trying to replace it. So the second case is another case in which you can see, I would just like to see one more case in which there is a complete tear. As you can see, the posterior third is just coming out, your probe is going in, and it's a through and through tear. So it's a clear-cut thing that we have to go ahead with the all suture or all inside repair. Now the thing is, how do you take this? Now before going to this, always remember your portal what you have made. It's suppose now you are addressing a medial meniscus tear, you should always go to the anteromedial portal, increase the size of the portal, put the cannula at first, push your all suture, this anchor thing, the needle thing, and then once you come close to it, push the cannula back and that pierce. And how much depth should you pierce? A minimum of 18 mm, what we basically keep. I mean, if it's a fat, largely bulky personnel, you can reduce it further. So this is the knot which we have gained for this posterior third tier, and once we give the stitch, you can go ahead and cut it short. This is one more interesting case in which there is similarly a posterior third meniscus tear, but it was slightly a complex pattern, and you can see that there is a vertical slit along with the posterior third. So at first what I did, I used the inside out technique in which I repaired both the cutting edge and tried to make it one structure. So it's something like the marginal interposition I was trying to do, and once I did it with one, you can see this. So there is still some more gap, so I took on another thing, another bite. Again, it goes from inside out. We always try to make it slightly closer to each other because you give more, it will create more, less tension at the sides of interface, and once this is done, I could see, here you can see the knot because I've used the same needle and tried to save the patient's money because he was not so much affordable, so I had an extra needle with me, so I used it, and further continued with the holded the posterior third tier with the all inside meniscus repair. And once it is done, you could see I could clearly save, I could reduce the vertical tear and could save the meniscus. There's one more interesting case which I would like to show is something like, you could see a superficial tear over here and which has gone deep, and similarly we just go ahead, try to pass something like a vertical stitch we give later on. So this is the horizontal tear. We brought it close and then followed by your all suture anchor in which we use. Now the stitch can be vertical, it can be horizontal. So in my initial days, and both are good with you, in my initial days I started with this horizontal stitching anchor. But the trick is when you take the bite of the thing, once you pierce it, to hold the other fragment you need to change the direction of your needle or stitch, and then you try to force it to get hold of the back, the other part of your tear. So once you do it, now you can see the repair is well repaired and the tear has been well held. Yeah, you can see that you have to always probe it and see whether it's coming out. This is a good firm contact. This is one more in which I'm trying to show you this is a clean cut tear in which first you use the diamond rasper. Once you have done it, followed by the all suture we take. I'll just forward it fast. So this is how you go ahead. I'm trying to hold both the tear fragment from here and going posterior also. I'm holding the other fragment coming out and then fixing it here. This is one tear which I fixed, and this is the second all suture. So this is how we can treat and done. And this is the last thing in which there was a tear at completely the root surface, in which you can see. So what I did is went ahead, similarly probed it, and here I took a vertical repair in which I have used at the interface of the meniscocapsular. One of the stitches gone there. You can see this with small fragment of them, but mostly I'm piercing the capsular, and the other one goes through the body of the tear. And so if like in bucket handle tear, though we take intermeniscal body, there should be one capsular stitch. So you can see the very nice grip I have got, and I'm quite happy with this stitching pattern and the reduction which I've got, and that's it. So intra-op difficulties, yes, one, the joint space, so always keep your pike resting ready. And especially for the lateral meniscus, we do struggle sometimes. So as Dr. Tejas was explaining in the morning, when you give a figure of 4, I'll just show like this. When you give a figure of 4, sometimes we give this till it doesn't come. You won't be able to open the lateral meniscus. Ask the assistant to review with this. Lift the leg with your left foot. So you know it opens up and gives you good access to your lateral meniscus. Yes, the re-tear of the sutures do happen. Don't panic. Even when you pass the Meniscal needle, you know sometimes you overdo it and it tears. So be ready for it. So when you put your needle, just check the direction and how far you are away from the initial one. Knots, yes, you can give it. You should always check it once you have done with the probe. And before you go for the knots, always put under vision how good your knot is. This is mostly for the bucket handle tears we can do. So this is how do we reduce the meniscus fragment if it's a bucket handle. Mostly that is what I think Dr. Tejas will be saying, but this small tip, if you have to lean 10 to 30 degree flexion, the meniscus fragment do reduce. And how to approach a middle meniscus bucket handle or knee tear. Anterior 1/3, always use the view from the AL portal. Mid 1/3, view from the AM portal. Posterior 1/3, always view from the AL portal and repair it. And for a lateral meniscus bucket handle meniscus tear, view from the AL portal always, rarely use the AM portal. So take home message, a proper clinical examination is must. The double PCL sign, always look for it, because you don't want to go inside thinking a simple radial tear and turn out to be a bucket handle tear, and you are less of instrumentation with you. Keep your hand instruments ready always. Minimum 3 to 4 stitches are regular. Combination of vertical and horizontal stitches, you can go ahead. And the incision, as I mentioned, is as per your choice. Tie the knots always under vision and probe the repaired meniscus and check the knee range of movement once it is repaired. Thank you very much.
Thank you very much, sir. Just a small announcement. I request everyone to keep their mobile phones on silent mode till we are actively involved in the session. Next up, I would like to invite Dr. Vikram Sapre to speak on the meniscal ramp and root repairs.
So coming to the ramp lesion, basically this was a term introduced by Strobel in 1988, and what exactly from where they have got this name is the standard ramp that we see everywhere. So this is the shape of the meniscus, and at the end there is the tear. So there came the name of ramp lesion. So they are present in around 9 to 17% in ACL tears. The commonly associated means mainly we see in ACL injuries only, and up to 40% in contact injuries. They are also called as hidden lesions or the blind spots. So basically what is a ramp lesion is a peripheral meniscocapsular lesion separation which involves meniscocapsular ligament as well as meniscotibial ligament. Meniscocapsular ligament is a superior one, and inferior one which attaches to the tibia is a meniscotibial ligament, and frequently associated with ACLs here. So here if we see the anatomy, so this one is the, can you see? I don't know. Yeah, so the upper one is a meniscocapsular ligament, and the inferior one is a meniscotibial ligament. That forms your ramp lesion or the ramp area. A tear along with ACL is a ramp lesion. So if you see the types of ramp lesion described by Thunat et al. Type 1, they are meniscocapsular lesions. Type 2, they are partial superior lesions of the peripheral meniscus. Type 3 divided into type 3A and B. Type 3 is a partial inferior peripheral posterior horn, and type B is here it involves the meniscotibial ligament, the inferior one. So that's the partial with superior and inferior involvement of a meniscotibial ligament. Type 4A and B, these are the complete tears. A is in the peripheral part of meniscus, B is in the meniscocapsular area. Type 5, they are double lesions, double tears. So, what are the biomechanical consequences of ramp lesion? It first increases the anterior tibial translation. So, in these cases, you will see a very increased pivot shift. It increases external rotation, internal rotation, as well as it has also been seen in the biomechanical studies that ramp repair, after you repair a ramp, there is a decrease in anterior tibial translation. So, looking at the risk factors, the main risk factors are the steeper medial meniscus and medial tibial slope, age less than 30, male patients, they are more prone, more than 3 months since the ACL injury, posteromedial bone marrow edema, this is commonly seen with the ramp lesion. This is an indirect evidence of ramp lesion in association with lateral meniscus tears and in varus knees. If you see the MRI has got not a very good sensitivity of detecting ramp lesion. It has got only 48% of sensitivity, but the specificity is high. So if they are saying it's a ramp lesion, there are high chances there will be a ramp lesion. So what we see here in the ramp lesion is peripheral meniscocapsular tear. You can see meniscocapsular tear in the peripheral lesion, commonly seen. You also see posteromedial bone marrow edema. So, diagnosis of a ramp lesion is based on clinical high grade. Clinically, if you see high grade pivot shift in association with ACL, it's probably a ramp, could be a ramp lesion associated with MRI finding and with the risk factors that we have seen. Then the tentative diagnosis of ramp lesion along with ACL can be made. That was high grade pivot. So, management, 40% of ramp lesions, they are missed with standard anterior arthroscopy. So, posteromedial scopy should be done in all cases of ACL injury. We should always go in the posteromedial compartment, posteromedial recess to assess for ramp lesions. Repair technique, repair can be done by only by suture lasso, the ramp lasso, or you can do it with scorpion, you can do it with double portal from posteromedial side. So, or it can be done with all inside implants also. But the standard technique that we follow is by making a posteromedial portal, repairing with the ramp lasso. So, looking this diagnostic scopy, if you see, that's the medial meniscus. Once you go there, are you able to appreciate? Yeah. So, from here you enter into the trans-notch view, or I think Gilchrist view. You can see there, you see a large ramp lesion. You can see ramp lesion out there. So, I think Morning Tejas was telling about the trick. So, you can put a rod there if it is difficult. So, if you see this prominent tibial spines, this will not allow you to enter. So, you put a rod there and then place your trocar over that rod, and then you will be able to reach on the posteromedial side. So, that's what we have seen. By transillumination, you can go into the posteromedial portal. From there, once you put a spinal needle, you do a needle probing. In all the cases you should do of ACL, you should do a needle probing to assess for ramp lesion. Once you are there, you put a cannula, and you see from posteromedial side, you can see a ramp lesion out there. Yeah, that's this is not very easily visible from anterior side. So, you can see a large ramp lesion out there. So, the standard technique of repair is first freshening the edges of both the sides, the capsular side as well as the meniscal side. Take a bite with lasso, shuttle the sutures and place the knot. So, you can generally the friable tissue is there, so preferably you don't put a sliding knot there. This is a low profile lasso which we use for ramp. because it will create a larger hole in capsule or the meniscus. So they are slightly smaller profile, low profile one. So use 2 to 3 stitches, and that's our final lasso repair for posteromedial portal. Yeah, so this is another ramp lesion you can see. At times it is difficult to take a bite in the meniscus. So what you can do is take a bite on the posterior side. I'm shuttling the suture below the meniscus anteriorly. Yeah, you shuttle that with the suture, fiber wire 20 or a 01, and then take the entire bite with a scorpion. And that is the another way of doing it. Sometimes you can see these are double tears, meniscus as well as peripheral. So it was very much approachable from anteriorly. So you can take direct knots and bites from the anterior side with a knee scorpion. So in conclusion, always do a transnotch scopy in a posteromedial space in all cases of ACL. We should always do a needle probing. Needle probing is required because sometimes the synovial flaps cover the tear. So once you probe with needle, you don't have to make a portal and with a probe, but just do a needle probing that will help you reveal the hidden lesion. And repair is highly recommended when it is lesion is present. Thank you. I'll have one more is there. Yeah. So coming to the meniscus root lesion, I'll quickly go through. So medial meniscus root tears, they are usually seen in isolated injuries, 90%. While lateral meniscus posterior horn root tears, they are seen commonly in association with ACL injuries. Medial meniscus along with ACL, they are very rare, seen mostly in a maybe percentage of individuals. So what are the biomechanical effects that root tear will cause? Normally there is an axial load, there is a circumferential hoop stress, there is a weight distribution which increases the contact area and decreases the peak pressure. So the axial load is distributed uniformly, but when there is a root tear, there is extrusion of meniscus and this hoop stress is lost, which decreases the contact surface and increases the contact pressure, which leads to further degeneration and which will lead to early osteoarthritis. Similar effects are seen with lateral meniscus posterior horn root tear, but the effects are less severe due to presence of meniscofemoral ligament, anterior meniscofemoral ligament and posterior meniscofemoral ligament of Risberg and Humphrey. So on the lateral meniscus, there is still some stability to the posterior horn even after the root tear. So if we see 60% when the contact area, if you see for by study with Forkel and et al., 14% prevalence of lateral meniscus extrusion in cases with intact meniscofemoral ligament. So extrusion is less common in on the lateral side. Only 14% when there is intact meniscofemoral ligament, and 60% when meniscofemoral ligaments are also torn. Coming to the classification, that's the classification given by Laprade. In the type 1, they are the partial tears. Type 2, they are complete tears. Type 3, they are along with bucket handle. Type 4, they are posterior horn oblique tears going into the root. And type 5, they are bony avulsions. There is a separate classification given by Forkel and Peterson for lateral meniscus, because lateral meniscus, if you see, they behave a bit different as compared to medial meniscus. So type 1, they are avulsion of the root. Type 2 is a sort of a radial tear. Type 3, which is main, is along with meniscofemoral ligament. So these are the real lateral meniscus posterior horn tears which will lead to extrusion and degeneration. On clinical evaluation, if you see the symptoms are highly variable. Mostly they will present with posterior knee pain, high grade pivot shift if it is associated with ACL, and meniscus extrusion maneuver. This has been described by Romain Sale, in which they are applying a varus force with the knee in full extension. While palpating the medial joint line, you can palpate the extrusion. This was the clinical sign for root avulsion described by Romain Sale. So on imaging, what you see is the ghost sign or the absence of meniscus there. In the axial, you can see the absence of posterior horn, and there also on the coronal images, you can see absence, the tear of posterior horn root. So management consideration depends upon how the cartilage is. Is there any varus, and how is the condition of the remaining meniscus? How is the limb alignment if there is varus knee? Only doing root repair won't help. And BMI of patient and the patient's willingness to adhere to their rehab protocol. Various types of specific instruments or the root repair jigs are available from different companies. They are site specific also, that can be used. You need some instrument to take bite in the posterior horn, direct instrument like first pass or scorpion you may need, and the specific jigs. So coming to this one, and this is a medial meniscus. You see the increased opening after I did a pie crusting. You can see a root tear out there. So once you define the root tear there, not a significant cartilage loss, so you go and decide to do a repair. You debride the area, you upgrade or denude cartilage where you are planned for repair, as well as the surrounding capsular area you need to freshen up. Yeah, and then this is a root specific jig where you place make a tunnel, transtibial tunnel, take the bites. There are various configuration of bites described. You can take a cinch knot, you can take a Mason Allen type of stitch also. So this is a Mason Allen type. I am using a fiber tape. I am shuttling a fiber tape over a fiber wire to 0, because with a scorpion you can't take more than 0 number. So there's a vertical stitch I have placed, and then here comes the horizontal one, and that's the Mason Allen type of configuration of a root repair that has been done. So on anteromedial tibia, you can do a fixation over a simple endo button or the various buttons available. ABS button that has got a small groove, and where your button will go inside the tunnel part of it. Here you have to be very cautious. At times your tunnel is slightly posteromedial, so you have to completely visualize if you are using endo button, it might go into the tunnel at times. So these buttons are better. That's a lateral meniscus posterior horn root tear, a radial type of tear near the root. You can see the contusion there also, and then in this case you make a tunnel out there. So you have made a transtibial tunnel, transosseous tunnel. I enlarge it with 4.5 reamer, then pass the sutures. Here I have taken 0 number sutures and have not shuttled them with tape here. So this was like type 3 of the Forkel type, and this was totally free posterior horn. So that was the final root repair. This again one more type of lateral meniscus posterior horn root tear. Probably the meniscofemoral ligaments are attached, so the root has raised up, appears elevated. quickly go through. And taken the bites with the tape, the final repair. This is oblique radial tear. Yeah, so this is oblique radial tear of root. So you have if you have remaining significant stump available which can be repaired. So here I have done repair with direct stitches I have taken with a scorpion. So you could take direct stitches, couple of stitches with scorpion on both the sides, end to end, and you can repair with that. You can use all inside implant also here, and that's the final repair here. That's last type of type 5 Laprad type of tear with a bony avulsion. You can see the bony fragment out there. This was the case in which both the lateral meniscus posterior horn and the medial meniscus posterior horn where there was a bony avulsion. This patient also had a ACL bony avulsion. So medial meniscus we have repaired, and that's the lateral meniscus repair, and this was the final ACL avulsion repair. So all three bony avulsions. Thank you.
Thank you very much, sir. I now invite Dr. Tejas Waghela sir on stage to shed some light on the inside out and outside in techniques of meniscal repair.
Thank you very much. This is my last talk of the day, the third talk, and I hope I finish it quickly. Before I start, I just thought that I feel like Surya Kumar Yadav. You have Rohit Sharma as Sarthak showing a lot of all inside stuff, and then Virat Kohli, Vikram Sapre sir, who has showed fantastic. I think we should give him a round of applause. I think they were like fantastic cases. And like Surya, I will just finish it. So I don't have a lot of videos for y'all. Y'all can clap for me as well. All right, don't clap. So now what I'm going to do is I'm going to be talking on inside or outside in. I have just 2 videos, and these videos are very brief. I want you all to assimilate this, process this information, because you're going to be using your cadavers tomorrow. And I think you should try these simple techniques, and these will benefit you in the long run. And that's why I have just kept 2 of them. So this is my armamentarium, which I always use when I'm doing any outside in or inside out repair. You should have a suture cutter. You should be basically well versed with all the shoulder knots. So you need a shoulder grasper, you need a shoulder cutter, you need zone specific cannulas. There's a spoon which is from my mom's kitchen, and it is still there with me since so many years, and it has been used by me for the last, I think, 7 years. And of course, use these small retractors. These small retractors will help you make your safety incisions and retract it in an elegant way, and you don't need to open it very significantly. So why do we need safety incisions? Whenever you are doing outside in, as you know, when you're going, especially when you're going, like Dr. Sarthak told you, that you can use all inside for posterior, and I agree with him. I do that. For extreme posterior ones, I do all inside. You don't need to have a hassle. But however, in certain times, you require your needles to be a little posterior, and you need to prevent the vascular injuries, and that's why you have these windows. So on the medial side, you have a window. Is this working? Oh, it is not working. So you use a medial incision. Now when you are doing this medial incision, see to it that it is also around 1/3 up above the joint line and 2/3 below. Go, like when you're looking, now I'm talking about the medial side. You retract the pes. You retract the pes posteriorly. You identify the sartorial fascia. You release the sartorial fascia, and then use a blunt dissector around the posterior capsule and put your spoon. Now you can also use, general surgeons use this a rectal retractor or a proctoscope kind of thing, you can use that also. However, I have found the spoon to be enough. Now the trick behind using it on the lateral side is a little more nuanced. You have to see to it that the fibular collateral ligament is not damaged here. So you go identify the biceps, just cut the biceps, split it up, you will see the lateral head of the gastrocnemius, retract it and use your blunt dissector to identify the capsule, and then you have to basically pass the needles. So that's how you're going to do it. That's the retractor, that is the medial head of the gastroc, this is on the medial side. As Dr. Sarthak also told us about how you do it, so the simple formula for that is whatever you want to pass the needles from should be in the same line, except when you are doing it on the lateral side in the root, because the neurovascular bundle is directly in line. So in that case, what I do is I put my scope here and my needle goes from the medial portal. And of course, you have your retractor or the safety spoon and the needles are taken out. Now, whenever you are doing this, when the needle is passed, that time your knee is in 30 degrees of flexion. As soon as it pierces, so once it pierces this, then you flex it more up to around 80 degrees, and then you'll have another giveaway which is of the capsule. And your assistant needs to be very well versed that as soon as it comes, he needs to grasp it and pull it out. So this is a simple maneuver, flexion. Again, I am repeating this. I want you all to, I think this is very important. You know, of course, Dr. Sapre is a very eloquent surgeon and he has an experience of more than 20 years, I think. And I'm sure Dr. Sarthak as well. However, these are the simple things which you want to learn now and then become better in other complex stuff. So, you're going here and you're pulling it out, right? And the same thing you're doing here also. So, 30 degrees, deep flexion, needle comes out, you pull it out. So, I use these by Smith & Nephew. I have my own set and we have been using these for a fairly large amount of our case, and it has saved me a lot of money for my patients. So, when the needle goes here, don't use a artery clip. Don't tell your assistant to grab this artery here, because one, it will make your needles blunt, second, it will curve. So once it curves, that needle is wasted. You have these needles which are reusable. So your assistant should be trained to grasp the needle here and not here. This is another simple trick. So that's how I use my safety incisions. Of course, trans-illumination in arthroscopy is your best friend. So it gives you a guideline. This is on the lateral side. This is on the medial side. These are both of my safety incisions. As I told you, I use these retractors. My scope is in the same side to detect the trans-illumination laterally as well as medially. So a quick, simple, single stitch. So how do we do it? So that's the lateral meniscus. I'm probing it. I'm freshening it up. This is a relatively acute case, so I did not use a diamond rasp. That's my magical window. That's my spoon going in. And there's the stitch. Now whenever you are stitching, again see to it that your first stitch is superiorly. If it is inferiorly, sometimes it shreds. So these are, I'm talking of vertical tears. I'm not talking of radial tears. I'm not talking of, other flap tears. And that's how it sits down. So what I do is I take 2 of these stitches and I use an all inside. So I just need one all inside device and it makes my patient better. Another tip, if you are doing your repairs with a ACL. Now when you are doing ACL, if you finish suturing and then you drill your femoral tunnel, so that would be a bad idea. That can rip. It has happened with me. In my first few cases, in fact in my first case itself, I repaired it, I tied it down the way it has been taught in textbooks, my assistant hyperflexed it and my meniscus gave away. So another tip, whenever you do it, first drill your femoral tunnel, finish the hyperflexion work, then start with your stitches and do your repair. So that's what, and also another thing that I do is, I don't keep all the sutures directly and then tie it, I do it one at a time. So, jhanjat nahi rehta hai, lot of, suture management. Take one, tie it, cut it. Next needle pass, tie it, cut it. Of course, there are some certain instances where you have to use an outside in, and generally this is done in the anterior setting. So again, I've just edited this video. I just want you to focus on how to do an outside in. Be proficient in small things. You'll become better in complex stuff later. So that's a meniscus. This had a bad meniscal tear. He had a radial component and a bucket handle component. We have repaired everything. However, I'm showing you just the outside in. So what I have done here is I've used a needle. I passed it from outside into inside. I use a simple ethylon suture. I grasp it, I take it out. Okay, so one more, just a minute. Yeah, so one more small tip. What happens is whenever the suture is there and you pull it, if you pull it on the sharp edge, it breaks. So take your needle, retreat your needle outside and then pull the suture. So it won't cut. This also happens a lot of times. So this is another small tip which I would like to give you. And once you have done that, then you can take your braided or your ultra braided sutures. Now take the other one with the needle itself. Now once you have done this, again open it. I have found the probe to be very good tool where you can open the whole device. Then use again your shoulder skills. Use a suture shuttle. Take it, pull it out, and then now again I am withdrawing the needle. So I am not using the needle, I have withdrawn the needle and only use the suture to take the green suture out, and then you tie it. So like Surya Kumar, I have one last fancy case to show you that if you do all these simple things properly, you will be able to do certain complex work. So that's an anterior horn lateral meniscus cyst. Now this patient had a large cyst with an avulsed root. So we gradually debrided this. We had to open the capsule. We went transcystic. And we realized that there was not a lot of tissue remaining here. So I used a suture shuttling device, passed it through this, and we used multiple of these shuttles. So there we are. That's one. That's the other one. Another one. So 3 stitches. Oh, one more. Yeah. Now since there was no anchorage, I curated and freshened the bone. So it was an anterior root avulsion with a large cyst. There I'm doing decorticating the bone. We passed a tunnel, we made a tunnel in that. We passed sutures through it, we shuttled these using the pseudo cannula technique. All of these were taken down onto the anteromedial side. And the whole thing was repaired down. Once this was repaired down, there was also a capsular rent which we had made. So I used an outside in technique. So that's the outside in technique. I am also repairing the capsule and I'm close the capsular mouth. So the same technique, we use a needle, pass ethibond through it, use a suture shuttle. And close everything up. And that's how it is done. Thank you.
Thank you very much, sir. Now we move on to the final part of our last session. For this, we will now divert our attention towards two important yet quite underrated aspects of the management of soft tissue knee injuries. So rehabilitation and gait analysis form an important part of the management pathway, without which even a technically perfectly done job can go waste. That being said, I would like to invite Dr. Manoj Pahukar to speak about the recent advances in ACL rehabilitation. Thank you, sir.
So very good afternoon to all of you. First of all, I would like to thank the organizing committee, Dr. Aashay and everybody for giving this opportunity. And it's good that this rehabilitation is now a norm to include into the main conference, because these topics are usually neglected when rehabilitation, gait analysis, because whatever good surgical techniques which you have followed, and if you don't give a good rehabilitation for that patient, it will not give a good results. So I was asked to speak about what's new in ACL rehabilitation, because we all know the standard protocols. And we'll start with this, the success of any surgery is the race between the biological healing and the fixation failure, which occurs first. And we all know that the effects of disuse, that because of immobility or immobilization, the collagen fibers, they will decrease in size and amount, and they will have a random orientation. And once that activity happens, then the collagen fibers, they increase in size as well as amount. Their orientation is correct, and that only gives the increased strength. That suggests you how important to have an activity, and very important to get the balance right as well. We should try to avoid the muscular atrophy, get a good muscle which they try to inhibit their muscular actions, and avoid any poor neuromuscular control which usually happens. So you have done good surgery with all the previous excellent techniques which are suggested. The further procedure is to understand how to move ahead with the physiotherapy. I think it is very essential. You should have a good team approach with your physiotherapists, with your colleagues. Physiotherapy should always know actually what kind of surgery we have done, because the routine trauma cases, joint cases, where you go for the x-rays properly where they can see, but arthroscopic cases, they don't have any idea what is gone inside. So they should be able to understand that is what kind of injury it was, what reconstruction, which graft were used, the patient, the pre-op education, their supervision, and important to have what are the associated injuries. Very essential to take these OT notes which are readily available with them. Just they should go through as to the how much repair quality surgeon was able to do. So the main important rehabilitation goals for any procedure after the ligament recovery ACL is like to, apart from reducing the pain and inflammation, is to get a good strength and endurance with a good normal range of movements. And the main is to have a good safe zone. You should not put much strain on the repair so as to cause any failure. So nowadays certainly it's moving towards an accelerated rehabilitation regimes. So this is this infrared thermalism will show you that this was an operated PCL ACL on the right side, where you can see almost this hyperthermia around this region, and they have done only 20 minutes of physiotherapy. This area is localized, getting reduced to only 30%. So that is the essence of these rehabilitation programs. Currently we use now this called as the criteria based rehabilitation progression. And we all know this chart as to how we process with these basics of any, that the ACL in the initial 1 or 2 weeks, you need to initially start with getting good range of movements up to 90 degrees, the quadriceps muscle, then walking without crutches can be done. Then at that second weeks, you try to achieve the full knee extension, get a flexion more than 110 degrees, improve your quadriceps strength. You can go for more activities. At 4 weeks, it should always be getting comparable to the other knee, good quadriceps strength. Then 6 to 8 weeks, they almost should get a good normal gait pattern. And finally, at around 12 weeks, when you feel all things are good, you can certainly go for the routine going back to the sports activity. So all this physio usually starts with the pre-op rehabilitation, with the good education, familiarization of the patient beforehand going to the surgery. They should be educated, they should be assessed, and you can categorize. Certainly there are poor candidates sometimes will not be able to follow properly, where you need to give more efforts. So it should be a whole kind of holistic approach, start early, go in a controlled manner and periodically monitor it whether those things which you are trying to achieve at 2 weeks for whether they are happening or not, because they come for follow up during that time we always say ठीक है ये हो जाएगा, it would improve, but there should be certain red flags where you need to act, because if the ROM is not coming at around 3 weeks more than around 80 or 90 degree only and you are expecting it to be more, so there are the things where you need to go for more other therapies. So again, the whatever repair the quality which you have done, then depending on that you can certainly speed up your physiotherapy if you certainly have a good stability after your surgery. So depending on whatever quality of repair you get, you can certainly intensify. So the main is to get never overstress the illustration, very important. Progress only when that initial criteria of that phasic whatever you are trying to do, then only if that criteria is met, then only you can just go for the, and you should have a patient specific goal as to control the muscle timing, control and strength. So we all know that it all rehabilitation like ACL, it goes through the phases which I already told the weekly. Another is to have early rehabilitation is usually the 2 weeks where you can starting getting good knee range of flexion, walking with full knee extension. You can certainly start getting some cycling and the stair climbing initially as well. You should try to incorporate the closed chain weight bearing exercises as well immediately. This certainly I found sometimes useful to get neuromuscular electricity if the things like you are not able to get the further range of movement. Sometimes this additional modalities you can certainly use the intermediate physiotherapy phase where you need to increase the cortical strain mode, get more knee range of movement. Go for a good balance and neuromuscular like the single leg balances, single leg cone pickup. These additional things you can start doing in the intermediate phase, and the less post-operative phase. The another milestone where you can at least get a good cortisol as compared to the other side. Almost the patient should have a good gait pattern, which I think the Aashay will be covering on. You should have a good complete full range of motion. And then once you feel that transition at the around 8 weeks, most of the your criteria is meeting, then running progression where you can certainly the patient has got no edema, there are any no effusion, where you can certainly go for the higher activities. We all know the soreness rules as to when you should stop. Whenever there's a time the pain is more, you can take a break for 2 days, or you can intermittently reduce the level of whatever activity which you have started. You can certainly go back a level. It all depends on like how the patient is behaving on that particular day. So very essential, like for my ACL patients, initially I ask them to come every weekly, at least for thrice if they are the local persons, or at least that physiotherapy should give me the exactly like how much he is improving, because I feel this initial 3 to 6 weeks are the most important. This is another phenomenon. Sometimes the good ACL patient says ki I am feeling very well, and he suddenly stretches out more for that particular day, and this will certainly lead to downward spiral of deconditioning. So try to avoid even progressing to a higher levels. In spite sometimes the patient could feel better. So try to avoid this boom and bust cycle as well. Very important to have a good pain management throughout with whatever analysis, cryotherapy, local cold fomentations, and return to sports criteria we already know. But certainly they say that there is no particular specific one thing which even I could tell. There are 4 articles which they are reviewed, and they certainly say that the return to sports, it's the optimal rehabilitation and design to return to sport should include depending on individual patient and whatever specific sports they are trying to use. So weight bearing exercises, whether they are really helpful, and they are certainly come out with good clinical evidence that weight bearing exercises are certainly highly recommended, and these patients with starting early weight bearing will have a less knee pain, more stable knees, and they are usually more satisfied. The exercises chosen should be depend on whatever graft things which are used as to maturation, and all these considerations should always be taken. Always use the proximal other thing like while performing lower extremity to facilitate greater hamstring contraction, you should try to use the hip, the gluteal, the hamstring, the proximal, which you consider as a broader picture, not only concentrate only on the knee exercises, because all other these muscles of the foot, the hip, they also aid you in getting the rehabilitation highest. Then it's not particular to our country, but wherever the autografts is used, they always to ask them to go slowly, because we know that the healing with autografts is not as good as the allografts. And also try to give the not only the ROM, the strain, it's a proprioception and neuromuscular control is very important, which they are. So there are so many exercises which will be beyond the scope for my talk, but we all know these are the various things which can do. Additionally, nowadays they have come up with the functional approach. Like the more recently, they rather than a home, it should be a supervised therapy. You can use certainly the other machines, the aquatic therapy. You can go for open close chain, and depending on various criteria, don't only judge that only the muscle strain, cortical strain, hamstring. It is a holistic combined approach. Don't ignore your proximal muscle control, which is also important. And it's like what this previously the knee strategy, only knee exercises better. Nowadays hip strategy is important. You have to control both this simultaneously, get a good functional approach. Now, what is a functional approach is nothing but like the functional rehabilitation, where the process of helping a person to recover from their movement capacity is by using their own movement repertoire. Means like whenever it's possible, it individualize specific particular program in the functional. You need to focus on their functional movement, the principle used to use, and the code for their particular motor adaptation. They could be certainly very important to give them the challenging, especially if these are the sports person athletes, where these are very high demand patient. You need to go for more cognitive autonomous space, the more practice it. And it's not the rehabilitation, it's the rehabilitation, what is there nowadays called the rehability of doing this thing rather than a rehab only. So these another composite workout, all these things we can say. And lastly, would like to have few things where there are associated, like what kind of graft each have used, again changes your rehabilitation. If you use the PTB graft, so we all know that there will be cortical weakness for initially, that pain will be there. If you use the hamstring, so we don't do any resistive exercises for initial 8 to 12 weeks for the hamstring activity. So accordingly, you need to change your plan. If you use a single bundle or double bundle, that also changes your rehabilitation. Like for double bundle, they certainly say that they have a more good rotational and anterior stability if the double bundle is used. But if you feel that patient is particularly making good progress, then either you use a single bundle or double bundle, it doesn't make any difference. If there is associated meniscal injury, if you have done only meniscectomy partial, so the protocol for physiotherapy doesn't changes. But if you have done the meniscus repair, we already know that if that repair is there, it needs to be healed, and the non-weight bearing for initial 4 weeks is highly recommended. For condyle defects, if you have done only a condyle debridement, again you don't need to wait much, only as far as the pain tolerance is there, then you can start with the physiotherapy. If you have done the microfracture drilling and those kind of things, where you can certainly wait for 2 to 8 weeks. If you have done the ACI, where the large cartilage and all these supplements, then you have to go for as far as the procedure is concerned, where you need a longer period of immobilization. Weight bearing is certainly delayed in those cases. If you have done a simultaneous ACL and MCL, we know that these are usually combined injuries. So very important whenever you are either conserved or you are MCL is also involved along with, you have to control those movement for initial 4 to 6 weeks so as to MCL to involve. Multi-ligament ACL along with PCL, we know that we should go for a more conservative PCL ligament rehabilitation program. And finally, whenever we are doing the revision ACLR, we need to account for more things, like you can go for a possible, because we are more concerned about the fixation concerns and complications which could happen because of this previous procedure. So in all, you need a good, all these optimal biomechanics throughout kinematic change to a good success. So it should have integrated into technique, reproducible, and which should be learned by the patient. So the main take-home message is like to get a good proximal as an overall picture, the hip strategy as well, functional rehabilitation, differentiate between demand and rehab, think movement not only as a muscle, and it's a complete teamwork from your point of view to the physiotherapist. So all these things is needed for the good proper ACL rehabilitation. So thank you very much for your kind attention. Thank you.
Thank you very much, sir. Lastly, I would like to call the final boss on stage to speak about the management of gait analysis in soft tissue injuries. Please welcome Dr. Aashay Kekatpure.
Very good friend of mine gave me an advice that the organizer should never give a talk. So, but I'm just not following his advice. So, I hope each and every one of you has at least assimilated some part of the fantastic lectures and the techniques which were displayed earlier. So, as rightly pointed out by Manoj Bhokar sir, all our surgery will not materialize or not matter unless and until we have got a very good backup rehabilitation plan. My talk is going to raise some eyebrows as well as going to make you think a few extra pointers. There are some pointers which I have accumulated through last 11, 12 years of my practice. And now slowly we have started understanding that a anterior cruciate ligament tear is just not an anterior cruciate ligament, just not a ligament tear inside the knee. There is a definitive neural connection. There is a neural disconnect which happens of that particular extremity, and therefore there is atrophy of the proximal thigh as well as the calf. More and more research area is getting focused on getting the thigh girth and the calf girth and return to sport early after ACL reconstruction. Why? Because we need to remind ourselves again and again is that we are replacing a different tissue to a different position, even if it is autograft. The mechanical properties are different. The basic microstructure is different. Okay. With that preface, I'll start it. So this is an inquiry of a real-time gait analysis. This was our research idea and no disclosures. So we are seeking some understanding in this when we are doing it. So this was my talk which I presented in South Korea. Why it's not playing? None of the GIF is playing. It's basically a GIF. Okay. There are multiple ways. It's okay. It's okay. So these are basically GIFs. There are multiple ways to approach reconstruction. These are the types of fixation which we have repetitively, my previous speakers have said. The knee ligament tears are associated with high thigh muscle atrophy and gait disturbances. What kind of gait disturbances? Most of the times the patient is sometimes unaware if it is an isolated ACL tear. ACL reconstruction along with meniscus surgery is one of the most common orthopedic procedures that we see day in day out. Surgical outcome is dependent on both reconstruction as well as rehabilitation. So what is the role? Gait analysis plays a crucial role in assessing and monitoring the recovery and progress of ACL tear patients. So we did an objective assessment, we gave them a quantitative feedback, and we individualized the treatment plan. And we monitored them for a long time. So how did we monitor them? The objective measurement was, we measure and analyze various parameters of gait, the step length, the stride, the cadence, and the joint angles. And identifying the abnormal movements. ACL tear often leads to alteration in movement patterns and compensatory strategies and movement imbalances. The imbalance and the movement disorder, as if you have some more finer discussion, the way yesterday evening when we were discussing Ayan Sarthak, the disturbances are so subtle that even the patient doesn't know him himself. And even after they have that slight shift in gait, which unless and until they are made aware of, they will keep on. We need to wean them right back into their normal gait. So basically, after a isolated ACL tear, there is a gait and neuromuscular asymmetry which happens, which needs to be shifted back. It helps, basically why we need to assess the gait, it helps in us to determine the effectiveness of rehabilitation. After you have reconstructed, after you have done a wonderful anterior cruciate ligament reconstruction job, unless and until you know what was the defect in the gait before you went ahead with the surgery and how the patient is getting rehabilitated better, most of the times they will not complain, because India, we don't go into active NFL, we are not running around, we are not doing rugby and sports. But some people who are clever, now that we are getting more and more educated class, we will get these patients who will complain, nahi, there is some difference, there is some difference. So it helps us determine the effectiveness of a rehabilitation protocol, how effective they are, and make the necessary adjustment real time, because these patients, they will be coming back to you on a regular follow-up to optimize the recovery outcomes. So here was our problem statement. There is a lack of qualitative and quantitative biofeedback. Biofeedback means the patient doesn't know how they're walking. Is there any real defect or is there any real problem in the gait after a chronic or a ACL, only isolated ACL tear of gait in recovery and post-ligament reconstruction. So what we planned to do was to use real-time biofeedback gait analysis system in post-ligament reconstruction. So the aim of the study was to use real-time biofeedback system to assist with rehabilitation of patients following knee ligament reconstruction, and to assess its use in post-knee ligament reconstruction. So this was the method. So this was where I was working in my previous institute. We had this GATE lab, which was used for neuromuscular patients where Parkinsonism and all those. So I asked them to shift it for our ACL rehab patients. And these are the sensors, these are the bio-wall sensors. Now we have moved far ahead from these sensors. Now the sensors, we don't need sensors now. And this is the pressure plate. So what we do is that these joint sensors, of course, for for the display purposes, usually the patient is made to undress and the sensors are attached directly to the joints. Video. I think the video file is not here. So the patient, video file is not here. So the patient is made to walk at least 3 times across the ramp, and the entire gait pattern is recorded using 2 or 3 cameras. 2 cameras on the entire ramp. And then we get output. Okay? In the output, we get, as I mentioned, all the parameters. When he puts his feet on the pressure plate, we can calculate how much amount of weight he is bearing, whether the weight distribution is equal on both lower limbs. Is there any excessive external rotation for which the anterior lateral ligament reconstruction comes into play? And how much is the stride length? What is the pattern? Is there any limp? All those things get recorded. What is his postural sway? Is his trunk swaying to one side? So for this particular study, we only consider the weight bearing time on the legs during the gait cycle and the mean weight distribution when both feet were placed on the pressure plate. And the data was obtained before surgery and at 3, 6 and 12 months after surgery. And the data was then reviewed and tested using SSPS. So this is for demonstrative purposes. And this gives, that's how we get our quantitative feedback. So these are the results. The mean distribution of the affected side was less as compared to the normal side in almost 75 to 100% of the patients. If you have got a chronic isolated ACL tear patient, he has gait disturbance. Okay? And moreover, most of the senior faculty will agree that they have motor atrophy of the quadriceps and the calf. We keep on claiming that this is disuse atrophy, but why there is disuse? We really need to answer this question. And there is a fantastic study now getting published by Bernard Sonnery-Cotet, where he has received his PhD in France. He is talking about arthrogenic muscle inhibition post-ACL tear. So, to further this study, there was a reduction in the mean weight bearing time and the mean weight bearing distribution on the affected side, which was statistically significant in all preoperative patients. After 3 months, 60% of the patient with biofeedback in the times when we made them aware that you are putting less weight, we put a mirror, and we had them with a regular rehabilitation protocol. The normal, as compared to the normal group 2. After 6 months, group 1 showed normal weight distribution pattern and 70% of the patient in group 2 showed normal weight distribution pattern. But the difference between both them, the patients who received biofeedback and those who did not receive biofeedback, it nullified after 12 months. The point which I am trying to take it home is that patients who received gait analysis based biofeedback recover faster. The patient with ACL tear were putting less weight on the affected limb as compared to the opposite side. Biofeedback group showed faster rehabilitation in 3 months. Limitations are, we have got a small sample size. Of course, in India, our patient compliance is an issue. So certain another question which remain is why there is a difference in weight distribution and thigh girth. So this is the literature. It's an online summary of his entire research. He has put it. It is in French. The subtitles are available. I request you all to see this particular topic. It's very, very inquisitive. There is huge talk which is going on right now. Now people are coming with literature that orthogenic muscle inhibition takes almost 3 years to recover completely. Okay? And now people are doing functional MRI post isolated ACL and trying to understand the amount of distribution, the weight distribution in brain, and neuronal replasticity or neuronal plasticity. So this is the future research direction which I was stating: arthrogenic muscle inhibition after anterior cruciate ligament, injured and uninjured limb, and functional MRI. It almost takes 3 years. So what are the alternative for these expensive prime track and these things? So this is Kinect. Again, the same word jugaad, but what we have understood is that instead of the high cost of the Kinect costs almost $200, and it has got the same accuracy as a Icon. So we are working towards it. Thank you. Thanks a lot. So any questions? I thought the senior faculty would have a lot of questions after this. No? Huh? Dinner getaway, yes. So we did not have any question and answer session before. So the house is open. Consider it as an open forum. We'll have the question and answer session now. It's okay.
So if any of the delegates or the faculty members have any questions regarding the session on meniscus or the previous session on ACL or for any session of the day for that matter, please feel free to ask questions.
An isolated ACL or an ACL with meniscus repair. So since I do the all inside ACL technique, so my protocol goes like this: post 24 hours, once the effect of spinal anesthesia has gone down, I start my patient on toe touch weight bearing and followed by 30 degree of knee flexion. Try to achieve around 30 to 50 degree of knee flexion in 1 week, and continue with the toe touch weight bearing with the walker. Then after in 2 weeks of time, once the stitch removal are there, I try to make more better, so that in within 3 weeks of time I try to get around 90 degree of knee flexion, and then after 3 weeks I let them go without braces and walker. So then they put on the braces only while during sleep till 2 months post ACL reconstruction, and then after around around 6 weeks I start them with single leg stance, and mostly at the end of 2 months I start them with side running, predominantly the side running, and then the other group chain of exercises which we do, starting from mild sloping, taking back support and go flexion, but mostly so within 2 months we are good with the patient with complete, so that he can start driving a 4-wheeler in say 2.5 months to 3 months, to 2-wheeler in 4 months of time. I think the basic protocol with Dr. Samir sir will also agree is 6 to 8 months to go to. 6 months is a good time of period of time he can go to play his normal club, but to go to a competitive level we all take 8 months better, and that also depends upon what type of fixation do you go, like whether you're doing a PTV fixation or a hamstring fixation per time, and the protocol changes which each demand of patient, like for a cricketer it changes, for a football player it changes, because see for a hockey it's like for a hockey or an ice, like you need to have the rotational, so we give lot of thing on the medicine ball or those, the wobble board exercise, we need to do them, those things differs and depend upon the patient demand.
It in his lecture in the knee examination. How many of all of you measure the thigh girth before operating the patient? Thigh and calf girth before the patient undergoes surgery. And do you always observe any difference in the thigh girth if it is a 1 month 3 months, 6 months old injury patient. So no measurement. So I would suggest that henceforward, I mean, as part, try always, you will always observe a atrophy or decreased thigh girth of the thigh and calf girth of the affected side. Okay, and please. No, I'm asking before surgery. Before surgery. Yeah, measure the gradual one. First instance, if the patient has come for the first time. Yeah. Exactly. Physiotherapy or something. Yes. So. Yes, please. Vikram sir, you want to like?
The traditional teaching is 6 weeks, but there is a literature where you can still operate early. But for me, like at least 2 to 3 weeks I will wait post ACL injury. You'll have stiffness if you operate early, but not necessarily on the patient. Few patients you will have. So if you are speaking about all the patients, wait for 2 to 3 weeks definitely.
I think there is one thing which I have to act like ACL with meniscal injury. If these two things are combined simultaneously, then you are means again there is a controversy like sometimes they say कि meniscus there needs a priority, and with ACL you need to operate immediately the both things simultaneously. It's an associated one.
When you need to operate after injury, it is also the mode of trauma you need to note, whether it is a high injury trauma associated with a bony contusion on the MRI, because you have to see the MRI also before deciding for the surgery. If you see a lot of contusion in the posterolateral aspect and a lot of contusion, then better to wait for 6 weeks or maybe more if you want. But the condition of the joint and the condition of the joint in the MRI and on clinical examination is important. And of course, if co-injuries like meniscus injuries are there.
No, meniscus you have to operate it.
See, first and foremost depends upon the presentation of the patient. When the patient is presenting to you, many times
his question is specific. Third day, patient has come to you with an MRI, has an ACL tip. When did you operate?
No, first of all, then my question will be, what is the knee range of movement for that patient? Sorry? 90 degree. Then I will wait till it gets the full complete range of movement, because I need a patient with full hyperflexion and a free knee. In that time, when I wait for 2 weeks, say for nearly 2 to 3 weeks, and after I need an MRI. The MRI, there will be lot of bone contusion. I have done a study in 2013 where the bone contusion, the edema, they takes a lot amount of time, starting from 3 months to around 6 months, and especially the posterior lateral, they takes from 6 to 9 months. So you have to understand the contusion pattern when it goes. So once I get a full range of movement and I get a pain-free knee, the response, so the result is quite far better than a patient you go down with 90 degree range of movement. Post of him will develop stiffness, and also the rehab protocol is going to slow because his mind is not aware with how to when to do other things.
So
I'll just summarize of what we have been discussing, because I think you raised a very interesting Pandora's box, and everyone has a different opinion.
I was going to say that
a different opinion, and it is something everyone is interested in.
See, forget about that.
We are looking at patient satisfaction. Commerce to alag hi baat hai.
Okay.
Yeah.
So as you have rightly said, pointed out by Dr. Tejas.
the valid, once the knee is silent, it could be 1 week, 3 weeks sometimes.
Doctor Saab.
So yeah, that's a very, very interesting and important point. Now this, I mean, this question has led to many questions. So if it's a bone contusion, how much? How much is good enough to operate early? How much is good enough to operate late? When we say so much bone contusion, I mean, that's a very vague term. That's point number one. Point number two, if it is associated meniscal tear, if a meniscal tear, if it is, I mean, it is in the intercondylar notch, definitely he's not going to flex more than 90. Okay. But you have to address it. It is not never going to get, okay. So you need to have your diagnosis ready with you unless and when you go and operate, or rather when you tell the patient what you are exactly going to do. You're getting my point. So a good MRI, 3 Tesla, of course there will be some amount of confusion, but once you have your right diagnosis, okay, so it's a isolated ACL tear. Now, why do you think these patients with an isolated tear should have only a 90-degree range of movement? What is the reason? Yeah, I mean, any idea what is the anatomical structure involved? If it is an isolated ACL tear, why should I? And some amount of bone contusion and still range of movement is less. Why so? Hemorrhosis, of course. Quadriceps inhibition, one thing, is a posterior capsular contracture. Okay. Now, there is some amount of posterior capsular contracture which limits movement. Okay. And that takes time. That takes rehab. And that's why we need to delay. Yes. Of course, of course.
Again, I think it should not quantify. It's like once the knee becomes silent, what should be the contraindication where you should not operate early? That should be the question. If it is swollen, the range of movement is less, you should not operate, you should wait. So I think silent knee, once you feel clinically, functionally, if that is happening, he is giving a good painless, more than some 90 degree of movement, swelling is less. And irrespective of time, whether he comes within a week or 3 weeks, I think that is another solution. And the bone edema which you are saying, on MRI, it is certainly seen that at least 6 months, that bone edema could be seen in the further follow-up MRI. So the edema in the bone and the soft tissue may be a different entity. You want to go faster mobilization with all inside, or with this, you want to aggravate the mobilization? It's a bone conserving procedure, and the stability is certainly much better than the, I think, the conventional one.
Yeah, so I so all inside, when I do an all inside, I agree, I actually be a little aggressive, but still for bio screws, irrespective of how the fixation was, I'd keep them non-weight bearing till 15 days. And there is a lot of literature backup. I don't know the author's name, but that's what I do. So 15 days, I keep them non-weight bearing if I'm using a bio screw. If it is all inside, then I go all out.
I think one.
So it's like nowadays it's a hamstrings which we are mostly using. So it's a standard protocol. Only hamstring, the resistive exercises for hamstring you need to avoid for initial 8 to 12 weeks. Right. I think the weight bearing is now very clear that we can start weight bearing early. What nowadays I use the dial brace. So it serves both purposes. Like you could keep it in the extension, make them walk the same day or the second day. So with extension walking without bending pressures on the knee, at more degrees of flexions are avoided and they are more comfortable with it. And with dial brace, you can certainly gradually monitor that range of movement. So rather than a knee brace, the dial brace where both these things can be solved is another way to help in your faster ambulation.
So one thing, sorry to interrupt. I would like to add that the differentiating factor between a PTB based ACL reconstruction and hamstring based reconstruction is the graft site morbidity. I mean, the reason once you harvest the PTB graft, the anterior knee pain is a more troubling factor for them to get a faster rehab. That I think they complain of that more. That's why the rehab in them should be delayed or slowed. That there is no other reason that why they should not weight bear in a complete extension. Yes, sir. I think I interrupted you.
Same thing I was telling. The BTB only the quadriceps, the anterior pain will be more. Otherwise, the rehabilitation almost remains same.
More aggressive rehab.
Aggressive from the.
I had a very strange and a very interesting encounter with Nick Verma. If you know Nick Verma, he is the chief sports surgeon for the NFL, National Football League in US. Okay, I asked him, swear to your heart, how much amount of ACL reconstruction you do with ACL on with BTB? 70% of American orthopedic surgeons who operate elite athlete who wants to have a very less time on the couch, they all go for BTB. 70%. They have to join sports. Their contracts are at stake. 70% of them and they can push them on faster, aggressive rehab. Okay, it's a very big finding. Okay, less of them go for hamstrings. Now they're pushing in for all inside ACLs and all those things. But there was a very big debate regarding all inside ACL in UPCAS meeting in Chengdu, China. Kabaddi. Okay. Yeah, I think PTB is a fantastic graph. Just you can manage to exactly. Hamstrings. Yeah.
We are not talking of CQT. CQT is another fantastic graph.
So that was purposefully avoided because of the. I mean, yeah.
But in fact, CQT, they should be learning it because it is easier than BTB, it is less morbid. And
CQT, yeah.
And CQT, plain CQT without a bone plug would be an ideal choice with all inside, giving you the stiffness as well as the stability.
We will discuss this. I mean, CQT, regarding CQT discussion, we will have more on the cadaveric table. It was avoided in the initial, on the basic course. Why? Because if someone goes ahead, becomes daredevil and takes CQT and ruptures the capsule, then becomes slightly unsalvageable situation. So start with the basics, and CQT we can have for discussion's sake, and then if you are proficient enough, then we can go ahead with CQT.
So one point to add for the graft reparation is the peroneus is another very important good
I was
simple.
that. My talk was there.
That was like these people should always get
Yes,
there.
yes. I can show that. माझा talk लावणे.
A very easy procedure to do. The beginner can start with that, and it almost gives good result. Like obese patient female, so that is ideal.
Sir, great.
And multi-ligament, the ACL with MCL injuries, so avoid hamstrings.
Sir, grade 1 ACL avulsion injury, adolescent patient and an athlete, operator conservation. Grade 1 ACL avulsion, athlete but adolescent. 16-15, operative versus conservative.
Okay, this is a very, I think this is again, do X-ray in full extension, lateral view, true lateral, full extension. If the fragment reduces, cast it.
For adolescent also.
Yes.
So I have something to say. Looking at the way the discussion has gone so far, I can see a difference in between, like, the questions asked by the delegates refer to, like, they are hoping or seeking to get a standard solution for their problems, whereas the faculty who are more experienced and have dealt with these kind of cases for a long period of time, they have a lot of options to offer, and they, because of their experience, they can select and choose their management plan on a per case basis, which is a privilege which is not afforded by someone who is starting off new in their journey on knee arthroscopy. So my question or suggestion would be that now that we have all eminent and respected members of the arthroscopy community in one room, can we as a community come up with certain standard guidelines on common conditions or common injuries associated with the knee, which can be used as a yardstick by someone who is starting off relatively fresh on his journey in knee arthroscopy, and then eventually as they gain experience, they can develop their own protocols.
But distal radius today also you have 5 options. Nah? So ACL will always have 5 options. Orthopedic stages is all about difference of opinion. That is what makes orthopedics so beautiful. So why to give up on that? There cannot be any consensus.
So the idea behind asking that question was for someone at the very basic level, for suppose someone who is still in his residency or his early SR-ship in a institute, where he is still relatively new and not used to dealing with these kind of injuries on a regular basis. It becomes a bit confusing for the resident and worrisome for the patient to wait for the resident to take a senior consultation, rather than if he has some guidelines with him, he can actually counsel the patient on those guidelines, and then the finer management can then be discussed and decided later on. Yeah.
isolated ramp.
Vascular, they are bound to heal. But in association of by definition, it is in association with ACL because its relevance is only in absence of ACL because it increases anterior translation. Isolated, it's bound to heal. So we don't bother much and not seen much.
Let me rephrase it. With ACL, you have seen the ramp lesion. So where are the indications we will not do anything for ramp? Means like it with ACL, all ramps to be operated, or there are certain few operated.
So what is your weight bearing protocol after meniscus repairs?
6 weeks non-weight bearing.
For all the
For all
configurations?
meniscus repairs. Non-weight bearing repair, meniscus repairs. Yes.
Even for horizontal previous
Yeah, only for like horizontal you can have early weight bearing, but for bucket handle tears or most of the repairs I give 6 weeks of non-weight bearing. You have a different.
Like 4 weeks to 6 weeks. I think if you feel that horizontal and the 4 weeks is a standard, but sometimes it is always better to delay in meniscus the healing. It certainly takes. Aashay would be the best person to compile all these things. Maybe, yeah, he has got a lot of following. Even the rehabilitation, bro.
Mucoid, I have a fair bit of experience, and I initially, in initial days, I used to do a bony notch plasty and debulk it. But now I have realized that our patients don't warrant second surgery. I burned my fingers once. That patient landed up with a tear of that debulked, and I had to do an ACL reconstruction. So, of course, what I do is I go in, I thoroughly debride it. This is one indication for using the radio frequency ablator. So I will go and even on the footprint area, I will do a radio frequency ablation of the whole mucoid tissue. So it is like considered like a debridement surgery. So debride the whole thing and reconstruct. In my hands, it has worked reasonably well.
So I had one input for this mucoid degeneration part. I've seen a couple of senior surgeons in Bombay treat this in a way in patients that have mucoid, they generally complain of terminal flexion pain and rest pain. So what they do is they put the leg in the figure of 4 and just the PL fibers, they take bites of the PL fibers till they can see the posterior horn of the lateral meniscus. Yeah. That is where they stop the debulking.
That's the location where most of the mucoid degeneration occurs and the cystic change occurs. So that's the way, means in the figure of 4 position, you debride that part. That's true. But initially, if I think I will first rehab, then you might try with some steroid injection. If doesn't work, then I do a debridement. Not all patients I do ACL reconstruction. So I debride thoroughly, and few patients do improve.
Can I say?
Yeah.
Post reconstruction, sometimes they develop a cyst mostly around the tibial side. So, what my approach, like I see the MRI thoroughly. I try to understand what is the intensity of how much is the ACL is involved. Sometimes mucoid ACL will be just like foci loci. Sometimes they're just involved around 25%. Sometimes they're completely diffusely involved. So you should be always trying to first and foremost is to debulk it. So intra what you do, you put your spinal needle, try to tear it, put your shaver, do a proper suction, open your shaver, and then go and do the RF as we told. And as you said, like you have to go to the notch with a complete dissection. Also, you try to go the intersurface between the ACL and the PCL, go behind that, clean its surface. Sometimes you can find a lot of mucous tissue. After that, you can go for a and you do a debridement, try to with the RF and try to save as much of ACL on table. I do an Lackman and pivot shift again. I see it's fine. There is no instability. I leave it. If it is a solid like 25% or 30% involvement, a diffuse involvement, completely shredded ACL, if I can't save it, I go for a complete removal. And luckily till date, what all I have done with my years of experience, no one has come back. Yes, they have come after 1 year with some bit of pain, but most commonly when a patient comes with you pain during the post ACL and all, mostly it will be some uric acid involvement, or there will be some ESRCRP which will get easily cured with some medications. So try to preserve, try to see the MRI thoroughly, how much of involvement is there. And what you asked regarding the post ACL reconstruction, mucoid degeneration you won't see, but yes, they develop post septal something like a cystic, mostly at the tibial stump side. So it will be like intratunnel, never on the like graft, but it will most on the tunnels. What we have seen sometimes a ganglionic cystic involvement or a mucoid fragment involvement.
So, okay, for the sake of time, I think we are getting, a lot of involved in this. What I would suggest is that we can have a small tea break and this Sorbonne workshop, okay? And then we can continue this discussion there. Thank you. You have been an excellent audience, and thanks a lot, everyone.
Just before we break for tea, can I please invite Dr. Vikram Sapre on stage to felicitate and give a token of appreciation to Dr. Manoj Pahukar.
Everybody to come for a group photo.
एक second pause. So till the time everyone till the time we are preparing for the group photo, I'll just say a last few words before everyone disperses for the tea break followed by the sorbonne workshop. I would like to thank you all for being patient and attentive all day, and I hope that each one of us will go back home today having learned something new. I thank all members of the organizing committee, our lovely student volunteers who have worked tirelessly over the last 2 days to help us make this event a success. Can we have a huge round of applause for our student volunteers, please? I also thank the electrical department, the audiovisual department, the housekeeping staff, the Sodexo staff for providing us with very nice food, and the entire DMMC staff for helping us organize and run this event smoothly and efficiently. Just a last announcement, dinner will be served at 6:45 p.m. at the same place where we had lunch. And I thank you all once again for being so patient and attentive all throughout the day. Thank you so much. Yes, can everyone please join for a group photo, please, including the delegates and faculty who are having tea outside, please.